about 1,000 respiratory therapists in that role and have been a respiratory therapist for 23 years.
Okay, all right. So what we are doing, we're gonna say something about the gadgets or the devices, and then it will be more as an interactive. Okay, so we'll be inviting some of you to come over and do something. Okay, in particular, let's have some fun for almost an hour. Okay, so our time here is from 8 o'clock until 8:50 or 8:55. Then you will be moving to the other station or to the next station. Okay. All right. So as you have, you have heard me talk about my lecture yesterday. Okay. So it's about oxygen therapy. Okay. So remember, as a respiratory therapist, one of the skills that we should be knowledgeable and skillful with, or an expert with, is oxygen therapy. Okay, so I knew na it's something that we do every day, but then the theory, but then you should be able to discuss with whoever, the patient's family, the reasons behind why we are doing it, the hazards and contraindications, so that they should be aware. Okay, and then of course, the most important thing is the safety. How are we going to deliver oxygen safely to our patients or to our clients? Okay, so for my part, I will be discussing about oxygen or the supply options. Okay, so and I knew I just want to see who are the currently clinical staff or who's working as a respiratory therapist. Okay. And then, yeah. And for students, do we have students here? You are the majority of your students. Okay, so welcome. Hope that you will learn something from our work, our skill station today. So hopefully, okay. So one of the things is, of course, we need to have a supply system. Okay. So that we'll be able to, where do we get our supply or our oxygen? Okay, so the most common that we have is the very familiar oxygen cylinder, right? Yeah. So unfortunately, we don't have the big one. Okay, so we only have a small A cylinder. Okay, so before we call it through the letters. Okay, E cylinders, H cylinder, G cylinders. Okay, so now they have a different nomenclature as discussed yesterday. So they're going by the numbers now, depending on how much cubic feet is in that tank. Okay, so for E cylinder, do you remember my lecture yesterday? How do you call it? M24, because this is an E cylinder, meaning there are 24 cubic feet of compressed gas inside. Okay, so that's a difference now. Okay, we used to call it E cylinder, now it's M24. And how about the tall one, the H and the G cylinder? What do you call it, sir? M250, excellent. Okay, so meaning there are 250 cubic feet of compressed gas in that oxygen. Okay, so so that's one of the most common supplies. Though in the hospital, if you're working in the hospital, where do we get the oxygen? Where do we get the supply from? Sorry, the wall. The wall outlet, yeah. So the most common, okay, if you are in a progressive country or a progressive place, then we have the wall outlet, okay. So where's the oxygen coming from? So remember, if you happen to see in the hospital, there's this white huge tank, okay. So that is the bulk oxygen supply, and then contains liquid oxygen. Okay, so how does they turn it into a gas for inhalation to your patients? Yeah.
The tank itself, the liquid, the the oxygen starts to evaporate.
Yeah.
Okay, when it's evaporate,
Okay.
that fluid gas situation.
Yeah.
And transfer through the
Yeah.
tunnel.
That's correct.
Okay. After
Yeah. So through engineering system, okay, they're able to to pass it through the different gas outlets until it reaches the wall of the up to, the wall outlet. Okay, so yan. And then all we have to do, okay, is insert a flow meter. Okay, so and this is the yeah. Okay, so typically, what is this? What do you call this? This is a torque flow meter. Okay, so when there's a wall outlet, all we have to do is, okay, so they are universally fitted, so it is uniform everywhere you go. Okay, so you have to do, and then just connect an nipple or an oxygen adapter or a humidifier if it is needed. Okay, yeah, so that is the option, the oxygen supply options. We have the wall outlet, which is very common in the hospital or inside the hospital, and we have the oxygen cylinders. Okay, so we have the portable e-cylinder, which we usually do for transporting, and then we have the huge one if we want a stationary one. Okay, but then you need to have safety features. Okay, so one of that. Okay, so what safety feature usually we use in using our oxygen supply? What do we have to put? Yes, sir.
the safety system,
Yeah. And then what do you put so that to warn people that there's oxygen in use? No smoking sign. So remember, oxygen does not burn, but supports combustion. Okay, and then that is the most important. Okay, and also when you are transporting our cylinders, you need to have the right tool. Okay, so for this one, yeah, this is the right one, and then for huge one, then we have a trolley. Okay, always remember that. You just don't bring it by yourself because you can hurt. Okay, apparently, a lot of big toes were hit because of, they got accidentally kicked or accidentally, yeah. Okay, so that's for the supply option. Okay, and then for the dispensing, remember the pressure in the gas inside is very high. Okay, so we have to bring it down to a working pressure. Okay, so sir, can I ask you which one here that you can use, or can you please come here and identify? Yeah. I'm sure you're familiar with that. Okay. So these are the dispensing device so that we can use the oxygen. So remember, the pressure is quite high, so we have to use a regulator. Okay. So, and there are two types of regulator.
Your question regarding the cylinder or
first the regulators. What are the two types of regulators?
regulator?
Yeah.
This kind for the cylinder.
So,
This for the cylinder. This for the wall.
Okay.
And
So
there's
what do you
two
call this?
types.
Yeah. What do you call this type?
Wall mounted.
Okay. So what do you call this?
A flow meter.
Yeah. What kind of flow meter? Torque flow meter. Okay. And then this one here, it's a Borden gauge, right? Yeah, it's a Borden gauge. Okay. Yeah. All right. So, sir, ma'am, which one do you prefer to use when you are using the e-cylinder? Is it the torque or the Borden gauge?
Boarding gauge.
Borden gauge. And may I ask why?
In the piping system, it's already reduced to a working pressure.
Yeah, I know.
But
In the e-cylinder,
it
yeah.
has a reducing valve that will reduce the pressure on the cylinder.
Okay, yeah,
working.
yeah, of course. What is the advantage of using the Borden gauge instead of the torque flow meter?
It didn't affect by the gravity. It didn't affect by the gravity.
Yeah. Okay. Yeah. Exactly. Very good. Yeah. So yeah. So what is this? A torque flow meter. Okay. The disadvantage is when you put it down, just like when you're transporting a patient and you don't have any other option, you don't know how many liters you are providing your patients. Where in fact, if you're using this one, okay, and it will never change. Okay, so whatever you set, it will be the same. Okay, so that's the advantage. Okay, yeah. And are you familiar or are you using this gadget in your hospital or in the schools where you are studying? Are you okay? What do you call this one? Okay. Okay. So what's the purpose of analyzer? Yeah. If you want to confirm, yeah, how much FiO2 is on the pipeline, then you can use this one. Okay. So it's like put online. So especially when you're using a ventilator. Okay, so sometimes the air oxygen blender is not working well, so you're not, then the digits are gone, so you want to know. So you can just put this in line and then check, okay, because this is battery operated. Okay, so you want to know. Okay, it's going to tell you how much FiO2. If it's 30%, you set on 30, just to confirm. This set the one on the blender. Okay, so yeah, and of course. Okay. So, and what is the most, or here, okay? What do you call this one? Air oxygen blender. Okay, so as it says here, and there are two compressed gas sources. Okay, so we're mixing air and oxygen. Okay, so and then there are two types of air oxygen blender. We have the low flow, the one that we're using for neonatal patients, and then we have the high flow. Okay, so you can see here. Okay, high flow air oxygen for the high flow. Okay, and so of course, yeah, using a flow meter, and then we have the ball is going to tell us how much liters you're giving to your patient. Okay, all right. Okay, so is there anything else, or do you have any question?
I think I have a question. Regards you mentioned that there are two types of the oxygen blender. I think the difference is the flow meter, not it's the built-in the blender itself. That's right or wrong?
What is that?
I think the only difference between neonatal and adult
Is in the flow, yeah.
The flow meter,
Yeah.
not the blender itself, because the principle is one.
Yeah, it's just the
Yeah,
flow.
Yeah, that's one.
It's different as well.
No, it's the system itself, right? Yeah, because they are calibrated differently.
Different calibrated.
Yeah,
To which
one is for low flow, and then one's for high flow to give you a lower concentration. Okay. All right. So yeah. So in totality, what I've discussed with you is the oxygen supply options. So the most common one is the cylinder, or in the hospital settings, we have the wall outlets. Okay. Okay. So and then the two cylinders, we have the huge one, the 8-cylinder, and then we have this small portable one, which is the E-cylinder, which we call now M24, and then the huge one is the M250. Okay, and then for dispensing devices, we have our regulators. Okay, so we can bring the pressure down to a working level, which is 50 psi. Okay, so we can either use the torque flow meter and or the one that has a Borden gauge. Okay, I think that one, yeah. All right, and then to confirm the FiO2 of your delivered gases, we can always use the oxygen analyzer. Okay, so it's battery operated, If you are in doubt, if the machine or if your ventilator or is giving a precise FiO2, we can always recheck or reconfirm using the oxygen analyzer. Okay, and of course, yeah. So we have the oxygen or air oxygen blender. Okay, so the one that we are using for neonatal patients that can regulate the FiO2 from 21 to 100%. So they're using two compressed gas sources, one for air and one for oxygen. Okay, and then we have the high flow for a high flow air oxygen blender as well. Okay, all right. So now it's Dr. Raid's turn to discuss with you the oxygen delivery devices.
Percent. Almost all of you know about the oxygen devices that we are using in the hospitals. Do we have none RT here? None RT. All of you are RT, mashallah. So you could. She is. Okay, so you are our friend, enemy friend. Okay. Oh, all right. So physician intensivist or? MashaAllah. So, okay. Let's start. Before we start, I would like to ask you a question. What's the percentage of oxygen that we are breathing now? Wrong. No.
70 nitrogen.
No, oxygen. I'm asking about the oxygen is. Okay, 21 is right. Sorry. But 20.9 is my, I'm an educator, I'm academic, so, you know, people, 20.9. So this is 20.9, that the percentage that you are breathing. But the patient, our patient, they need more than 20.9. Sometimes they need the 20.9 or 21. Let's make it easy, 21. But we have some conditions that prevent the 21 go to their blood. So that's why we need the oxygen devices. That's why we need the oxygen supplies here. So today, inshallah, we'll go through some of the oxygen devices. So the other question is, what's the major classification of the oxygen devices that we have? What does that mean, high flow and low flow? When I was in the school, I was confusing what's the meaning of high flow, because I thought high flow, that's mean I have to use the flow meter and use the high flow. I thought this is the definition. This is the definition, that using this device using high flow and the other device is using the low flow? Student, intense. You make it more confused for me. Please explain, huh?
The performance of the device itself, if it's fixed performance or not fixed performance.
Allah, more complicated. Yeah, Sheikh, come on.
High delivery, or oxygen or mixed.
Okay.
Fixed FiO2 you can give.
Still, I didn't find the right answer. I don't know. Students, interns, شو الفرق بين الهاي flow? We have high flow devices and low.
So you're not talking about fixed, you mean high flow.
Yeah, what does that mean, fixed?
No,
Yeah.
we know the percentage that we delivered for the patient.
Are you satisfied with the answer? Their answers? This is the book definition, but
They're not saying the wrong thing.
okay. This is the definition in the book, but patient demand. What does that mean, patient demand? Somebody said demand before. What does that mean? Okay, that's mean. Tell me how many liter we are breathing per minute, the normal people. أعطوني كم liter تقريبا? Maybe 25, 40, 60, maybe sometimes. That means this device will not give you the all flow that you need. Will give you partially. This is the low devices. So that's mean the oxygen device, if you call it low flow, that's mean it give you partially, and you patient, you have to breathe by your own to take from out atmosphere. This will not provide you the whole flow that you need. This is the meaning, the best meaning. I mean, just to make it easy, I'm sure the majority of you know this meaning, but My concern, the intern and the student at the same time. طيب. So we have high flow, low flow oxygen devices. So let's start from the low flow devices. So what's the best device with them? Comes to our mind, nasal cannula, which is this one, nasal cannula. The nasal cannula. Anyone want to see it? Actually, we have a large number, but you can come here if you want to see my devices. You can play with it. If you need it, just you want to see it, just I will bring it to you. So the oxygen, the nasal cannula, when we should give it to our patients, the nasal cannula. What kind of, yeah. The first question, what's the percentage? Give the minimum and the maximum percentage. Huh? The minimum is? The book says 24? No, the book says, right says 21. Because you can turn it to 0. Shut down, so to give the atmosphere 21. So it's from 24 to, what's the maximum? 40. Maybe we have, just I'll give you a formula that we can calculate this one. Okay, so what's the flow?
Maybe 3.
From 1? What's the maximum flow? 5, 6. It depends on your reference. The box says 8. Okay. Hospitals, what says? Our reference here, it says from 1 to 8, but what about your hospital? Up to 6? 5, 6? Why 5, 6, 8? Why? Why we are saying that? Huh? It's uncomfortable, number one, plus the other box, the other science is saying if you go to 10, 12 will make no difference. So stop there at 5, 6, 8. So you will do nothing. So we need to stop 8. That means we need if we reach 8 and the patient is not receiving the oxygen that we are, the pulse oximeter, the doctor told about you, the percentage that we need, either it's adult, pediatric, or neonatal, so we need to upgrade to another device. So when we use this nasal cannula, what kind of patients? We have to have some requirement. The first thing, I believe, the patient, they should breathing by their own, conscious, maybe they are non-mouth breather, that they breathing by their nose, plus what? There is no blockage, nothing that prevent the delivery of the oxygen. So we are saying from 1. I used to work in some hospital, we start with the half liter per minute, but the box says from 1 to 8. So give us the percentage. If I increase 1 liter, that means how many percent that I increase? And if I do 4%. So if you do the math, that's mean the doctor, you have the physician orders to put the patient in nasal cannula 32. If I do 32, that's mean how many flow meter? The flow meter, how many liter you put the patient in the flow meter? 3 liter. How did you calculate that? 20 plus 20. The box says not 20, but so 20. But in this device, we starting from 20 is not 21. So you do the math. For 3 liter, you are saying 3 liter times 4. So 20. We have 12. We have 20 before. So this is 32. So we reach the doctor demand. Any question about nasal cannula? Okay. So it's preferred for our patient. If your patient is conscious, they are not mouth breather, so use the nasal cannula because it's easy for them to speak, to eat, to communicate with you. They prefer it, our patients. Okay. So what's the next? Simple face mask. So what's the simple face mask? Give us how many liter we can. Give us the percentage, please. Huh? When we are saying percentage, that means is fixed percentage, depends on other reasons. Okay, it's not depends only the flow meter that we put the patient in, but we have another factors like what?
The patient's effort.
The patient's effort. What does that mean, patient effort?
Respiratory rate.
It's not only the respiratory rate. I can breathe 20.
Hyperventilation can mix the air.
Okay.
Oxygen with air.
It's not only the rate, also the volume they are taking. It's not only the rate, the volume, which is the minute ventilation or the alveolar ventilation. So it depends. Plus the pathophysiology the patient they have. If you have patients breathing normally from 12 to 10 and the volume they are taking normally, but you have some conditions like, for example, pneumothorax, hemothorax, something, and then the like atelectasis or something. So we have another problem that prevent the oxygen go and diffuse in the blood. So this is the problem. So the patient condition, patient effort, plus the oxygen that the flow that the percentage you are providing them. So this all of them affecting the percentage of oxygen, the delivery of the oxygen to their lung, to their blood. Okay, so now we are in simple face mask based in our book referenced for this course. What's the flow meter we are saying? The liter, how many liters?
Minimum 5.
And I give you the barcode. Some of you scanned my barcode. The people they came late. Sorry, you can share it with your friend. You have a table. 5 to 12. So I don't know about the test. Maybe they will ask you the questions about these things. I don't know. I have no idea about the posters. The people they care about the posters. But I believe you have to know or memorize these numbers. So 5 to 12. Why we start from 5?
Because if we decrease it, CO2 remains potential.
Because in this mask, where is it? Simple face mask. There is a dead space. If we put our flow meter less than 5, that's mean we are building CO2. When the patient rebreathe again, some CO2 will be staying, so we are not flashing the oxygen, so we need to start from 5. If you don't start with 5, so that means you are providing CO2 plus oxygen to the patient. So be careful. The list is 5. Some references say 6, but our reference is 5. 5 to? Okay, why 12? That's I see some physicians, sorry, doctor, some physicians, they are saying, put the patient in simple mask, 15 liter minute. Doctor, if you go beyond 12, no benefits, nothing. So 12 is the maximum. That means the patient, if need more than 12, what does that mean? We have to upgrade.
Yes.
We have another devices. Still, we are in the low flow devices. So what's next? It's not non-breather. Non-breather directly, huh? Partial breather mask. This is still in the market, so this is the partial breather mask. What does that mean? If you want to go to the non-breather, then we'll come back to the partially, but this is a non-breather. What is that non-breather? It's non-breather, the partial breather mask. I don't know, some hospitals they don't have it. The first time you see it?
Most of the hospitals.
They don't have
Only
it?
in the books.
Wallah?
Yeah.
Is it real?
Most of the hospitals.
Come on. It's bad news because that means I'm getting old. And then the university, so a long time I didn't go to the hospital. Guys, come on. We see it, it's here. So this is a non-breather. So okay, what difference between breather and non-breather mask? The valve, which valve? This is non-breather, so if you want to come, please come here. We have valve, this is non-breather, this is breather mask, right? Which valve you are talking? It's not the valve, this one, it's not only the valve. The most important valve is here, between the bag and the mask. Also, what's the function of this valve? What does that mean? When you give the oxygen to the patient to go to the reservoir, and there is a valve here. The valve is not to prevent mixing CO2 with the oxygen. And there is another releasing valve here that's mean preventing release when the patient exhale, so the CO2 will go outside. What keeps inside in the system? Pure oxygen, pure 100 oxygen. So this is why we need first partial breather mask, then non-breather mask, and you have the percentage here. And so the first thing, the liter, how many liters? 6 minutes what? Left? Okay. 6 to 10. This is non-breather or partial breather mask? Percentage? Provide. ممتاز. طيب. Breather mask? No, sorry, non-breather mask. Okay, so there is a difference in the flow? For sure. Okay. And the percentage to give us to 200?
100.
Depends. Even your reference, what it says. It says some reference. It says it 100, and it depends to the patient.
High percentage.
The patient. Okay, to the patient effort plus the patient condition. Okay. So this is, we are still in the low flow oxygen devices. So what's the high flow oxygen devices again? Now we are moving to the high flow oxygen devices. What's the famous guy here in the device in the could be high flow nasal cannula is high flow, yes or no? I have no idea. Answer her, please. Yes or no? Yes.
Yes.
It's high flow.
Precise oxygen.
No, we are not talking about the precise. We are saying the patient demand.
Even patient.
Forget the precise. This is not the high. This is not the definition of high flow or low flow. Okay. Is high flow the nasal, high flow nasal cannula is high or low oxygen devices? High flow or low flow?
High.
Don't be shy. Just answer. Okay. Tell us,
High.
High flow.
Yes.
Who's saying high flow? The majority. Okay. Low flow. Okay. Come on, guys. ما في ولا واحد low flow. Doctor, is high flow or low flow? Both. Doctor, is high flow or low flow? You have no idea. High flow? Okay, so we have, it could be high flow or low flow, which is high flow nasal cannula. Don't forget the name. The name is high flow nasal cannula, but doesn't mean that's high flow is in high flow devices. Okay, what else? Which is Venturi mask, the Venturi mask. And the Venturi mask, we have this Venturi mask. This is the company, the Venturi mask. If you want to see it, you want to play with it. I know if you didn't use before, haven't used the Venturi mask, this one. You know how to use this one, huh? Do you see it? Because it depends on the, we have another kind, we have another company, which is this one. The other company, it says this one. And it comes with the color coded. If you want to see it, you want to play with it, it's yours in the table. Please come. Here, you are welcome to come here and play with it. Come on, guys. I'm not good in teaching these things. Thank you. يعطيك العافية. So if you see the nasal, this one, it says, please pass it. You can see it. كلكم عارفينها? Everyone knows? Okay, خلاص. You don't have to explain it. This one, it tell you what's the percentage. And what's the flow that you put your flow meter to deliver this percentage to the patient. So the Venturi mask, this is what we have in the reference here.
Pure, not to be blocked.
What's this?
One is fixed nozzles to enter the oxygen, but the air interment
From outside, that's what we are saying.
the other side, the nozzle is fixed. Sorry, the opposite. The nozzle is changed, but the air interment
Fixed.
fixed.
Okay. So it depends on the manufacturer we are saying it. So now we have the low flow, based on our book, we have the low flow oxygen devices and also the high flow oxygen devices. Any question about the oxygen devices now? Are we okay? Fine. If you want to see it,
For the nasal cannula for neonates.
okay.
I think the FiO2 will be variable, maybe reach 96.
The FI2?
Yeah.
Maybe the doctor can answer no. There is you have to the maximum. You are saying the FI2.
The FiO2.
The FI2. Okay, but you have to keep the saturation until is the level what? The level?
The patient.
No, it's not more than 94.
Yeah.
Why?
But
Is affecting what? You are saying the neonatal, huh? Affecting what?
There is oxygen fixes.
Plus. What is that? Salt must be. Which is? Can I give you the definition? Their eyes is gonna affect their eyes. So there is it's like the COPD patient. We don't wanna give him. It's not like the adult people. That's the good number is 100%. COPD patient 88, 92 based on your reference. The policy in the hospital. The neonatal is 92, 94.
But
So
he's
this.
right, Mr. White.
Yeah.
He's talking about pure oxygen.
The pure
May,
oxygen.
Rise the oxygen level to the patient. So we have to use the oxygen blender.
The oxygen, you are saying this is the oxygen. I thought you are using the CSA. Okay, طيب يعطيك العافية. So finishing our devices, we also now. Do you have a question? We are talking about the long term. The long term, that's the patient needs the oxygen with low flow. We have the oxygen concentrator. This is the machine, the oxygen concentrator. We have also the small cylinders, liquid cylinders that we are using for the long term. For the patient, the chronic patient, they are using oxygen from 19 to 24 hours per day. Still in my time?
Almost.
Almost? Okay. So we have an example, the oxygen concentrator. Some of you maybe haven't seen it before with the patients. Unfortunately, we don't have the small or the liquid for the carry on cylinders for the chronic patients. But maybe you see it in the public with the chronic patients, that especially COPD patients, that they need the low flow. I don't know about this machine. I haven't seen it. What's the maximum flow that you provide? 5.
There is 8.
8. I heard that in the market there is a 12. So the 10. I heard they have 12. Now they reach the 12, the maximum flow oxygen compressor that can provide it. Any question for me? The oxygen devices.
Thank you.
شكرا يعطيكم العافية.
All right, thank you, Dr. Rahim. Okay, so discussing about the different types of oxygen devices, which is low flow and high flow. Okay, and giving you to present the
Because it has a mic, I think. So this is a mic.
All right. Well, that's weird. All right. Yeah, that's weird. Hi, everyone. So I'm going to talk about humidification. I think I mentioned to you I've been a respiratory therapist for a long time, but I've worked in adult critical care, neonatal, and pediatric critical care as well as air transport for many years. And so everything I'm going to talk to you about today, for the most part, is fairly translatable when it comes to humidification across all patient populations. There are some differences, and I'll mention those as they come up. But first, why do we humidify medical gas? Oxygen is dry. Yeah, do we have moisture in our air and gas oxygen lines? No, why not?
Maybe it may cause burn or something.
It may what?
Cause burn.
Well, we don't put moisture in dark places. Things grow, right? So, yeah, fungus, mold, all sorts of stuff, right? So we have to make sure that it's cold and dry for a reason, right? So on our end, we have to heat and humidify it for patients. Oh boy, this is weird. Awesome. Okay, I'm just gonna hold it. Okay, great. What happens if we don't humidify medical gas? Oh, loud, loud, loud. What happens?
Irritation.
Irritation? Why?
Dryness.
Why?
Oxygen is dry gas. Oxygen is a dry gas.
It is?
Because it's high flow and it's reaching the lower airway as the high flow is passing. Also, it will cause the cilia not to move and might cause the retention of the secretion.
Yep, you're exactly right. So you can have reduced cilia motility, retained secretions, but why?
Fiction.
Not infection, right? The humidity deficit.
Injury.
This is the important thing. So humidity deficit, right? The humidity deficit is what causes everything you just described. So ciliary destruction, airway epithelial cell destruction, reduced ciliary motility, retained secretions associated with that, thickened secretions, all of those things that we really hope to avoid, all caused by humidity deficit, right? And so what is the definition of humidity deficit? You guys are kind of getting to it. What is that? If I were to put that into a sentence, how would I say that? Don't all speak at once.
The isothermic point. The isothermic point will be lower in the
You're absolutely correct. A humidity deficit can lower the location of the isothermic saturation boundary. That's true. I think sometimes we overcomplicate this. A humidity deficit simply means that the air I'm inhaling is less than 37 degrees Celsius and less than 100% saturated. That's all it means. So all of us right now are functioning at a humidity deficit, period, but your body is accustomed to it and can overcome it, right? This is not 37 degrees Celsius in here, thank goodness. And it's not 100% relative humidity, thank goodness, right? But your body accommodates that, right? So that's called body BTPS, right? So at BTPS, 37 degrees Celsius, right? And then we talk about the water vapor content at 100% of 37 degrees Celsius. What is the water vapor pressure? 47. It's 46 point something. 47 millimeters of mercury of water vapor pressure, 100% saturated at BTPS. If I were to say that in a volume, what's the volume? Yes, it's 44 milligrams per liter. I mention it both ways because when you mathematically calculate humidity deficit, they always do it based on volume, not water vapor pressure, but we think about it both ways. Right. So room air, 22 degrees Celsius, you're going to get about 10 milligrams per liter. Right, so your body is then responsible for the remaining 34, give or take, right? And so how does that work, right? Your upper airway heats and humidifies. Your trachea and your mainstem bronchi do a little bit as well, but it's mostly the upper airway that does that. The isothermic saturation boundary, which is a word I just like saying because I'm weird, but the isothermic saturation boundary is simply the point at which the gas that you're inhaling reaches 37 degrees Celsius and 100% saturation, so that 44 milligrams per liter or 47 millimeters of mercury. About in a healthy adult patient, so hopefully everyone in this room, where is that approximately in the body? Where does that occur?
5 centimeters above the
Yeah.
below.
Below the carina, 5 centimeters below the carina. This is a very important random fact to remember. You got me? 5 centimeters. Where's the isothermic saturation boundary? 5 centimeters below the carina typically. If you are breathing in drier gas, what happens to the ISB? It goes lower, right? And so then you start exposing more of your conducting airways and deeper into the airway dry gas. This is bad, right? And the harder and harder your body has to work to overcome that humidity deficit, and that's when we can start to see the things that you mentioned, particularly when we bypass the upper airway with an advanced airway, ET tube tracheostomy, right? Or if we're using really high flows, right? Very difficult to overcome 60 liters a minute. It's just tearing through there, right? So those are important things. When we think about humidification, and this is true with all the devices, but also with your body, there are 3 things that are important to think about when we talk about the effectiveness of a heater. Time, right? So the amount of time the gas encounters the liquid, right? The temperature, right? So temperature impacts the amount of carrying capacity a gas can have. So when a temperature goes up, does the carrying capacity go up or down? It goes up, yeah. Hotter gas can be more humid. That's why I don't like to go to Atlanta in August. It's very hot and humid there, right? So when it's colder, less carrying capacity, right? So if you have a gas in a ventilator circuit, for example, that starts hot, and if it moves through a cold circuit, which we try to avoid, what would happen in that ventilator circuit? Condensate, right, because it reaches its dew point, right? So the dew point is the maximum amount of water a gas can hold at that temperature, and it starts to rain out, right? Exactly. Very good. And the third thing then is surface area. So temperature, time, and surface area, these are the things that impact a heater, right? So the efficiency of a humidifier, rather, right? So the greater surface area, just the more space it has to pick up humidity in those particles. 3 things, okay? Very good. Lots of different humidifiers that I'm going to show you, but there are 2 general classifications. Do you remember what the 2 general classifications of humidifier are? Active and passive, super easy, right? Right, either I'm doing the work or the heater's doing the work. Active or passive, right? So I'm either using my airway to supplement, that would be an HME, or the device is doing it for me, active or passive. Very good. Okay, what kind of humidifier would I use for this guy? Yeah, it's really the only thing I have, right? It's the only choice I have. Everybody has seen a bubbler, right? Right, just connects and goes directly to the Thorpe tube flow meter or Bourdon gauge flow meter, as was previously mentioned. How does this work?
As the high flow passes, it goes down and gets saturated with the water, and it goes up, saturated and oxidated.
Very good. Yeah, it's literally a bubble humidifier. It bubbles up, right? So the gas comes in and goes down this tube and then bubbles back up through the water, right? The diffuser in here, the size of the particles it makes is really important, right? The smaller the particle size, the more surface area of the gas that's exposed to the water, right? As it literally bubbles back up and goes to the patient. Okay. Do you think this thing is more efficient at 2 liters or 6 liters? 2. Why? Why would 2 be more efficient than 6? Time. Yes. Right? It's like driving a car. If I'm going 60 miles an hour, I will get there faster than if I'm going 20, right? And so remember, the length of time it spends in the water impacts the humidity this can provide, right? So 2 liters will pick up more water vapor content than at 6 liters, right? There are a lot of data that would tell you this isn't a very efficient means of humidification anyway, because maybe you don't need it at 2 liters, and at 6 it may not be very efficient anyway. Controversial. I do know some hospitals that don't buy these anymore, actually, which is interesting, but that's the point to this. You can have a relative humidity of 100% with this device. It's not heated. It'll never reach 44 milligrams per liter, right? Maybe you'll get 10 or 15, but you'll never get the maximum out of this, okay? Very important. Can I connect it to this?
No.
What happens if I do? Because I've seen this.
It will fill.
Yeah, the bag just becomes a water bag, which is fun for parties, but not for your patient. Okay, yes, I've seen that many times, unfortunately. Great, okay. There are other types of bubble humidifiers. What is this? Yeah, it's an aerosol, but it functionally works very similar to a bubble humidifier. You see the wick, the tube in there? Right? So the gas still, that we fill this up with distilled or sterile water, yes. And then, the gas still comes in and still bubbles back up. Functions very similar to this. The difference is there's the opportunity to be precise in the oxygen administration, right? So this is most commonly used either with an aerosol face mask or a trach collar. Why does it have to have this little water bag in the middle?
Like a trap for the because that's
To drain.
This is not a heated circuit. This is not heated. Yeah, if I'm walking down the hallway, I can find these with my ears. They're very, very loud, right, because a lot of flow tears through them. But they're not heated. It's very cooled. So the water will evaporate and condense into this water bag. Yes. It would be very sad if you don't have this water bag in here, right, because you'll just have water sloshing around. Do you remember what happens if you have water sloshing around in this tube? What happens to the FiO2? Causes back pressure, right? It will increase because it will reduce the amount of air entrainment, right? Yes. Very good. All right. There are some little heated collars. Have you guys seen those, the little heated collars you can put on these? Yeah, a million years ago they used to make those. They're not very effective. Just makes this kind of warm plastic. But the intent here is to increase the temperature, right? Remember, temperature, time, surface area. Very good. Okay. All right. What is this for? This is what type of humidification? It's definitely active. Yes. And what you most commonly see it with mechanical ventilation, invasive, non-invasive, high flow nasal cannula. Sometime you'll see with this as well, just depending upon the setup. Yes, very good. This can be heated or unheated. It can be both. It really can. Most commonly in the hospital, you're going to see this as heated. Right? This is probably one of the more efficient means, right, of providing humidification to our patients. You can achieve BTPS using this type of a device, particularly if you're using a heated wire circuit on the other end of it, right? Okay. How does this work? You teach me. How does this work?
It's connected to the water bag.
Yes, this goes to a water bag, right? So there's a little float in here. So this is one that autofills, but they do have some that you have to manually fill. That's true.
Then we'll connect it to the circuit.
Yep, so I've got a circuit here and I've got a circuit here. So this goes to the ventilator and this goes to the patient. So the gas goes through here, right? What type of humidifier does that make this? It's a passover. Yeah, it's not bubbling down and up. It's literally going over the surface of the water, right? So this is more efficient than this. Why?
Heated.
It's heated. Yeah, it's heated. Very good. So yeah, it passes over here. The reason that temperature, it makes it a more efficient humidifier is because it speeds evaporation, right? Very basic science, right? It speeds evaporation. So there's just more water vapor available to the gas going through. The efficiency of this will vary depending upon the speed, the flow rate of gas you've going through here. Remember, that's about time. Surface area is important. This type of heater actually creates molecular particles, so there's a lot of surface area for that, which is great. So it comes out of here completely heated and humidified and then moves into the patient's ventilator circuit, high flow nasal cannula circuit, non-invasive circuit, etc. How do you know that it's 100% saturated? How can your eyes tell you it's 100% saturated? Condensation where? In the ventilator circuit. Yeah, what if you walk into a patient's room and there's no condensation in the ventilator circuit? It's definitely dry. What's the problem with that?
Finish that one.
Maybe no heat.
There's something wrong. You have to troubleshoot it, right? And what's the...
Water finish.
Oh, this could be dry. That's true. I've seen that. Yes, yes. Yeah, what's the impact to your patient, though?
Close maybe.
Dryness.
Humidity deficit, right? Increased humidity deficit. This is a problem, so you want to troubleshoot this. Do you know what kind of things, I talked about this yesterday briefly, what kind of things can trick this heater? Ambient temperature. Yeah, so the temperature in the room, if it's a very hot room, it can trick the temp probe, right? If you're in a radiant warmer or in a neonatal ICU, it can trick the temperature probe. Or the other place I've seen this I mentioned yesterday is in burn units, when they have, again, the radiant heaters above the patients. Again, it's tricking the temperature. So you have to watch that very, very carefully. Good. All right, the last one I want to talk about quickly, because I'm out of time, is this. What's this? It's an HME. How does this work?
Maintain the
Yeah, this is why we call this an artificial nose sometimes. It functions like your upper airway, right? So I exhale into it, I heat it, and I humidify it. I'm doing the work, right? That's why it's passive. And then when I inhale the gas again, my own exhaled gases are both heating and humidifying this. There are several types of these. You probably heard about this during COVID, right? Some of them are just paper. All they do is heat and humidify. Others, like the one I have in my hand, also serve as a HEPA filter to filter out viral particles that come through here. So during COVID, we tried to use both HMEs that are HEPA filters as well, which was nice. So I'll just mention that. What are the contraindications to this device? Thick secretions, bloody secretions, hypothermia, you can't heat if you're cold, and a big leak. Why a big leak?
Because it also would reduce the voltage.
Yeah, if I'm not exhaling through this, I can't heat it or humidify it. If I'm just breathing out in the room, right? So you can't heat or humidify this. So thick or bloody secretions, low body temperature hypothermia, large leak, minute volume greater than 10, too fast, right? And you generally don't want to use this for more than 3 days. Excellent. And I'm at time. Any questions quickly? Yes, sir.
Any patient mechanical ventilator connected in the HME filter or humidifier without don't connect the patient without filter or without any humidification. Yes.
Yes, you should never use invasive mechanical ventilation without some sort of supplemental humidification, either active or passive. It is an absolute requirement. Yes, good question. All right, you have to run to your next room. Thank you guys so much. If you have other questions, please find me later.
Anyway, I'll keep it. There are two types of nebulizers. We have jet nebulizers. The first generation of jet nebulizers that I mentioned in my presentation yesterday. The issue with this is that it is very inefficient, right? It is inefficient because of two reasons. Do you remember the first reason? The residual volume. Yes. How do we call residual volume? What is the definition of the residual volume? The amount of drug that stayed in the nebulizer cup at the end of the treatment. So this nebulizer has a large residual volume. Usually 2/3 of the medication stays in the nebulizer cup, and that's the reason why it is inefficient. Another reason is that you lose a lot of medication during the treatment. Even though you place this 6 large bore tubing here to keep the medication or aerosols in the system, you still lose a lot of medication. So that's why we do not enjoy using this, but there are several institutions that are using this device because they are cheaper than other types of nebulizers. So to improve their efficiency, some other companies designed other nebulizers that you see in this in here. In this particular one, there are 2 valves. One valve here, another valve here, to prevent aerosol loss, right? So they tried to improve aerosol drug delivery by adding valves at 2 different locations, including the mouthpiece and the nebulizer itself. And they also tried to reduce the residual volume to improve aerosol drug delivery to spontaneously breathing patients. And 2 different companies did the same thing, and they had the same principle. Even though the design is different, they had the same idea. And then we have the mesh nebulizers that you guys are familiar with. It can be used either with a mouthpiece or a face mask. Which one should we use? Should we prefer the mouthpiece or the face mask? Depending on the age, that's exactly right. But if we are treating an adult, mouthpiece would be our choice if the patient is able to use the mouthpiece consistently and reliably during the entire treatment. If you use the face mask in children, what do you need to do? Seal it, exactly. Why? Yes, you don't want to have any leak when you use the face mask during aerosol therapy. Even small leaks will create a big reduction, will cause a big reduction in aerosol drug delivery. That's why it is important to use a good seal between the face and the mask. What happens when you have a good seal between face and the mask in children? They start fussing and crying and you cannot deliver aerosolized medications. In this case, what do you need to do next? Designed for children. Yes, exactly. You can use a pacifier mask or high flow nasal cannula because children are nose breathers, so they will benefit from the high flow nasal cannula. You can deliver aerosolized medications through high flow nasal cannula. So face mask may not be the ideal interface for children, but you will be able to find other interfaces that will be much better tolerated by your patient. Yes?
What's the space up with the mixed dose inhaler for children?
Actually, that is the topic that Mabruk will cover. So hang in there. We will talk about this as well. So when you use the jet nebulizer, it doesn't matter which one. What is the flow rate you need to use? 6 to 8 to generate ideal particle size. What is the ideal particle size? 5. Excellent, excellent. You guys are so good. And in mesh nebulizers, we do not need any additional flow, right? I mean, if you use this that is designed for spontaneously breathing patients, of course, you can add the flow rate. But in general, we do not need the additional flow or additional oxygen or gas to operate the device. It is operated by electricity or battery. So you should be able to use it without adding additional flow to the system. So that's the beauty of the mesh nebulizers. Every time when you use other types of nebulizers like the smart nebulizers that we do not have it in here, you should always follow the manufacturer's guidelines. I think one other thing that I would like to mention is the compressor. Do you remember what I said about the compressors yesterday? Sometimes if we are using the nebulizer at home, we use the compressor to operate the jet nebulizer. And in this case, we need to make sure that both the jet nebulizer and the compressor are manufactured by the same company. Otherwise, they may not work well together. Even though you will see that the nebulizer operates, it may not generate the ideal particle size. And you should always question what the particle size is, what the aerosol deposition is, every time when you have a new device in your unit. Talk to the representative of the company and ask for those information to determine the efficiency of the device. So that's my
Is it working now? شغال? Okay. So with each device, we need to make sure that we have a one-to-one session with the patient or a guardian if the patient is a child, and also to consider all factors that might affect the teaching delivery. For the meter dose inhaler, for this device, it has 120 puffs, okay? And we need to prime the device before using it, usually in the first time. So first, you will open the cover, okay? Shake it, then you need to prime it, which is at least 1 puff or more, okay? And with this device, you need to do 4 puffs, and you have it like away from you. 1, then you will wait, then the second. And also, remember the 15 seconds that we need to wait between 2 actuations, okay? And the beauty of this device actually is that it has an indicator that tells you how many dosage left. And other types of meter dose inhaler, like the common ones, the conventional ones, is it doesn't have a counter. That's why we need to count how many puffs they have per day. Is it twice BID or TID? And just have like a log and explain to the patient when is the next refill, because sometimes the medicine is empty, but still there is some gas coming out, but there is no medicine. So it's very important to make sure that the patient is aware when to have a refill. For the patient to start like with the MDI, so again, you need to shake it very well. If you didn't shake it, how many percentage or how many?
30%.
Almost 25 to 35 or 30%, okay, will be reduction. That's why you need to mix this propellant with the medicine inside the canister. When it's prepared, you need to have the patient either sit or standing with a tilt, like having the head back a little bit, then a good seal. Then he need to coordinate the press with the first second of inspiration. So, and this is the difficulty and challenge with geriatric patients or patients who have dementia or patients who are have some limitations with doing these coordination, especially like as also Dr. Ajid mentioned yesterday in his presentation. Most of the RT in the capital or the kingdom are from Philippines or other non-Arabic speaker, which have also difficulty sharing this knowledge with the patient. So maybe you need an interpreter or somebody who speaks the language to deliver this message. Very crucial and it's very important to make sure that he delivers. So it's ready, he will have it sealed, then press, then he should take deep fast or deep slow with the MDI.
Deep slow.
Deep slow. It's very important to have it deep slow, then he have it. Then he will hold how many seconds?
10 seconds at least.
10 seconds at least, or as some patient has he tolerated 8 seconds, but as it should be ideal like 10 seconds. Then he will exhale. Then how many seconds he need to wait from 15 seconds, at least 15 seconds. Also for the device it has to be cleaned. Okay, to clean this device you need to remove the compressed canister, okay, leave it away, don't submerge it in water, and this is the house that you need to clean it. You need to clean it with the warm water, okay, every other week, and make it air dry, okay, don't use like a tissue or a cloth, air dry, okay, and check it from the water and just let it air dry, then make sure it's fully dry, then you can place the canister again, okay. So this is for the meter dose inhaler. For the other challenges and problems with the MDIs is, as I mentioned, which is the coordination, also the higher oropharyngeal deposition because of the coordination. Sometimes patients they will taste the medicine and also they will have the medicine in their oral cavity, and that's why you can add a spacer air chamber. And air chamber we usually prefer to have antistatic chamber that doesn't have the electrostatic for higher deposition. So you just, again, you prepare it, shake it, then you place it here, okay? And you can use it with a mask or without. This one with a mask or without a mask, okay? And this is a valve chamber. What's the difference between spacer and valve holding chambers? Yes, the one-way valve. And also this device has to be cleaned, okay, and should be cleaned with soap and water. You can just deassemble it and wash it, then make it air dry as well, okay. Now we'll move to dry powder inhaler. So dry powder inhaler, it's have less coordination compared to the meter dose inhaler. It contains powder. It doesn't have a compressed gas like the meter dose inhaler. And all the dry powder inhaler has a counter. Usually the device will be like this. What we call this device? Dry powder inhaler, discus inhaler. And here we have dry powder inhaler, turbo inhaler. And here we have dry powder inhaler, hand inhaler, okay, which is the unit dose. And also we have a dry powder inhaler, which is the ellipta. So it's have the powder, but in terms of priming, it has some differences, okay? So for the unit dose inhaler, which is the hand inhaler, which is the old version of Respimat, okay, that's by Riva, okay? So usually you'll have a capsule, you'll open it, okay? You'll place the capsule here, you close it, and you have the needle, you need to puncture it, okay? Then it's ready to go. And for the technique, is it fast deep or slow deep breath? Fast. So here, what is the how many liters inspiratory flow? At least to have the full dose. 60 liters. 60 liters. So it's very important to make sure that the patient is capable of using this device. Again, we can discuss all the advantages and disadvantages for all kind of aerosol therapy devices, but the question is, what does the patient need? What does the patient is capable of? You will see a patient in EMS, an outpatient, at home, in ICU. The medicine is here, but what is best for this patient? Okay, we have patients who are elderly, we have patients they are blind, we have patients that cannot hear, we have patients they speak different language. There is a lot of limitation to it. That's why it's very important to differentiate. And this one also, when you have the device ready, you have exhale all out, then take deep and fast breath, then you will hold 10 seconds, then you will breathe normally. And also, we need to instruct the patient not to exhale in the device. Is very important, and also not to keep it in any warm area like a bathroom or any humid, because it will cause, it's a powder, maybe it'll have some build up on the opening or the opening of the device. This is for the dry powder inhaler, hand inhaler. And for the turbo inhaler, you will just open it like this, okay? And also it does have a counter. Make sure there is enough medicine in it. Then you need to just click right, then left, and you hear the click. Then have it like this, sitting or standing, okay? Then take deep and fast breath. Then he should hold for 10 seconds, then breathe out. Also here we have a dry powder here, which is ellipta, okay? Okay. 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 And my colleague will distribute just to see it. And this one is very easy. Once you flip it, it's ready to go, okay? You'll have it, you take deep, fast breath, then you breathe out normally. And also it does have a counter, tells you how many left in the device. Okay. Lastly, for the peak flow meter, okay. Peak flow meter usually it's used to assess the level of obstruction. Sometimes we don't need to use it actually, because it's the clinical presentation of the patient. If you see a patient in EMS who's in respiratory distress, tachypneic, desatting, it's not necessary. His clinical presentations tell us that he has exacerbation. But yes, we can use it at home. We can use it also as an inpatient to assess the level of obstruction. And here you have liters per minute, okay? And here the indicator, you put the indicator at 0. Then you will ask the patient to do what? What's the instruction for this device? So you will exhale. You ask him to blast the air out as much as he can. Yes, and he still need to be sitting or standing. Okay, so he'll take a deep breath. Then he will blast the air out, and then it will tell you how many liters per minute he has. Okay, and this also device can be built with action plan, like asthma action plan, with the green, yellow, red zone, and can be distributed at the clinic and for patient to assess their situation at home, to tell them what they are. Are they in a comfortable zone, or they need to see a doctor, or they need a EMS visit. And this also need to be doing, he need to do it 3 times, and you will record the highest result. For the cleaning, for the discuss and dry powder hair, don't use any wet cloth, or don't use, so you can use dry cloth or tissue, but anything that's humid or watery, don't use it, because it will ruin your device. Any questions? I believe I'm done. How many? 2 minutes? Okay, so I'll hand it now to my colleague, Dr. Yahya.
Okay, in this part of the workshop, I will talk about using aerosol delivery devices on invasive mechanical ventilation, on BiPAP, non-invasive ventilation, and on high-flow nasal cannula. We'll not go through details, but I just will mention important consideration about the other 2 devices. But let's start with invasive mechanical ventilation. My colleague mentioned 4 devices, or 4 different types of aerosol devices, namely jet nebulizer, vibrating mesh nebulizer, we have the pressurized metered dose inhaler, and the dry powder inhaler. Which one of those 4? One of those we cannot use with invasive mechanical ventilation, or even the other 2 devices?
The dry powder.
The dry powder. Why?
It's dry. It's need the patient to.
Okay, it requires faster inspiratory flow. Also, the powder nature of the medication will make it settle or deposit into the circuit, the upper airways, and also the artificial airways. Okay, so we have those 3 devices, which I will show you. Using aerosol delivery devices also on mechanical ventilation add another layer of challenge to us as a clinician. Can you tell me, or if you know, what are the factors that could affect the aerosol deposition or aerosol performance on invasive mechanical ventilation? So why it's more challenging or difficult than spontaneously breathing patients? Why? What are the factors, if you read it in the book, or if you know it, or if you can even imagine what factors here would affect the aerosol deposition? What's that? Dead space is one thing. We have longer areas. Thanks.
Exhalation, you cannot tell the patient to inhale or exhale, so you have to watch this point, inhalation,
Okay.
exhalation phases.
Exactly. Exhalation or expiratory hold is very important for aerosol deposition. You cannot really instruct the patient if they are, sedated or uncooperative. What else? There are plenty, actually, you could think of. What's that? Condensation due to humidity, you mean? Humidifier? The use of humidifier or humidity and temperature, that's one thing also. What else?
Synchronize the breath with the patient.
Exactly. So the synchrony is an issue as well. Okay, great. So I will start with some of these factors. We'll start from the ventilator, then moving forward to the patients. So from the ventilator, ideally, you want the patient to have an inspiratory time or tidal volume of 500 ml, inspiratory time of 1.5 seconds, and having the expiratory hold you mentioned. But you cannot really actually do this. You should not. You can, with the ventilator, adjust the tidal volume. You can add, increase the inspiratory time, either by increasing it directly on pressure control or maybe reducing the flow and volume control. This will increase the inspiratory time. But those places the patient at risk of trauma if you increase the tidal volume, or maybe increase the mean airway pressure if you increase the inspiratory time, which further compromise the cardiovascular function if you do so. So this is why you could, but you shouldn't do any of those changes. Moving forward to the circuit, dead space, some of you mentioned, also all the angles, and those circuits will, some of the medication will deposit into the circuit, into the artificial airway as well, having all these connection. On the patient side, we have the asynchrony that your say groupmate mentioned. We have the asynchrony, we have the disease process. The patient start to wake up, they start fighting the ventilator, so this makes it difficult to deliver aerosol or to optimize the aerosol deposition. But we'll talk about some technique what we could do to optimize it. The first thing I'll talk about is using jet nebulizer. So the very first thing when you receive an order or prescription or you want to do something on the patient, what should you do as a respiratory therapist? Exactly. So verification. You verify the order, double check the order if it's correct, if it's right for the patient. You identify the patient and you assess the need for aerosol therapy. The patient might not need it now or has been on aerosol therapy for a few days and the patient is improving. So he or she won't need aerosol anymore. So you have to assess this. Then during your assessment, you have to also assess the presence of secretion. If there is any secretion, the upper airway or the patient needs to be suctioned, that needs to be done first because you want to clear the airway. Secretion will act as a barrier for aerosol, which will further reduce the aerosol deposition. Okay. What's the other thing that reduce the deposition or act as a barrier is the HME. HME also need to be removed if you're using filter HME from the circuit before using any sort of nebulizer devices, unless you have HME aerosol delivery, the one that will allow you to deliver aerosol. With this, they have usually rotating knob switching between HME and aerosol. I have one device that you may not commonly seen. So this is HME and aerosol. This is called Air Life. It's also in your book. So for this one, if you control the knob, if you open it here, you can see the space to for the aerosol to pass by. So you can just move the knob and watch the space here. So for this one, you can switch in between. If you have this type or the different type that you control the knob, you can leave it in place. But make sure you turn it to aerosol section before you deliver the medication. Otherwise, you need to remove it from the circuit like this way. So what's the most ideal location for aerosol delivery? What's the ideal location? Okay. How far from the Y?
It's near to the endotracheal tube, not near to the.
Okay. Exactly, but it's on a respiratory limb. On an respiratory limb, that's very important. 6 inches or about 15 centimeter from the Y. That's the most ideal. When they test this out, and Dr. Arya and I believe her colleague did several studies, and they found this is the best location. to optimize aerosol delivery. So it has to be in the inspiratory limb and 6 inches or 15 centimeter from the Y. We could not actually set it up here because most of the hospital now use vibrating mesh. So the circuit now are glued into the Y. We couldn't find the old circuit that you can disconnect and just place this one here. But just for the sake of demonstration, you will have this about 15 centimeter from the Y to optimize the medication. Then what's the fill volume? Say you have a medication, what's the fill volume for nebulizer or jet nebulizer on mechanical ventilation? 3 to 5, that's for spontaneous breathing. For this one, due to all the factors we mentioned, you may need to increase the fill volume to 4 to 6. Usually 4 to 6 is the lift, especially with the jet, because you will have residual volume. So some remaining volume will stay into the jet nebulizer. That's one of the actually shortcomings of jet nebulizer. So with the new ventilator, you can actually use the ventilator itself. It has built-in compressor to generate sufficient air flow to supply the jet nebulizer. Otherwise, with the old ones, you will rely on external gas source. For external gas source, either you have oxygen source from the outlet or you have oxygen cylinder to rely to power your jet nebulizer. When you do so, the ventilator does what it does. It doesn't know that you are using nebulizer. Yes. So what the ventilator do, it will notice additional flow coming. With the additional flow, you will have higher volume and higher minute volume as well. So the ventilator will start sounding. That's one thing you need to consider before, if you are using external gas source, before administering the medication, is to loosen your alarm limits a little bit. So just increase the minute volume and tidal volume alarm limits before using jet nebulizer. For this ventilator, actually, it has a built-in one of those, and most of the newer ventilator they do. So you just connect the oxygen tubing to this one and activate through either it has a knob or through the user interface. You can actually access some function or additional function of the ventilator to actually allow it to generate nebulizer. So then the treatment will take about 10 to 15 minutes. After you hear the nebulizer sputtering, that sound indicates that's almost finished. You wait for about 1 minute before you turn off the nebulizer, or some ventilator will turn off automatically if it reaches 15 minutes period. Then you can remove the nebulizer because it's adding dead space. Make sure you don't leave it in place. You have to replace everything and return everything to the way it was. So if you remove the HME, you put it back. If you adjust your alarm limits, you have to put them back to the previous setting. If you are using heated humidifier, you should keep it on. Make sure you don't turn it off. It's an old practice. One of you mentioned the humidity or the condensation. We thought it could enlarge the particle size, and this lead to aerosol being deposited either in the circuit, the artificial airway, or into the upper airway of the patient. But also Dr. Arya and her colleague conducted a study comparing the aerosol deposition when the humidifier is on versus when it's off, and they found no significant difference in aerosol deposition. Also, the other reason is having the patient or administering high flow cold air to the patient for 10 to 15 minutes has side effect. It could induce bronchospasm, the cold air. It could also affect the ciliary function. Also, it could induce hypothermia. And that's two reasons you need to consider this. So after you remove the medication, we always do what we're supposed to do. We have to do the post-assessment, assess for any adverse event or side effect of the medication that could have happened. Then we document the findings. The second thing I'm talking about is vibrating mesh. For vibrating mesh, also we follow the same step until we get to this placement. What's the best or the optimized, the most optimized location for vibrating mesh? The dry limb at the heated. Okay. If you have using heated humidifier, you place this on the dry side. So the connection that comes out of the ventilator, you connect this into the dry side, then the other side will go to the patient. Okay, so this is the most ideal. If you are using HME, So you don't have your heated humidifier. Where should this go? You have to remove the HME. Unless it's the aerosol HME, you remove it and you place this at the Y, okay, at the inspiratory limb proximal to the Y, okay. So this is the most ideal location. And as Dr. Ari explained, so this usually is electric powered. It has battery, but you need to be connected to the electrical outlet most of the time. So the fibrated mesh is so far the best device that will deliver more aerosol deposition when compared with other devices. The last thing I'm talking about, في MDI The last thing is using MDI, because we still use it with the ventilator. Of course, you need MDI adapter to be attached to the circuit. And what's the best location to optimize aerosol deposition with MDI? Masma. Close to the Y, exactly. So you need to keep it close to the Y. You can use spacer with it to enhance aerosol deposition with the same principle that my colleague Mabrouk explained when using spacer. So optimize or increase the aerosol deposition when using spacer. We have collapsible and different types. Sometimes some adapters actually, it's at the ET tube. So we have elbow adapter attached to this one, and you can use it to deliver the medication. One important consideration, if you have patient cooperative, which is very rare, if you have patient on mechanical ventilation, you want them to simulate the same breathing pattern that Mabrouk just explained. You want them to sit upright, you want them to take a deep breath. Once you actuate the medication, you synchronize this with the deep breath and ask them to hold their breath 4 to 6 seconds. That's the ideal, but not the case in most of the patients would say. So one thing you need to consider is to synchronize or coordinate your actuation with the initiation of inspiration on ventilator. So you watch the waveform, and once you notice the patient started to take the breath, you actuate the medication. So this will improve the aerosol deposition. How long you have to wait between puffs? 15, a minimum of 15 seconds according to the manufacturer guidelines or recommendations. So you wait 15 seconds in between puffs. And do you remember why? Dr. Ari explained it yesterday. Exactly. Okay. So if you do several puffs back to back, like you have 2 puffs in less than 15 seconds, the second dose will have less medication than the first dose. Okay. So this metering dose here, this is why it's called metered dose. So this metering dose fill with medication. Once you give the first dose, it takes some time to refill to deliver the exact same dose that's supposed to be delivered. And again, we'll conclude once you finish with the treatment, you will do the same. As explained earlier, you have to do the post assessment. If you did remove the HME, replace it back, assess the patient, and watch for any adverse event. The patient is stable, you have to document. Okay, and a question on this part? Yes? The high frequency, it does, of course. You know, with this high frequency affected the aerosol deposition, but I'm not sure if there's any studies done on high frequency and aerosol deposition.
We did a study on high frequency ventilation, and we can deliver aerosolized medications through high frequency oscillatory ventilation. And we didn't compare it with the regular mechanical ventilation. But it is possible to deliver aerosolized medications through high frequency oscillatory ventilation, and we need to place the device near the patient.
Okay, now I'll show you the high flow nasal cannula setup. We have the Airway 2 here. Okay, we have so a special type of setup. So this is the heated humidifier, but for this device they have special connection. You can see here vibrating mesh usually is the most commonly used and the most ideal, and the recommended use with high flow nasal cannula. It's attached to this board in here, and then the cable goes into this board. Then of course you have to initiate the medication. One important consideration with high flow is you may need to reduce the flow during the delivery of the medication. Why? Why is that? Flow is important, or it's recommended to reduce the flow if tolerated by the patient.
Because it will affect the particles.
Exactly. So this is why the same thing with MDI, you don't want them to take a deep breath because the turbulence will affect the deposition of the airway. So that's one important thing about high flow nasal cannula.
Reduce to 30 or something. 30 isn't the flow.
You reduce by 10 and watch for any fluctuation and saturation. If tolerated, that's fine. But if not, you just deliver as it is. The other thing is non-invasive ventilation. So usually the vibrating mesh comes in between the circuit and the leak port. If we have leak port, actually the leak port should not use it. So if you have a mask with the leak port, most of the medication will be a waste. But this is not leak port actually here. This is anti-asphyxia. It has a one-way valve. Don't know if you notice. So if there is a flow, it will block this valve. But if the patient is asphyxiated or there is no flow, it will just open for the patient to prevent asphyxia. So this is where the vibrating mesh goes into the device. Or you may use this type of mask that doesn't have any port or whatsoever, and this one. Okay. Do you have any question? Clear? Okay, this concludes the timing of. I believe الانبوت هنا.
So now we are going to talk about everything one more time, and we will give you some take-home messages. And as I mentioned,
تحتاج إلى تلفنت ولا خليني؟
be prepared with slides for you guys, and we will start with spontaneous breathing patients. How we are going to select aerosol delivery devices in spontaneous breathing patients? What will be our patient's capability, patient's impairment, patient's physical and cognitive impairment will be one of those criteria that we need to pay attention when we are ready to select in our spontaneous. So you need to select. Thank you. You need to select an aerosol delivery device based on drug device and patient-related factors. First, you need to determine the goal of your treatment and then decide which medication is available for your goal that you would like to achieve in aerosol therapy. If it is available as a PMDI, use the PMDI. If the medication is available on 3 different forms as PMDIs, DPIs, and nebulizers, in this case you need to look at patient-related factors like physical and cognitive abilities, age, preference, tolerance, and all that stuff. You need to prefer nebulizers over inhalers in 3 conditions. 1, if the patient is unable to use the inhaler because they cannot perform the specific breathing technique that is required by the inhaler. That's 1. The second is if drug formulation is not available as an inhaler. The third one is that if there is a shortage of inhalers. In this case, again, we need to use the nebulizer. Do not use the DPI if the patient cannot generate high inspiratory flow rate during treatment. And do not use the PMDI if your patient doesn't have a good hand-breath coordination. If that's the case, you should combine the PMDI with the spacer or the wiped holding chamber. But most of the time, patients don't want to carry spacers or wiped holding chambers with them. So ask what they prefer. Always, that's something you need to consider doing. So as for the interface, which interface we are going to use in adults? Mouthpiece is our choice, but face mask will be another idea, or high flow nasal cannula, right? That's another. What about children? What are we going to use? High flow nasal cannula would be a good choice. Or we can use a face mask if the patient is tolerating the interface. If your patient, if you have pacifier mask, use it. That's perfect because they won't fuss and cry during treatment. And every time when you use the PMDI in children, make sure that you use it in small volume while holding chambers, because they won't be able to empty the medication inside the chamber if it is too large for them, because their tidal volume is small, right? That's why it's important to choose the right one. Particle size between 1 and 5 micron is the ideal. We all learned that, right? And we need to make sure that we have the nebulizer fill volume adequate for the nebulizer. What we need to do to increase the delivery efficiency of the jet nebulizer if we have to use it? What do we need to do if we would like to use the jet nebulizer and if we would like to increase its delivery efficiency? Yeah, you can use a breath actuated nebulizer or breath enhanced nebulizer or mash nebulizer, which will be much better actually. Or you can increase the volume of the fill volume of the jet nebulizer. If you use a 3 ml unit dose, you can add another 2 ml of normal saline. That will be another option. So use always sitting up, upright position every time when you deliver aerosolized medications to spontaneously breathing patients, and make sure that you actuate the PMDI with the beginning of at the beginning of inspiration. How long do you need to wait in between PMDI actuations?
15 seconds.
At least 15 seconds. And when you teach your patient how to use aerosol delivery devices, make sure that you cover everything, not only the device. Make sure that you tell them about their disease and how the medication will be beneficial for their treatment, what type of skills they will need to do the correct inhalation technique if they use the inhaler, and give them some daily self-assessment tips so that they can assess themselves on a daily basis, and they will know what to do when they have a disease exacerbation. So that's another thing I would like to emphasize. And those tables are important tables that you need to review. If you haven't had a chance to review them, please review them in your book chapter. When you evaluate your patient in a follow-up visit, don't ask only the device. Ask about the disease, if they are still understanding the disease, if they are still understanding the benefit of the medication, and ask about the breathing technique, and ask them to show it to you so that you can correct their breathing technique if there's some steps that are missing, and ask about the daily treatment plan and their adherence to treatment. And some patients may say, oh, I am using it to please you. So that is usually the case with the patients, right? They don't want to say, I don't use it, especially if this question comes from their doctors. But understand what factors impact patient adherence. For instance, if the treatment is too complex for them, they won't use it. If they think they are very confused with different breathing techniques, including with the PMDI and DPI, they won't be able to perform the treatment well, and at the end they will stop using those devices because they don't use the right breathing technique and they don't benefit from the medication. Also, if you give too many medications to them, they will be too tired of getting medications all the time. So simplify the treatment plan. That will be very important. Also understand their reasons why they don't use the device or the treatment. Sometimes they say, oh, I'm fine, I don't want to use it, I don't need it. Sometimes they will say, oh, I'm so afraid of the side effects, let me not use it. They don't tell this to you, but that's what they will believe. Unless you ask them, you will not know. So address those questions and make sure that you understand their belief system and you can correct the issues with their adherence. As for mechanical ventilation, aerosol drug delivery during mechanical ventilation, you have two choices. You can use either a PMDI or a nebulizer. When you use the PMDI, place the PMDI 15 centimeter away from the Y piece on the inspiratory limb. And if you use the nebulizer, let's say you are using it with a bias flow, in this case, jet and mesh nebulizers should be placed at the inlet of the humidifier. That way, inspiratory limb will be used as a reservoir. The medication will stay in the inspiratory limb, and in the next breath, patient can get more medication. So that's the best position for both nebulizers. Do you need to turn off the humidifier? No, you don't need to. Thank you. Should you use the regular HMEs?
No.
No, because you don't want to break the system every time when you are ready to deliver aerosolized medication. So Yahya did a very nice job showing you the HMEs designed for aerosol drug delivery. If you have one of those devices, use it in your clinical practice. How are you going to use the PMDI during mechanical ventilation? Huh?
During inspiration.
Yes, you need to actuate it at the beginning of inspiration and wait at least 15 seconds. What is the flow rate you are going to use with the jet nebulizer? 6 to 8, exactly. Okay. And non-invasive ventilation, very similar. You can use either PMDIs or nebulizers. Can you use the helmet during non-invasive ventilation to deliver aerosols, the helmet or full face mask? No, you should not. If you are using the helmet or full face mask for aerosol drug delivery, please don't use it anymore, because aerosols can deposit in the eye and create all sorts of problems. You don't want that. So oronasal face mask will be ideal for aerosol deposition. And choose the circuit with leak port, not the face mask with leak port, if you would like to deliver aerosols efficiently during non-invasive ventilation. Also choose a chamber spacer to use with the PMDI. Not only in non-invasive ventilation, but also during mechanical ventilation, because you can increase aerosol drug delivery up to 6-fold. 6-fold. It's a big difference. And the procedure is the same. Actuate the PMDI at the beginning of inspiration during non-invasive ventilation and wait at least 15 seconds. Aerosol therapy with the high flow nasal cannula is a hot topic, actually. You should prefer mesh nebulizers with this particular setting, because you do not add additional flow to the system since the mesh nebulizer is operated with electricity or battery, unlike the jet nebulizer that requires additional gas flow to operate. Also use the largest available cannulas, up to 50% of the diameter of nares of each patient. Place the nebulizer at the inlet of the humidifier. That's the best position to increase aerosol deposition. Same reason, you can use the circuit as a reservoir, and you can lose all these large volume, large particles in the humidification system. You can, they can stay in the humidifier instead of creating a condensate in the cannula if you place them, if you place the nebulizer near the patient. So as for the flow rate, that's the most important part. You should use lower flow rate during high flow nasal cannula when you deliver aerosolized medications with this particular device. If you are able to choose, if you are able to measure your patient's inspiratory flow rate, in this case, measure it and then take 50% of it and then set the flow rate based on that. If your patient's peak inspiratory flow rate is 60 liters per minute, ideal flow rate setting for the high flow nasal cannula will be 30. And then you can go back to whatever level you are using at the high flow nasal cannula. If you are unable to use, unable to measure the flow rate with your patient, in this case you can reduce the flow rate by 10 and stay at the bedside, monitor your patient, make sure that your patient tolerates the low flow rate, and always go back to the original setting at the end of the treatment. You can use Heliox, but Heliox is expensive. If your patient is already on Heliox, use it. Otherwise, just use oxygen with the high flow nasal cannula. Do not deliver aerosolized medications during concurrent high flow nasal cannula. So sometimes clinicians keep the high flow nasal cannula on the nares and then place the face mask or use the mouthpiece with the traditional aerosol therapy. But this is very inefficient. We don't recommend that technique. Deliver aerosolized medications either through the high flow nasal cannula, or you can use the regular treatment modality, and do not turn off the humidifier to increase aerosol drug deposition during high flow nasal cannula. Did you guys get the PDF document? Yeah. You're all good. You can go to the next workshop. It was a pleasure to have you in this session. Thanks to my colleagues who helped me. And I would like to hear more from you guys. So let's keep in touch and enjoy the rest of the workshops. Sure. Mm-hmm.
Okay, is that better? Better? Testing, testing. Is good? Yeah. Okay. All right. So where was I? I graduated from University of Kansas in 2012, and then or 2008. Sorry, forget my own history. And then in 2012, I got a master's degree in respiratory therapy. And in 2016, I moved my family north to Everett, Washington, which is about 30 minutes north of Seattle. So the Pacific Northwest is a lot of trees, a lot of mountain, rains about 9 months out of the year. I'm probably the only person that came from the United States who was actually happy to see the heat here because it's so wet and damp where I live all the time. I've been involved in the volunteer side of respiratory therapy since 2010 at the local level at Washington State. And then I was the adult acute care section chair for the association. Then I was a board of director. And then I was blessed and honored to be voted as the president of the AARC to serve 2023 and 2024. So it's been an honor to serve the profession in that capacity. And in that role, Jerome Sullivan and Hassan, who were working on the FRCS course, asked me to participate. So I'm very happy to be here. It has been a joy and an honor to meet everyone that I've met on this trip, and I'm sad that I'm, going back home tonight. But I've had an absolute great time, and hope you've enjoyed the course. So that's my introduction.
Thank you very much, Carl. My name is Tariq Jasser. I'm the head of here at King Faisal Specialist Hospital here in Riyadh. I've been a respiratory therapist since 2002. I graduated from my bachelor's degree from University of Kansas in the US, and I worked as a staff therapist mostly in pediatrics and some in neonatal, but my focus area was pediatric medical, pediatric cardiac surgery, post-cardiac surgery with cardiac defects, and of course I worked in the emergency room for pediatric emergencies. And then later I went back to the States around 2012 where I obtained my master's degree from Georgia State University. Came back and continued my work as a, I actually did work a lot, even experiences with many areas in the hospital, became supervisor, then in 2017 I've been the department head of respiratory care. And it's an honor for me again to be here, to meet you guys, and to be with this finest group of expertise from Dr. Khatib. And we thank him a lot actually because taking the lead and help us guide and put together how we are going to conduct this, which is so far it's been a major success. And also thank my colleague Carl for sharing his expertise with us. And more importantly, I thank all of you guys, and I like to always contribute back to this great profession of respiratory, where we can help the future of this profession with you guys practicing, even for others who are practicing, having to practice the respiratory care is something that is very important, and it's one of the things that I always like to do is to be an educator and educate all the time. So thank you.
Okay, well, thank you very much. I want to start by mentioning that none of us participated in authoring the chapter we're going to present to you, but I believe we all listened to a wonderful lecture yesterday by Carl on the topic. So also to indicate that we declare no conflict of interest. We have no conflict of interest, whatever equipment you are seeing here, what we're going to talk about. And basically we're just following exactly what was presented in the chapter in your text. All right? So, Carl?
Okay, first we're going to cover conventional chest physiotherapy. So this was one of the first airway clearance therapies that was developed, very basic. You position the patient in a particular position according to this chart to try and position the patient so that the lobe is draining, right? One deviation that I'll say from this chart versus the textbook is the textbook clearly just says that we do not put patients in the Trendelenburg position because you put them at risk for gastrointestinal reflux. But But that being said, you know, CPT is a therapy where you put the patient into position to where the lobe is draining and then you're applying cupping, right? This is the hand technique. How many of you have actually done this by hand? Okay. I did this in my practice. We did it for 8 minutes, and after 8 minutes, you're pretty tired, you're breaking a sweat, and then you start to develop carpal tunnel syndrome. So I always recommend using a device to do this therapy. So in the United States, they sell something called like a percussion air, which we hook up to our gas source, has a little knob on it, and you twist the knob, it opens up the valve, and it goes, and then you apply that to the patient's area. I usually put a towel over it, and then the textbook says about 30 seconds to a minute, I think, to drain, to percuss the area, and then all that CPT really does is you use the kinetic energy to move the sputum from point A in the lower lobes to point B, which is hopefully near the trachea to where the patient can cough it out, right? So after you do all this percussive therapy, you're always going to have to ask the patient to cough out. Next, we're going to talk about is forced exhalation technique. So this is an exercise where we help patients who have a difficult time coughing to cough out. And so with this one, we're going to have the patient take a deep breath successively until their FRC is really high, and then try and cough out if they have a weak cough. This helps them I've done this when I'm like, if I have a cold, and yeah, you might want to do it. If you're sore and you want to help the patient cough, or you want to help yourself cough. But it is successive deep breaths and then cough out. Another patient population that I think this is a very successful technique to use is patients who have spinal cord injuries or neuromuscular dysfunction, because they also have a hard time taking a deep breath. So they will take a deep breath, but what is different in this particular technique is when we look at the basic mechanisms of a cough, right? We take a deep breath, we bear down, our accessory muscles squeeze the lungs, and then we open up and stuff coughs out. Well, if I have a spinal cord injury or I have a neuromuscular weakness or something, when I get to that point and then I try to bear down, my muscles aren't strong enough to force a strong enough force to get a good cough. So a technique that I could do is and when I get to this point and I cough, I'm going to throw my head in between my knees. Because what I'm doing there is I'm using my belly to compress my lungs and force the sputum out. And I've met and worked with patients who have spinal cord injuries who use this technique very, very effectively. Even the forced exhalation technique, the two combined to help themselves cough and keep themselves clear. For these patient populations, a lot of our patients that have chronic diseases, when we teach them these techniques, we're teaching them a stronger technique than what we would know just by our instincts to help themselves keep their lungs clear. So again, you or all the way up, and then heads between our knees. Next one is sort of the autogenic technique. Is this where we put ourselves into a position where we can kind of drain, where we feel like we can drain the secretions, and then at that point, try and cough them out. Fairly easy, so intuitive, I would say. Now, we covered this at length or somewhat at length yesterday, and you all read your textbooks last night, right? With highlighter and some annotation. You memorized the doses, right? Yep. All right. Well, I'll take your word for it. So expectorants as a reminder. So these are agents that are meant to, if you have really thick tenacious secretions, it's supposed to help you thin them out so that they are easy to cough out. So the way hypertonic saline works and mannitol is that it draws the fluid from the cellular space into the airway space, and then it thins out the secretions. Then we have our mucolytics or classical mucolytics. We have acetylacetylene, which is mucomist, and aerodistine. It smells really bad. What are the hazards of using mucomist? You can cause laryngospasm, bronchospasm if you use it. So these two are usually generally kept with our CF population. And then we have peptide mucolytics that they break down the bonds in the sputum. So we have alpha dornase and timomycin B+. Now, in most of these agents, when we study broad uses of them, the research on this is fairly, unconvincing, I would say, with the exception for cystic fibrosis. In fact, you can probably take any of these techniques that we're doing, and they're probably very effective in the cystic fibrosis population, and then we don't know about the rest of the population because it's too heterogeneous. Then we have our mucoregulatory agents, which would be like our Mucinex and other agents, and then we have our cough clearance promoters, which is our albuterol, our bronchodilators. And how do those agents promote cough, right? If we open the airways up, we can get a bigger breath in, and then we can generate a better cough out. So that's how bronchodilators are effective in coughing, helping our patients cough their sputum out. Then we go through some of our devices, our toys. One that we use in the United States, used abroad actually, for vibratory positive expiratory pressure therapy. We refer to this as the pickle because it looks like an American dill pickle. With this device, it's handheld, and you're going to ask the patient to take a breath and then blow slow and steady out. The device has a valve in it, and what happens is the patient exhales against the valve, and it flaps and then causes percussion, and then when it blows, it goes pop, 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 and causes percussion. So the way I always think about this is I compare it to CPT, right? Chest physiotherapy. So chest physiotherapy was the first one we did, and you're doing external kinetic energy to try and force secretions from lobe to trachea, right? And there's some challenges with that. I'm using external kinetic energy. In the United States, we have a lot of patients who are morbidly obese, and I can pound on their chest wall all I want. The energy is never going to make it to where the lobes are. And it's really sometimes difficult to get the patient into the correct position. Well, these are really nice because all I have to do is have the patient blow, and it causes intrapulmonary percussion. So you get the same effect as you would if you're doing directed CPT as you would as you do with these devices. Now, sometimes I want to be more direct if I have like a right upper lobe collapse where I'm targeting a particular lobe. But for some of our patients who have really chronic hypersecretive diseases, or that they have a lot of thick tenacious secretions everywhere, this is a useful technique for them to use. And again, the technique is take a breath and then blow out. We don't have a physical example today, but it's kind of hard to see here, but on the back of the acapella, there is a dial, and then you turn the dial for the level of intensity for the patient. So usually you adjust it to either less intense or more intense to be more effective for the patient. The more intense, sometimes it's the more difficult for them to blow through if you have an elderly lady who has a hard time generating a long flow. That might be the difficulty there. Next kind of device is the TheraPep. So again, this is what I'll say about why we have so many different devices. Every time a company invents a device that works in a particular way or works, then somebody else wants to invent a different device and then try and tell us it's better than the other device. So we are unbiased in this because no one paid us anything. So all these devices, I think the evidence kind of demonstrates they're pretty equivocal, so you use them for what the patient can be effective for and comfortable with. With this particular device, I'm going to blow through it, and on this there's a riser that's going to come up, and I want the riser to come up between the two hash marks on the window. And this should generate enough force for me coughing that it should help stimulate a cough. And then there's a dial here in the one-way valve that allows me to adjust this from either less intense to more intense. Right? So then my technique is going to be if that's not doing it, then I can adjust it to be more intense. See, works for me. And then another device is the Aerobica. So this is made by Monahan. On this particular device, we have a window here for 1 as less intense and then 5 is more intense. Again, the technique is pretty similar. And so you can kind of hear the flapping of the valve. It's a little bit different on this particular device. There's a chamber system and then the valve. The nice thing about this device is it's designed to go home with the patient and be repeatedly used. It can be thrown in the dishwasher and cleaned. What's also nice about the device, if I can put it back together correctly, is that you can attach a nebulizer to this. So oftentimes we want, before we're doing our airway clearance therapy to generate cough, we're going to deliver our nebulizers first so that the airways are as open as they can be. We do our airway clearance therapy and then cough for the end of the patient. Well, the company that made this designed it so that you could do your nebulizer and your aerobica therapy at the same time. So you're taking your nebulizer in. And one of the reasons they pitched this is I was talking to a leader here, so it sounds like it's a similar challenge here. In the United States, they're always asking us to do more with less. So we're, how less time can you spend with patients? So that makes a nice way to kind of combine those two therapies. Another airway clearance device here, which Tariq has way more experience with than I do because he worked in pediatrics, is the vest. This is the device where you wrap it around the patient's size and then it inflates and percusses. This is really a popular device in the pediatric and the CF population. In my adult critical care world, we would use a wrap, and usually the patient population that I use it in was donor patient populations. Dr. Khadib has had some other experiences with it. But there's basically 3 settings on it. There's the frequency, the speed at which it percusses, and then the volume, how much inflation to the chest, and then there's the time. So you adjust it to the effectiveness of this. So it inflates. And then therapy starts. When I was on the coffee break, I saw a baby bear with one. Just you go turn it on so you can see. If you've never seen it, it's like one of the most popular things at conferences. But a lot of your patients who use this type of device, they will use it for chronic use. This is part of their maintenance package. They may do their mucomist in the morning, get their nebs in, and run this for a couple minutes while they're getting ready for their day and cough up stuff. And they may have a routine where they use this throughout the day. A lot of these airway clearance device techniques that you're going to see are meant for their chronic management of their airway secretions. And now we go probably to one of my favorites, is the cough assist device, now, or sometimes called the mechanical inexsufflator. So in your book, you will read that this device is good for patients with neuromuscular weakness. Now, the clinical indication is 160 liters or less per minute. Now, these are when we think about how is this helpful for these patients, when we think about the regular cough mechanism, this is the concept I want the students and everyone to kind of consider, right? When we think about pulmonary toilet, we have to know the normal system for cough. Patient takes a deep breath, bears down and coughs. If their cough isn't effective, where is the breakdown in that system? Are they too weak to cough out the type of secretions they have? Can we change the type of secretions? Or are they unable to take a deep breath? How do we help them take a deep breath? Or if they're unable to generate enough force to cough. With this particular one, we're addressing they can't generate enough force to have an effective cough chronically. And so how we measure that is we would have a patient take a peak flow meter, take a deep breath, bear down, and then try and cough into the peak flow meter, and that is their peak cough flow. If that value is less than 160, probably an indication for the MIE or cough assist. Now, how the cough assist works is it gives positive pressure and then it gives negative pressure. And we adjust. There's two modes that we can run this on. We can run it on an automatic mode where we just set it and it gives positive pressure and then negative pressure. The technique I'm going to demonstrate for you is the technique that I used when I worked with spinal cord injury patients. So I'm going to use it in manual mode, and I'm going to give 3 successive positive pressure breaths because I'm building up that FRC, and then I'm going to go into the negative pressure mode to help the patient cough. And when it goes into negative pressure mode, it's going to apply a suction that's going to help pull those secretions up to the trachea or the airway.
Any particular pressures?
So we start, I would say start around 20 and then adjust to effectiveness. Now, I don't want to scare anyone here, but we use pretty high pressures when we work with the spinal cord injury population, up to 30, sometimes 40. And the reason we would get away with that is because we were dealing with patients who had fairly healthy lungs, right? It was, their lungs were healthy, it's just that their control for breathing was busted. So we would get away with being able to use some of those high pressures because they would go back to regular mechanical ventilation afterwards, so this is a pretty short period of time. But what we would do, so let's say I have a patient that's, I was doing this for, that's not trached. I would put the mask on them, and then I'm going to 3 breaths, but the time between the breaths is going to be short so they don't go back, so that I slowly increase their FRC. So it's going to be 1001, oh, that's turn on therapy. 1001, 1001, 1001, and then cough, 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 cough. On that third one, I'm going to go straight to cough, and then I want the patient to cough. They'll start coughing, and then I'll take the mask off, and whatever they have up will suction. Frequently, can I have the inline suction catheter? Frequently, some of our spinal cord injury patients would have a trach in place. And what I would do with this case is I would advance this inline suction catheter just to the tip of the trach tube, and then, and keep in mind, these are awake and alert patients. We're always talking to these patients because it's a team effort, right? I have to coordinate this with the patient. So I'd say, hey, okay, ready, Joe, here we go. 1,000, 2, 1,000, 1,000. Okay, ready, cough, 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 cough. And while he's coughing, I'm suctioning, so anything that he's able to cough comes up to the suction catheter and we capture it. And then we may do 2 to 3 rounds of this until the patient says, oh, until we either you're producing nothing on your coughing or the patient's like, yeah, I think we got it all. So that was a fairly effective technique for the spinal cord injury patient population. Another sort of hand technique that which the textbook calls directed cough is pushing on the belly, kind of the same conversation I'm having with the patient. All right, we're going to count to 3. I want you to take a deep breath and cough, and then I'm going to push on their belly. So back when I started into the profession, we called that quad coughing. Has anyone ever done this before? Am I the only one? I'm that old. You've done it. So the therapist that taught me how to do this, it's really, if you've never done it before, it's hard to explain the amount of force you actually need to make this effective. And what the therapist had taught me, and it's kind of funny but not funny, is you want to use enough pressure to bounce the patient's head off the headboard or really move that patient. Because when they say, okay, Joe, on count 3, I want you to take a deep breath and we're going to cough. It's going to be, whew, I'm really going to push that stomach into their chest. Because what I'm doing is I'm taking their abdominal contents and shoving them up into their lung space, trying to force that cough out. And you may think it bothers them, but most of these guys don't have the sensation left anymore to really bother them. So I would have my Yankauer, and we would be having the conversation, then let's take a deep breath, and then cough. There's some things you have to use a lot of force, and then the other thing that you have to keep in mind is you got to have proper body positioning, right? I joke about this because you're actually, when you do it, you're twisting your hips. You're not twisting your torso, you're twisting your hips. I was making a joke earlier with one of the earlier groups. It's like you're doing karate, going, yeah! But you're just pushing your hips. If you don't, then you're going to twist your back. We went through a time at where my one job where respiratory therapists kept throwing their backs out trying to do this technique. And we had to bring PT in to help us do it correctly. And some of the smaller therapists, if they had a big patient in there, they would actually sometimes have to climb into the bed and use both hands to push to spare their back. So that was directed cough. I think I'm good. I hand it over to you now. Do you get the microphone or am I good?
I think I'm okay. Yeah, okay.
All right, thank you. Do you have presentation?
Huh? No. No presentation. All right. Thank you, Carl. So now you've seen the whole airway clearance, particularly the mobilization of the secretions. We talked about how we can move the secretions, move them from their position of being sitting in the alveoli for a little bit of a time. He discussed with you how to thin these secretions, how to break them for certain medications also, if that is the required, depending on the disease. You've seen so many procedures of how to mobilize the secretions, whether it's by the patient themselves, aka autogenic, or by high-frequency chest wall oscillation. That's another way. Also, you've seen how we can assist the cough if the patient is not really moving the cough. Now we will be talking in this station about the suction. And the suction is a common procedure. It's available in all of our practice as a healthcare provider, whether it's physicians, nursing particularly, or even respiratory therapists. It's a procedure that is done for the patients, especially if the patient has an airway, or if the patient has don't have an airway, but they are still have a week of cough, or they need to clear their secretions. So the suctioning, there are always specific types that we will be talking about. Your first element of the suctioning is the source of suction. Okay, in our particular example here, we have the suction machine, which is available here. But of course, in your hospitals, you will have it in the wall outlet. Okay, and those outlets are connected to a big equipment centralized in the hospital. They create major negative pressure. So, but you are using this regulator. Why? Because you need to regulate the pressure. Why do we need to regulate the pressure? Exactly. It's not only for adult and pediatric. Of course, this is for our scope, our daily. But also, you can regulate it based on what you need it. Sometimes they use the suction for something else in the surgeries. So sometimes they will use it for chest tubes. Sometimes they use it they suction not necessarily for secretions, but other things. But the majority of the utilization of suction is done by for like secretions. Okay, so the suction machine here, or the suction outlet in the wall, and the regulation of the pressure, as our colleague here mentioned, you have to evaluate it in your book. You have to understand it for adult how much, for pediatric and for neonatal. You need to know these pressures. The next part is what we call a suction container. Okay, you will see it usually on the wall hanged, but here it's available here as a suction. Okay, again, brands are different, but the function is one. The third part is what we call a suction tubing. Again, it depends. Sometimes there is a purple color of it. Sometimes it's clear. I prefer the clear, so I can see what kind of secretions are coming from the patient. So that is important. And what connects here is the variety of things. Okay, one, as you've seen in the previous discussion, is the Yanker, or the what some textbook can refer to it as oral suction appliance. Yes, and it's known as Yanker, and it connects and basically you suction, and you have it in multiple sizes again for depending on the patient population. When you suction, please be careful not to go too far on the patient, then you may cause gag reflex and maybe vomiting or anything. So you have to be careful about that, and that's the Yanker. The other appliance that used for suction here is, again, one of the most common one is called suction catheter.
Okay, and the suction catheters are, very simple yet extremely important. They are classified as emergency equipment actually because they're important in every emergency setup in any hospital. Okay, and these are very important and comes in sizes, usually referred to as French. Usually the largest one is 16 French, which is used in some large adult patients. But they go down also to almost 6 or 8 French for newborn and pediatric. Usually it's 6, 8, 10, 12, 14, and so on. Okay, so this is the open suction. This is how the things started maybe 50, 60 years ago. And then in the last 20 years, I would say, or plus or minus, because at the beginning of at least my practice, the closed suction system was more of a luxury. We did have a criteria. Not all the patients had it because it was expensive. But now, with the development, this became an important part, which is called closed suction. Some people refer to it as inline. Thank you very much. Yes, that's the other terminology for it. Two terminology are exchangeable. It connects here as regular, and then it connects at the end with two connections. Where do they go? Thank you very much. One goes to the airway, yes, which either tracheostomy or endotracheal tube. One goes to the ventilator, or sometimes oxygen source if it's a tracheostomy, if we are doing the trach piece. Okay, so that is the second. Of course, there is two types of inline. Anybody knows what are they? Short and long. Thank you very much. That's good. Short and long, ATT. We call it short and long, but it's actually labeled as ETT and tracheostomy. Well, what's the difference? The length. Yes. And if you excuse me, this is only the short, but you can imagine the long one would be longer than this. So we cannot use this one on endotracheal tube. Yeah, it will not reach enough. And you can just push in here, you can see it. And then once you reach, you always suction. Okay? These are pretty much, of course, the majority of the suction connections and everything. And as I mentioned to you, you could connect it to the tracheostomy tube instead, and the ventilator goes from here. And this is the connection. Okay? Now, when you are performing the suction itself in the adult patients, you normally, of course, especially if the patient's on the ventilator, we normally do what before the suction procedure? Sorry? Yes, we have to do what we call pre-oxygenate. You go, it depends. It used to be 100% oxygen. Then the neonatal people became very upset because they don't like 100% oxygen. And then it's different schools. Right now, it depends on your hospital specific standard, but it's usually between 30 to 40, up to above what the patient has. Why you want to do this? Because for a brief time, you want to compensate for whatever you are going to cause as a suction and reduce the oxygen on the patients. You don't want to, so you want to give them an appropriate oxygen before you perform the suction. Okay? Of course, before that, you have to make sure that you wear all the necessary equipment. The closed suction system does not require sterile gloves, but regular gloves is enough. Okay? And then you pre-oxygenate the patient, you ensure everything is fine. You can explain the procedure to the patient, and that he will be expecting to cough, because once you do the suction, you will be triggering the patients a little bit. You push the catheter until you hit the resistance, start pressing this, and come out, and you will start seeing the secretions. And then you have to wait for a few minutes, and then assess to see if you need to go back again, and you go. Some practices also can consider instilling saline. Sometimes you can suction, but you can feel like these are thick or tenacious secretions. Maybe you can instill a few drops, maybe 1 to 2 ml of saline to help thin the secretions and help suctioning these, and then you go from there. Some practices they like to give saline, then manual ventilation, or to help mix it up a little bit and break it down. Then these are all some of the practices, and then you go again, and then you suction the patient. We don't like to go very often and a lot. then we can cause trauma to the patient. But your usual guide for this is by auscultations of the patient. Sometimes you can see it in the ventilator screen, and sometimes you can. In certain cases, I guess, especially in pediatrics, I'll speak about that. You can always have a little bit of feeling on the patient, and you can see that, and that's why it's important to assess for breath sounds before you suction, so you can see the benefit of the patient that is going there. So that was suctioning of the patients, of the mechanically ventilated patients. Now, suctioning the patients who is spontaneously breathing is also a practice that is available, yet it's not something that is commonly used. Okay, particularly we're talking about the nasotracheal suctioning, or known as NTS. Nasotracheal suctioning is something, it's been there. It's a little, again, it's kind of a little bit of an invasive procedure, and it uses the open suction catheter. Okay, but for this, that's why it's important to always make sure that you treat this as a sterile procedure, meaning that you have to don your sterile gloves. You have to maintain sterility, okay, and you have a little bit of a small sterile field for you to use it. And then you have to use lubrications. That's why we have the lubricant with us, so you can lubricate the tip. I like to go even a little bit far, the first few centimeters of the catheter. And then you can proceed to go through one of the patient nares. I must mention that it's important when you do this that you clarify the patient's medical situation. And this procedure is usually done, we don't do it as a normal, as a routine procedure, whether from nursing or from respiratory. We always like to have a discussion with the medical doctor, perhaps get an order for that to make sure, because we need to make sure that there is no any bleeding possibilities with the patient. Patient is not on anticoagulant or anything. Also, we want to make sure that the patient is, this is again common in pediatrics, but sometimes you can get some cases with blocked nair, because they're born with a single nair only, because the other one is blocked because of either anatomy or it's just like a choanal atresia, to be specific. These cases you may have to be careful. You can't, because you could puncture the tissue, and that's an issue. So some of these precautionary, I guess you have to take it into consideration, and then you can go and usually follow the anatomy when you go in there until you reach the resistance, you suction, and you come back. Sometimes this is beneficial for certain patients who are not able to suction. And also, some cases, again, it's common in pediatrics more, where they want to obtain a sample. They want to do it for culture, they want to do it for this. So it's always, that's why it's extremely important to ensure the sterile procedure. So you don't contaminate the sample, then could be misleading the result of the patient. And, I think we covered all the suctioning aspects of the patients, and that's all about it. If you have any other questions, or we move to the last station. Thank you.
So now we come to the final part, which is volume expansion. All right, so we come to the volume lung expansion therapy. So there are some what's the objective of lung and volume expansion therapy is basically to establish or re-establish and restore lung volumes and lung capacities. Why? Because we know very well that many of the diseases will impact these capacities and volume. In particular, for example, patients with restrictive lung disease, ARDS, there is a very high risk for atelectatic changes and the loss and the decrease of the functional residual capacity, which has a major impact on oxygenation. We all know that the FRC is our main oxygen store. Other patient population we might face are those who are undergoing procedures, particularly surgeries and long surgeries of long duration. Any surgery that's greater than 2 hours under general anesthesia might expose patients to loss of lung volumes, FRC. And it's often, particularly with the use of high concentration of oxygen, because we tend to denitrogenate the lung and replace it with oxygen. And we know that oxygen diffuses readily in the lung, so the chance for losing the FRC also is increased. And this is why you see many of, or most of the surgeons will prescribe a form of re-expansion therapy for patients post-op, mainly incentive spirometry, right? So that's one simple way of re-establishing these, the FRC. In the old days, I still remember when we had an incentive spirometer that has either, I do remember the Portex in the States. It's just like a spirometer with just one ball, and it has a dial, like 1, 2, 3, 4, 5, 6, which is intended to increase the resistance, so it becomes a bit harder. And obviously, once it's given to the patient and seeing a ball, immediately the patient wants just to start to breathe in this incentive spirometer just to raise the ball, right? And we used to instruct them to keep it as long as you can so you can achieve a volume, because the objective is not just create very high flow and move the ball up. The objective is always to re-expand the lung and re-establish the volumes. There is another type of incentive spirometer which is based on the 3 balls. Have you seen them? Okay. And if you can read it closely on these columns, what do you see? You see units of flow. Okay. It's cc per minute. You see a units of flow. So again, the problem with these are flow directed, so you don't know exactly the volume you are moving inside the lung. Number 2, you tend to do them at very high flow. And when you do at very high flow, when the volume goes inside the lung, one of the very big concern is how we distribute this volume within the lung, right? So it's not like you want it to go to one side of the lung, rather you want it to be as possible as we can, evenly distributed. All right? So the improvement for this, the second generation, were the volume directed incentive spirometer. So this is what I'm holding in my hand, and as you can see right here, you see a unit of volume, mLs, right? And the beauty is, one of the disadvantages of the flow directed is, because this is an incentive spirometer and this is a procedure that the patient will keep doing over and over and over at a certain frequency for a certain duration, you kind of forget what was the last performance of the patient. How did the patient do? Was he able to raise all 3 balls or 2, and the second one at which level it was reached? So there is no way. Once the patient removes the mouth, everything goes back to where it was before. With a volume director, you can have like a marker, an indication. Okay, the patient is doing today 1 ml, tomorrow my target is to go to 150, 1,500, 2,000, so on and so forth. All right? There is also another ball, which the role is basically to do this volume at a certain flow. So you don't do it as a very fast flow or at a very slow flow. And you can see a smiley face in the middle and 2 grumpy faces on the top and below the smiley face. So obviously it becomes easy to tell that I need to rise this to reach my target while maintaining the ball in between with the smiley face. All right? So here you see me, I'm working hard to maintain the ball in the middle with a very good flow, slow flow that will be able to distribute the volume well inside the lung. All right? So usually there are no major disadvantages with these incentive spirometer. It involves a little bit of education for the patient and making sure they are doing it the right way, and probably leave it with the patient, and the patient will be using at the prescribed frequency. All right? Okay, another way that was described in the book, I'm not sure if any of you have used this before or not. It's basically kind of, if you have like a deflated balloon, it's kind of like inflated and maintain it inside, so it like restore the volume. So this is exactly what we're doing with this. As you can see, there is a bag. I can squeeze and deliver a certain volume. There is a one-way valve, okay? So this one-way valve will move the gas in one direction and don't allow the loss of the volume, so the patient will not be able to exhale back and lose what we have moved inside the lung. All right, and like you do like 2 to 3 squeezes as if you are increasing the lung function residual capacity, and then you remove it and the patient just will relax. Honestly, I've never used this, but the author in the textbook described it as one way of re-establishing the functional residual capacity. All right. Now, obviously, this is an approach that would require a clinician to be all the time with the patient. This is not something that the patient can do on her own, but definitively an incentive spirometer can be left with the patient if they are well educated, pain-free at least, and so you'd be able to do it, and they can do it at their pace. All right, but not this, definitively. Another way of re-establishing lung capacities is for patients who are on mechanical ventilation. Okay, and we call this lung recruitment maneuvers. All right, lung recruitment maneuvers are done with the use of a mechanical ventilator, and it's easier to be used or done using pressure-controlled ventilation. Why? Because what we're doing basically with lung recruitment is we're manipulating the level of PEEP. We're increasing the PEEP inside the lung at a certain incremental rate, all right, so that we re-establish the FRC. And we know the direct relationship between PEEP and functional residual capacity. However, the most important aspect and component about lung recruitment ventilation in patients who are lung recruitment maneuvers, in patients who are invasively ventilated, is to set a plan before doing the procedure. The plan should first start with a question is this lung recruitable or not? We cannot just go and perform these recruitment maneuvers on every single patient on the ventilators. Because as you will see, these recruitment maneuvers entitles use a very high level of pressures. Okay? So there are big issue or topic or debate about identifying the lung that's recruitable versus non-recruitable lungs. All right? Recruitment maneuvers works well in lung with high recruitability, and they might be detrimental in lungs with no recruitability. Okay? And this is something, as I said, you have to decide and agree with your attending physician. Number 2 is you want to set to what extent you're going to do this maneuver. Okay? Can we get the screen off and move to the PowerPoint? Okay. Here I'm showing over here the high lung recruitability, where you can see most of the time we're talking about restrictive lung disease, your ARDS patient with diffuse lung diseases, versus another CT of the lung where you just see an area of the lung that's consolidated rather than the disease process affecting the whole lung. So obviously this is a patient who will benefit from a lung recruitment maneuver, and this is a patient who will just be exposed to unnecessarily over-distension of the healthy part of the lung. And we all know what are the problems with over-distension, right? Hemodynamic compromise, barotrauma, risk of barotrauma, although we never see this. What about biotrauma? What's biotrauma?
Biological transfer of bacteria.
So basically, we are triggering release of inflammatory mediators. All right. So even before causing a mechanical injury, before bursting the lung will be over-distended, right? Like if we have a balloon and we're going to just
Doctor has yesterday mentioned about the patient self-injury lung.
Sorry?
The doctor has yesterday mentioned about patient self-injury lung also, like with the high PEEP and high pressure.
Yeah, but this is a little bit of a different mechanism. The silly We call it the SILI. It's self-inflicted lung injury. This is mainly like directly a volume-induced, ventilator-induced lung injury or a ventilation-induced lung injury. But what I'm trying to say that before bursting a balloon, we over-distend the balloon, right? Yes. We overinflate. We go through a period of overinflation. So this overinflation, although it's not causing a mechanical injury, it's not causing a burst, but it will trigger release of inflammatory mediators. So it's very important to set a target where you want to go with this recruitment maneuver, all right? And of course, be at the bedside and making sure you monitor the patient very well so that you terminate the procedure if need be, all right? So there have been so many recommendations to use recruitment maneuvers. Probably the first and the most famous one that started was what we call the 40-40 maneuver, okay? 40 centimeters for 40 seconds. So just patient without any ventilatory support, increase the PEEP to 40, and just look at your watch. After 40 seconds, you break it down, all right? Well, this is there was so many critiques about this for this maneuvers, particularly the duration of 40 seconds. So people were trying to shorten these durations, but they were not getting the same effect and the long sustainable effect of the recruitment maneuvers. There were so many hemodynamic compromises during these maneuvers. So we're looking at another technique, and this was shown to be a very efficient and kind of safer technique than the 40-40, which we call the incremental decremental, right? Because we're going into an incremental phase, and once we reach a certain limit, we start to go down, okay? And it's interestingly enough that many of the modern mechanical ventilators can do this for us automatically. It's just for us to decide our starting point and our end point. And for this, for example, I'm having a starting point. This is a patient who's maintained at a PEEP of 10 centimeters, and I'm ventilating this patient with a pressure control level of 15. Okay? Now, as I said, you can do it with volume-controlled ventilation. I've done it with volume-controlled ventilation. Particularly most of the time, these patients are either heavily sedated or paralyzed. So you don't expect to see a lot of changes in their tidal volume, in their pressure with the volume. But it's always easier and straightforward to use two pressures, because you're going to set your target in terms of pressure. You want to reach a maximum pressure of, for example, in this example, it's 60 centimeter, right? Yeah. Maybe you want to decide, I don't want to go more than 50. So my maximum pressure is going to be 50. Okay, you don't just say, I'm going to use that volume and keep measuring your pressure to make sure that your alveolar pressure is not exceeding 50. All right, so this is the reason we use two pressures. So a baseline PEEP of 10, pressure control of 15, and you just, next step, increase the PEEP from 10 to 20. All right, and you just maintain this. You're always having your frequencies. The patient is being ventilated. There is no concern about CO2. All right, and you maintain this for a couple of minutes, 2 minutes. Then you increase the PEEP by another 5. And as you can see, as you increase the PEEP, obviously your peak alveolar is increasing by the same amount, theoretically, right? Unless there is a sudden overdistension. And so on until you reach the 60, and then you start to go down. All right? Honestly, I've never done a 60. I've never reached a patient 60. I've done 50. I always have my close watch of my hemodynamics, making sure the patient is hemodynamically stable, patient is well with good intravascular volume, so that I don't see any surprises during the procedure. Coming down, you can see that you can stay longer time now because you are coming back from where you wanted to go. You are not as concerned going up as you are coming down. Okay. All right. So this is basically it. Actually, I'm done. These are the procedures. Carl, you want to read? You can read the summaries.
So for a summary of our concepts, we have a wide range
Oh, no, that's fine.
that we use. It's always important to make sure that you are selecting the
So maybe I can ask you a favor.
for the patient.
Maybe if you can take a photo.
Well,
Take a photo again.
and you have to master the operation of the device, teaching of the device, and the last thing I'll say is patient involvement is key with this type of therapy. This is you and the patient working together, communicating constantly as you're educating or assisting the patient through, cough therapy. So thank you. I hope you guys enjoyed the session. And I think it's time to move on.
Thank you.
I have a question
Yeah.
about IS. Is there another alternative? Because sometimes we have a lack of IS in the hospital.
that's important for in trauma world, the C-collar is part of Airway. Okay, you shouldn't have a trauma patient without a C-collar on until you've ruled out an injury. So every patient should come in with the C-collar on, and I think I've been putting it on this one, with the C-collar on, and I'll show you how that affects some of our maneuvers and ways to mitigate that. So that's part of Airway if you're a trauma center. So the next thing you want to do is listen. And again, before you even touch the patient, you can hear if they're talking, do they sound like they're underwater, are they gurgling, is there audible wheezing, stridor, anything like that you can hear before you even listen with your stethoscope. When you listen with your stethoscope, assess for breath sounds. Do they have absence of breath sounds? That would indicate a pneumo or hemothorax. Those are things that you can assess very quickly as well. And then you want to feel, do they have crepitus? Do they have chest wall deformities? What about their trachea? Is it deviated, indicating like a tension pneumothorax? So look, listen, feel, and these things can happen very quickly. You also want to look at just them in general. Are they very large? Do they have a short neck? Do they have a large beard? All of that will increase your difficulty of airway management. So then we'll talk about the basic equipment and maneuvers and move on to advanced. The first to discuss is nasopharyngeal airways. They're flexible rubber catheters that can be used in the conscious patient. Oh, I keep going to the wrong screen. In the conscious patient, because it doesn't hit the epiglottis. So it's supposed to terminate above the epiglottis so it doesn't cause gagging. And then I will say before I switch back over to the video screen, the oropharyngeal airway. Is that you? The oropharyngeal airway we'll talk about as well, larger in caliber and very rigid. And the way that this is placed, you place it upside down and then turn around behind the tongue to pull. Do you mind getting that again, Afnan? To pull that tongue forward, okay? And this can be only used in the unconscious patient because it will induce gagging. So I'll show you both of these on the actual mannequin, and we won't go back to the slides. So we have our nasopharyngeal airway. Just goes in like this. Okay, and then you can bag or do other maneuvers. That one's pretty easy to place. Oropharyngeal, you put in upside down and then flip it around. Okay? For both of these, you want to use the appropriate size for the patient. For the nasopharyngeal, it's the edge of the nose to the pinna of the ear. That's about the length that you want. And then you also want it to be about the same patient's pinky size. That's how big. And then for the oropharyngeal, side of the lips to the pinna of the ear. That's how you see if that is the appropriate length for that patient. Now these both can and should be used with other basic airway maneuvers. Head tilt chin lift is an option if you do not have a suspected C-spine injury. It's very easy. Hand on the forehead, and then fingers on the chin, the bony prominence. And then, so if they are completely supine, you end up putting them in sniffing position this way. That helps open up that oropharynx. Not an option in the C-spine patient. However, the jaw thrust can be used. Again, you want to use the bony prominences of the face to help maneuver the mandible because A, that will structurally lift all that soft tissue off the oropharynx, and also you don't want to cause damage on the soft tissue. So find the angle of the mandible. You can feel it on yourself if you want. And all you do is jut that chin up to the sky. And that really helps pull that soft tissue out of the oropharynx. Okay? And as you can see on the patient in the C-collar, it's totally fine. You don't move the C-spine at all. Okay? So again, these maneuvers can and should be used in conjunction with our oro and nasopharyngeal airways. And I've modified it for suspected C-spine injury versus not. Okay, so I think we will discuss now a couple case scenarios to kind of help bring it all together. Let me pull it up. All right. So you are at the grocery store and suddenly a woman next to you collapses. You can see that she is unconscious and not awake. She does have a pulse, but she seems to be struggling to breathe. You ask an employee to call for medical help. What can you do while waiting for help? A, intubation. B, chest compressions. C, head tilt chin lift. Excellent. Now, that's a very simple question and pretty basic, and it seems pretty easy, and it is. But the reason that I ask that question is because these basic maneuvers are often forgotten about in emergency situations, and they can be performed in the ICU or in the grocery store, right? Just doing a simple jaw lift on someone can open up their oropharynx. If they're spontaneously breathing, then you can take a situation that could be very dangerous if they have no patency of their airway, and simply all you're doing is this. So in the grocery store, in the ICU, in the PACU, wherever you may be, they're simple maneuvers that can and should be used and not forgotten about. So that's, they are important even though they seem kind of easy. So that's just to highlight that kind of aspect of these basic maneuvers that folks will often forget. I'll see people bag masking people without an oral airway. They have got a seal, but it's not going anywhere because they can't get down the oral pharynx, right? So simply a jaw thrust or an oropharyngeal airway will help you allow to bag that patient. All right, last case scenario for my section. You are in the hospital and a patient is somewhat confused and oxygen saturations are 83%. You're a respiratory intern, it's your very first day on the job, and you're alone with that patient right now. He is very obese, he has a large beard, he's already on oxygen via nasal cannula. You have called for the physician and or intubating team. What maneuvers can you perform while you're awaiting help? A, bag masking with a nasopharyngeal airway. B, jaw thrust, or C, place an LMA. Jaw thrust is right. Is that the only right one?
I think
A is also correct. And C could be correct. So A was bag masking with a nasopharyngeal airway. Why nasopharyngeal?
He is awake.
Thank you. Very good. So you can do that while you're waiting. I mean, his sats are 83, so you're not really in a great spot. You know that they're a difficult airway. They're large. They have a beard. So that will, in theory, help buy you some time. The jaw thrust also will help. In theory, you could place an LMA and bag through that.
If you are doing too much. If you are doing the LMA or...
Right. I was going to say, in theory, you can do that if your team is taking a little too long to get there and the patient isn't doing well. So, yes, exactly. And so that leads into our next section. Dr. Al-Ramai will take over. Thank you. And I think this is for you.
Okay. If you could grab your phones and scan the barcode, please. We'll start with a case. See that there's 2 answers only. Let's see that majority of the answers. Great, so majority of the answers goes for place and oropharyngeal airways and bag mask ventilation. Let's go for the next picture. So I would like to know what is the differences between the first picture and the second part of the pictures, the other two pictures. EC technique.
You don't have a
To the screw.
along your bagging.
Yes.
And there's somebody who's doing conversion.
That's
So
great.
this is the CE technique.
Great. And the other one? Two hands. Yes, so probably yes, this is the one hand technique and that one is the two hand techniques to do. So from here we'll go for the technique of performing the ambu bagging. So most of the ambu bag tubes or ambu bags in general, so the ambu bag is mainly is a self-inflating bag here with the reservoir. The reservoir here also to maintain extra oxygenation. Also the PEEP valve here to maintain an additional extra oxygenation, and that is connected to the tube. Masks here, and we usually use the ambu bags or the bag mask ventilation is for maintaining an apneic patient or if the patient's tidal volume is insufficient. So the first thing we want to maintain the airways, however. Maintaining the airways, as what Dr. Rachel just told us, we have to make sure if the patient has any kind of spinal injuries or not. Assuming that this patient has no spinal injury, we will extend the neck to maintain an open airways. And then for the one-hand technique, first, the apex of the mask goes in the bridge of the nose. The lower part goes just beneath the lower lip. So placing it here, the E is here, and then the C, is here, and the E is on the bony prominences. So, and then you started with a very good seal, and you start to bag your patients. Coming for the second one, which is the two hands technique, we're using the two hands. So you can use your two hands like this, and then your E is here, or you can use your thumbs like this, and E is here. So when you're trying to ventilate your patient, you want to maintain ventilation and oxygenation. So you want to maintain ventilation, but you do not want to have hyperventilation. That's a risk of aspiration. How do we maintain this? Maintaining an adequate seal first, maintaining a very good tidal volumes that is given, maintaining a good rate, 10 to 12 breaths per minute, and so on to maintain for the patient good oxygenation. Okay. Another slide, another case, please. Okay, 20, fair enough. So yes, place an LMA and attempt to bag masking the ventilation with the LMA in place. So whenever you cannot maintain adequate ventilation or oxygenation with the bag mask ventilation, it's the time to switch to an advanced airways. What kind of advanced airways we could use? One of them is the LMA. The LMA tubes, as you can see, it has a tube and then it has some inflating bag. It's really easy to be inserted. It doesn't need any visualization. You can insert it very quickly and without having any visualization added to this. And it's very quick. You can maintain ventilation for a period of time. So the first thing, you want to deflate your cuff. You don't want to go there and your cuff is inflated to injure any kind of the airways. Then you want to add some gel You don't add it at this part to block the airways. You add it only in the outer part. You want to open the airways. Open again the airways from here, and then insert it blindly. You insert it until you feel resistance. When you feel resistance, that's the side that you're supposed to be in. And then inflate your cuff. After inflating your cuff, it's time to ventilate either by your ambo bag or by the mechanical ventilator. Now you have to take consideration when you're placing the mechanical ventilators, high pressures, because it might affect the delivery of gases and air to the patients. How can we choose the appropriate size for the patients? Each LMA comes with a size here, and what is the weight, suggested weight to be used with the patient, in addition to the LMLs that can be used with that patients, or with that LMA. There is another type of this LMA, which is the gel LMA. You don't need to inflate any cuff. You just go directly and it is gel. Okay, coming back to here. I did something wrong. In this part, I want you to memorize the location of each equipment. Have 1 minute or less? Just see the equipment and where it's located in the slide. Good to go? Okay. Let's start. 1, cuff manometer, that's true. 2, silent. 3, great. 4, there's which one? The Macintosh, yes. 5, tube. 6, nope. Tie, this tie. What about 7? 8, stethoscope. 9, gel. 10, CO2 detector. What about 11? Miller, that's true. Last one, syringe. So all these are the equipments for intubation. Whenever you want to intubate the patient, you're probably going to need all these equipments. What is the differences between the Miller and the Macintosh is the blade. So you can see here in the Macintosh, blades are curved. Whenever the Miller here is straight forward, these things. There's several types that could support for the laryngoscopes. The laryngoscopes comes like, for example, for this type, it comes with a full light all over. And there is another types of laryngoscopes, as you can see here, which Dr. Keith will talk about, is the video laryngoscopes. And all these supports in intubation. Bougie and stylets, as you can see, it's also helping either changing the tube or supporting the tube. And we can see here, inflating the cuffs comes either by the cuff manometer, and then you measure your cuff and monitor your cuff pressures. Also, or either you can inflate it just by the syringes. Then you could stabilize, or let's say confirm, the patient's position of the endotracheal tubes by the CO2 detectors or the stethoscope. During the procedure, you're going to need the gel also to facilitate the insertion of the tube. Ambo bag going to be needed all over before and after the procedure. Do you know which color it has supposed to be changed from which one? Yellow, it's the purple to yellow. That's correct. That's for me, from my section. I think Dr. Keith will continue from here. Oh.
It's still morning. Good morning. So a lot of stuff to cover in a short period of time. So let's assume that the ICU team, including you and whomever, has decided that the patient needs to be intubated. Now, sometimes this is emergent, and it has to all sort of happen pretty quickly, but preferably you have time to get appropriately prepared. So what does that mean? So you've decided to intubate the patient. If I have time, I really like to look in the chart and see if I can find a note from a provider that's intubated this patient before. Because if I find an anesthesia, one of my anesthesia friends who has intubated this patient before, and they're very experienced, and they say they were grade 4, and they were difficult to mask ventilate, and we had to do this, we had to do that, we had to call Dr. Sullivan to get her scalpel and come over and get ready to do a surgical airway, then my approach to that airway management will be different than it will be if I intubated this person before, I extubated them in a straightforward intubation. I still worry about things, but I probably worry less if I had intubated them before. That said, then you decide what your approach is. Dr. Sullivan talked yesterday during her lecture about medication selection and whether or not you want to do a rapid sequence induction / intubation, or if you want to do an awake intubation, and what kind of pharmacology that you're going to use. That's been decided. And then you need to decide what sort of approach you're going to take in terms of what equipment to use. So Dr. Afnan talked about the Macintosh blade. The Macintosh blade is used and placed in the vallecula and lifts up anatomical structures so that you can get a good view of the glottis. The Miller blade, I've done almost 4,000 adult intubations, and I've used the Miller blade maybe 8 or 10 times overall. And the times I have used them, they've been in people with really high BMI that have a lot of redundant soft tissue, laryngeal soft tissue. And so I might anticipate that it'd be easier to get up under the epiglottis and lift everything up that way for a better view. That being said, since the advent of the video laryngoscope, I would probably go straight to that instead of the Miller blade, right? So you have direct laryngoscopy, you have video laryngoscopy. Video laryngoscopy in the literature, if you look at the literature, supports that there's a higher first attempt success rate for intubation and a longer time to desaturation if you use the video laryngoscope. So I recommend that if you have it available to you, that you use the video laryngoscope all the time, but you stay really proficient at using this, because you're going to find yourself at 3 o'clock in the morning getting called to do an emergent intubation, and that's going to be on the other side of the hospital, and you're going to have an airway box with this in it, and you need to be able to use this, okay, because you might not have that available to you. But if you do have it available, do that. Pre-oxygenation, some different ways of doing that. If you have an LMA that's placed, then you're going to exchange that for an ET tube. Then you can pre-oxygenate through the LMA. You can use non-invasive ventilation. If the person's spontaneously breathing, then that's a really good way of pre-oxygenating somebody. There's some literature that supports that. And even a high-flow nasal cannula. I really like to use a high-flow nasal cannula to pre-oxygenate somebody. It's particularly convenient if the person's already on it, right? If somebody's on it, they're in hypoxemic respiratory failure. You have them on the high-flow nasal cannula, you turn it up to 100%, you give them a few minutes, you get your act together, you get your partners in there, get ready to intubate the patient, and that's probably just as good at pre-oxygenating somebody as anything else. So, pre-oxygenation, you've decided what way you're going to approach, you've got your medication plan, you need a team, right? You can't do all of this by yourself. At least you don't want to have to do all this by yourself. You need somebody that's going to monitor vital signs and tell you if something's going wrong up there. You need somebody that can push medicine through the venous access when you ask them to. And you need somebody, you really need 2 more hands sometimes, or most of the time, to actually do the intubation. Right? So you have the person doing the procedure, and then you have somebody helping you, hand you the tools. So let's say that we don't have a video laryngoscope right now, and we decided we're just going to intubate the patient via direct laryngoscopy, and we've already style it. Thank you. We've already got our medicine. Now, if you're doing an RSI, a rapid sequence induction / intubation, then you're going to want to be completely prepared before you ask the person to push the paralytic, right? So you do that, you have them pre-oxygenated, you go in with you decide to use the person's normal body habitus, you don't anticipate any problems, so you grab a regular Macintosh laryngoscope, you go in and you sweep the tongue, you start out to the right, sweep the tongue over. This patient keeps trying to leave. Can you just hold that down right there? Every time. So I have a really good view, but the patient's trying to leave. Okay. So you have them intubated. Now the next step is to confirm that you have appropriately intubated the patient. The number one way to confirm that you have put the endotracheal tube in the trachea is to see it, right? To see it. You saw the ET tube go through the vocal cords, right? Just you watch it go through. Now, if that's not 100% accurate though, right? You think you saw it go through, and you're pretty confident that it went through, but things happen. So maybe it bounced off of something and at the last second went into the esophagus. So you pull the stylet out, you put the capnograph on there, and then you give the patient, so your partner would auscultate the epigastrum. I recommend that you listen to above the stomach first because you can hear transmitted breath sounds from the esophagus. If you listen to the chest first, you're going to hear something if it's in the esophagus, right? If it's in the trachea, you're not going to hear anything over the epigastrum. So I recommend, and I teach this way, that the first thing you do is listen above the stomach. One nice, yes. One slow breath, and then your partner is going to listen to the breath sounds to make sure that you hear breath sounds, and if you hear them greater than, that you have equal breath sounds. Now, depending upon the pathology or the trauma, you might not hear breath sounds on both sides because they have a big pneumothorax or something on one side, right? So, but you do what you can do. So you saw it go through the cords. You listen to epigastric sounds. You listen to bilateral mid-axillary breath sounds. You use the easy cap. This should be purple when it comes out of the little foil packet, and then it should turn yellow if there's CO2 that's coming back through there. That being said, there have been times where people are fooled by that because if somebody just had lunch, they may have had a Coke and they may have some carbon dioxide in their stomach, and you can get a yellow change even though it's not in the airway. It's not sustained, but it can be just enough to make you think about it, right? So you see end-tidal CO2, you've listened to breath sounds, you're confident that the ET tube is in the trachea, you can now transfer it over to the ventilator before or after you secure it. It's your preference. I like to secure it first before I do anything else. And you put them on the ventilator. Okay, so that's direct laryngoscopy. Now let's decide that you're intubating one of Dr. Sullivan's trauma patients that's in that potentially has a neck injury. You can't manipulate the neck. Yes, let's do video. Is that okay?
Yeah, on this guy.
I really like to use this guy because he's easier to intubate. Okay. By the way, intubating real people is normally a lot easier than intubating any of these things.
So I'll demonstrate how you're supposed to take the C collar off on this guy because it actually has a neck. because you do need a separate provider to provide inline C-spine mobilization when you have a suspected C-spine injury. So you want to use the bony prominences again of the patient's head, the last two fingers kind of on their occiput, part of the hand next to the ear, and then the fingers kind of down the neck. So occiput, ear, neck, and you want to provide inline stabilization here, okay? It doesn't allow any, you can't move the neck around, but you at least allow a little bit of play. So you'll keep the C-collar on until the patient's paralyzed, because that way they won't flail around or anything. And when it's taken off, it is your job and your job only to hold this until you personally put the C-collar back on. So we will pretend over here, this one doesn't have a neck, but I'll pretend to continue holding inline C-spine stabilization.
If you're familiar with the glide scope, you know that it has a really exaggerated curve on it, right? And that's so that it can get in there and give you a better view. You're more likely to get a better view with this than you would a regular Macintosh blade. That being said, you also need to have a rigid stylet. I recommend that you use this. Some people like to just kind of go rogue and put a regular stylet in here, but it really needs to be directed and rigid for this to work appropriately. You also really need to use the handle that's on the end of this thing. If you try to manipulate this, because it's so rigid, if you try to manipulate this by just holding the ET tube, you're less likely to have good control of the endotracheal tube. Sorry, thank you so much. So first thing, just like you're intubating anybody else, you'll get in there and you'll get underneath the tongue. All right. Sometimes you go too far in and you pull the epiglottis up and you don't. See, I almost broke my own rule here. So sorry. We're going to need a surgeon over here.
Just leave that for now.
Okay.
I'm still holding C-spine
Yep.
stabilization.
Yeah, thankfully. And then you do the same procedure that you would do any other type of intubation, right? Confirm intubation. Even though you had a better view and you saw the ET tube coming out of the trachea, through the side wall of the trachea, you still need to go through your confirmation process, okay?
And I continue to hold C-spine stabilization until it's confirmed.
And then
collar goes back on, and then tube should then be secured as well.
Yep.
Okay.
Mm-hmm. Yep. You want to do should we do this still?
Oh,
do we have time?
We have time briefly.
If I hurry? Yeah.
Yep, we have time briefly.
Okay. Okay, so do we have that syringe still? Yeah. Here's one right here. So let's say you've decided to use a bronchoscope. There's clinical scenarios where this might be beneficial, particularly if you don't want to poke the ET tube through the side of the trachea, or if you can't manipulate the airway, you can't move anything, then this may be a better approach. Then you would go in until you see. You see that anatomy right there? Can you see it? So the procedure would be, I don't want to injure this guy any more than I already have. The procedure would be to go ahead and advance the bronchoscope through the glottis, just like you would the ET tube. And once you have the bronchoscope through the glottis, then just feed the ET tube over the bronchoscope. Right. So extubation. Again, team approach. The team has decided that the patient's appropriate for extubation. Sometimes that only takes a few minutes. Sometimes that's a bigger, longer process. Spontaneous awakening trial, spontaneous breathing trial, whatever the standard practice is where you are, and you've decided to extubate. You should have everything that you need to re-intubate the patient close by. You should make sure that you have a bag valve mask, especially the mask. You can't use the bag without the mask. Intubation equipment, if the person was a difficult intubation the first time, and it may benefit you to get your whole team there for extubation. I will tell you, most extubations I do, it's me and the nurse, right? So, but if you anticipate a problem, then I would get more people in there to be ready. You talk to the patient, you make sure the sedation's off, unless you're using like Precedex or something to sort of transition to extubation. Of course, we can extubate people on that drug, but make sure they're not getting anything that's going to make them sleepy or not breathe. Sit them up if you can. A lot of trauma patients, you can't sit up in the middle, you can't bend in the middle, so you just have to do reverse Trendelenburg and get their head above their feet some. You talk to them, tell them what you're going to do. Suction the airway out, the above airway out, suction through the endotracheal tube. I usually, when I'm ready to go and I have everything unsecured and I have a syringe attached to it, I'll reach over real quick and just turn the ventilator off or put it in standby so that it doesn't blow air all over the room and snot. And then I tell the patient what I'm going to do. And I take the air out of the cuff. I tell them to take a big deep breath in. I pull the ET tube out. You don't want to pull the ET tube out while they're coughing, because what do their vocal cords do when they cough? They do this, right? And you don't want that to hold on to the ET tube and cause trauma to the glottis. And then once the ET tube's out, then I just do a quick assessment. I ask them to tell me their name so I can hear their voice, make sure that they don't have so much edema, upper airway edema, that they can't talk. And then evaluate them for a couple of minutes, just watch them, and then that's sort of it. One of the most important things, though, is to really just be ready for anything, right? Because anything happens when you expect it the least, oftentimes. So be ready for that.
Intubation box.
Yes.
Intubation box.
Yes, yeah. Should be nearby.
Yeah.
All right, and so we are going to talk about trachs just a little bit. Do you want to get your presentation ready to go? If you cannot be ventilated from the ventilator, usually 7 to 10 days, or sometimes in an elective situation, or sometimes airway emergency situations, we'll need to do a tracheostomy. We have a rep here to talk about that, but I just kind of want to go over the equipment itself. While she's getting set up.
Yes, sorry.
No problem. So you can see this doesn't fit, the curvature doesn't fit, but it will go into the trachea here. And if you remember from my lecture yesterday, it's below the vocal cord, so it's much less irritating to the patient. You get it in, you blow your balloon up, just like all of the other tubes we've seen. Gotta push this harder. Pilot balloon, you blow this up, goes to all the trachea. You've got your phalange here. That's against the patient's skin. You can either sew that in, generally we do when we do them fresh, or have the trach collar on, and then they just sit in the patient's airway like that. So we'll give you about 5 minutes to talk about the products.
Okay.
And, then we'll have a few minutes for questions.
Yes. So hi everybody, I'm from Arabian Trade House. We have a booth over here, and please feel free to come and ask more questions or have some hands-on, okay? I just run through our portfolio, which we offer here in Saudi Arabia. So we do have a percutaneous dilation tracheostomy set with all relevant components for the Chalia technique to dilate open the tracheostoma. We do have 3 different tube lines with various types of tracheostomy tubes to use as primary tubes with pre-mounted on a minimally traumatic inserter. So this is a Vario, this is a Twist, and this is a Twist Plus line. So you see we have various primary tubes available. Then we have the Vario tubes, more in detail. It's a single lumen tube. We do offer that in 2 different lengths, so in standard and extra long, and it has a very nice adjustable neck flange, which you can adjust along the tube. So when you have patients, for example, burn patients or something with lots of inflammation, you could adjust it after the inflammation went down. We do offer those tubes with a spiral reinforcement to have a stable but flexible tube. We do have them also in transparent with and without cuff, as well as 2 tubes with a subglottic suction line, integrated subglottic suction line, the Vario extract tubes. With a twist line, it's a different material. We can have a much better inner-outer diameter ratio. So you have a big lumen and at the same time a small outer diameter. We offer those tubes from size 4 up to 10 in 1 millimeter increments with a double swivel neck flange. We do have 6 different types, 4 standard types with and without cuff, with and without fenestration, as well 2 twist extract tubes with subglottic suction channel. Then we do have our latest tube is the Twist Plus. Twist Plus is a little bit longer than the Twist tube. The Twist Plus, because of the longer length, we offer only in sizes 7 up to 10, so only the adult tubes. It has an even better inner-outer diameter ratio because it's an even thinner material. So yeah. We do offer also the 4 standard types, as mentioned before, as well as 2 Twist Plus extract tubes with subglottic suction channel. It's an innovative suction channel. Then we do have a pediatric tube or kids tubes in neonatal and pediatric sizes and length. The Silcosoft, the Traco Silcosoft, is made out of silicone. It has an nitinol spiral reinforcement. It's a single lumen tube, of course. It's a pediatric tube. We do offer those tubes from size 2.5 and half millimeter increments in both lines, and we have different types, 4 different types in standard with a proximal longer because you have no to bridge that, as well as tubes with an H2O cuff. In this case, the cuff material is also silicone, and then you should use another medium than air. You should use sterile water to block the cuff because it has bigger pores and will not hold the cuff, the air in the cuff. Then we do have a range of heat and moisture exchanges to have a good pulmonary climate. We do have one T-shaped one, which an option for an oxygen port. Its medium is paper coated with calcium chloride to keep more moisture and heat in the material. Then we do have one which you attach also to the 50 millimeter connector with an integrated oxygen port. Medium is foam, also with calcium chloride. It has a very nice feature here. It has an opening here. You can additionally suction the patient off without taking the HME off, which is at the same time pressure relief when the patient is coughing, so it's not popping off. And this is the same idea with this one. And here you have, in addition, actually, you can press down this part, and so the patient could voice. And we do have also a variety of one-way speaking valves. So I give back. Thank you. Please come and visit us. Thank you.
Thank you. Yes. All right. Do you have any questions? We have about 5 minutes for questions.
No questions?
All right. We did a great job.
Thank you.
Okay. Thank you. Thank you so much for coming.
Thank you. Thank you. Yes, thank you. Thank you for your help and have safe travels. Yes, of course. This is position.
Sure. So let's go ahead and get started. There's very busy afternoon. This is your first of 4 stations, and we need to stay on time. In this workshop, I will begin for about 15 minutes, and then I will pass to Ahmed for 15 minutes, Jabir for 15 minutes, and we would like this to be very interactive. So I will ask questions of you, and you should ask questions of us as well. So I suspect that all of you have some experience with non-invasive, correct? So you know a little bit about the subject, so we can have an open discussion about non-invasive ventilation and high-flow nasal cannula. So let's begin this way. So let's say that you have presented to you a patient with COPD exacerbation. Do we all agree that we will try non-invasive ventilation? Yes. So no debate, right? That's why this is the non-invasive ventilation session. So what interface, what mask will you choose? So we have different styles here that you can see, and there may be others that you're familiar with. Which is going to be your first choice of a mask?
Face mask.
So nose and mouth? Just nose? Nose and mouth. Why nose and mouth?
To make sure there is efficient delivery of pressure.
So in patients with acute respiratory failure, my experience is, and I think I'm hearing your experiences, mouth leak can be very common. It can be a big problem. So there'd be a big leak through the mask, so how we can get around that problem is to have an interface that fits over the nose and the mask. So this one, for example, right? So how do you decide how large it should be?
It's a ruler. It's a special ruler to measure the sizing.
Yeah, so you can measure, you can be fancy, but you want the mask to go here to here? No. So maybe over the bridge of the nose, maybe right where the cartilage and the bone meets. And depending upon the mask, there are some that are designed to go under the chin, but most of them go on the chin, right? Yeah. So it's like this, as you were pointing out. So we use a mask like this. So let me ask you, so you see this flapper here? Yeah. What's that for? Anti-asphyxia valve. So this is not for exhalation. Yeah. This is in case the hose comes off, then the patient can breathe through here. Yeah. So when we apply flow and pressure from the hose, this goes up and it should remain closed. But if the hose comes loose, the patient can breathe through here rather than having to breathe through the mask or through the hose and rebreathing carbon dioxide. Okay, so then how does the patient exhale? So with this mask, how does the patient exhale? So the breath will come in here. Yes, sir.
We are using with the ventilator, we use dual limb. So the inhalation and exhalation coming from the ventilator.
Okay, so if it's a dual limb ICU ventilator, the patient would exhale through the exhalation hose. Let's say that it is a single limb like this.
So we
need a leak port, right? Yeah. So we could use a mask that has the leak in the mask, or we could use, and this one has no leak in the mask, so we need to put a leak port here. Otherwise, the patient will not be able to clear carbon dioxide, to exhale carbon dioxide. So this might, by itself, might work well with an ICU ventilator, as you were suggesting, but if you were to use it with a single limb ventilator, we'd have to put some type of a leak port here. Okay? Anything you would like to add about this? Any? Okay. So, do you like to use this for humidification?
No.
Why not?
Because there is no maintain.
The patient will exhale before he reach the patient.
It will increase the leak as well.
Will increase the, should not increase the leak, but it adds dead space, right? So it'll add some dead space. I don't know what the dead space of this one is, but it will add some dead space.
Okay.
Now, what if we used, I was looking for the mask with the leak in the mask, but we can just, this one? So what if we use, so I may need your help with this one, or not. There we go. So this one has the leak here in the mask. So will this be very effective? Will this work?
No.
If the patient's breathing in from the hose, if they're exhaling here, this cannot work at all, right? Because in order for this to work, patient has to inhale and exhale in both directions through this, which would happen with an endotracheal tube, for example, but not with a mask like this. Okay, so let's think about what kind of settings will we place on the machine. So let's say we'll use a machine like this. Looks like this. So what kind of settings do you want to put on the machine? 30/5? What kind of settings? To begin. The patient's never used this before.
So first we need to know what's the appropriate tidal volume for the patient.
Okay, so what is an appropriate tidal volume?
So we need to do our equation.
Yeah.
So that we have a target tidal volume. Then from that point, we will start our pressure.
Okay, so you will target, so let's say that I am 70 kilograms. What will be your target tidal volume for me?
70 kilograms?
Yes.
So I'll just calculate it.
You could do it in your head. Around 400, 420, something like that. Do you monitor tidal volume here?
No.
Yes, so she does. So we can monitor the tidal volume, but we're going to have to set the pressure, right? So how much pressure do you want to set?
We can start very low to make the patient comfort, as you mentioned yesterday. To start with anything above the pressure support of nothing. Then we can increase until we reach that target tidal volume.
I agree completely. So we may start with 8/5 or 8/4 or something like that, so that the patient can get used to having the mask and the pressure and so forth. And then we can fit the mask and take care of leaks. And then we can gradually increase our pressure to our target tidal volume. Okay, how much? So we can increase our pressure support, our IPAP, till we get the tidal volume that we want. So I agree with that approach. How do you set the expiratory pressure, the EPAP? How would you decide how much?
It's on the X-ray.
Pardon?
X-ray.
Yeah, we don't have time for an X-ray. I'm being difficult.
Yeah.
If he has an oxygenation issue.
So maybe if there's an oxygenation issue. So maybe if it's cardiogenic pulmonary edema, I might use higher PEEP because there I want to increase the intrathoracic pressure to help with the left heart failure and so forth. What about with COPD?
High EPAP.
No, we don't use high PEEP. No need for high PEEP.
There may or may not be a need for a higher level of PEEP, but sometimes there is. because the patient may have auto-PEEP if they have COPD. And with auto-PEEP, they may have trouble triggering the ventilator. So then we can increase the EPAP so that it makes it easier for the patient to trigger the ventilator, just as we would if the patient was to be intubated. So now we...
To improve the gas exchange.
Correct, to improve gas exchange. So now we increase the EPAP, so we have an EPAP of 4 here now, and an IPAP of 10. So what do we have to remember if we increase the EPAP? You have to also increase the IPAP, right? So if you increase the EPAP from 4 to 8, and you keep the IPAP at 10, you decrease the level of pressure support, right? Okay, one more thing, and then I'll turn it over to my colleague.
4 minutes.
So your patient is, so you start non-invasive ventilation. The patient's gas exchange is improving. Patient's respiratory rate is improving. But the patient says, I don't like it. Please take it off. And you say, but I'm the respiratory therapist. I know this is working. They said, just take it off. So what can you do about that? You ever have a patient like that? Always. So what can you do? What are...
Maybe I can alternate him with the high flow.
Exactly. So you're going to hear more about high flow later, but what you can do is you can alternate with high flow. So you can say, I understand, this is difficult. It is helping you, but it's difficult. So let's take a break and we will put you on this other therapy for maybe 1 hour or 2 hours, and then we'll come back and try the mask again. Okay? So I am starting to talk too much, so Ahmed, I'm going to let you talk for a little bit.
Thank you. Thank you. Okay, have a seat, please.
I'll be happy to have a seat.
In fact, I don't know what you would like to know about non-invasive ventilation for sleep disorders. It's different from acute respiratory failure. Patients are not.
Oh, I'm sorry.
So patients.
They want to hear. They want to hear you.
Okay, thank you.
Let them hear you.
Yeah. Okay. So patients are not apprehended. They are not in distress because of respiratory failure, and also the team, they are not under stress because patient is desaturating. They want to avoid intubation. So you have all the time to manage and try this and try that. So it's to some extent easier than acute respiratory failure. But the problem that in acute respiratory failure, you use it only for a short time, so you can push the patient. But now you want them to use it for a long time. And this is the problem. When you use it for a long time, you go to the problem of adherence. So they put some points here. Probably you can ask me anytime if you like to ask. But when we talk about sleep disorder breathing, who are ambulatory, stable, we talk mainly about obstructive sleep apnea. Or we may talk about central sleep apnea or obesity hypoventilation. Obesity hypoventilation, you have to remember that they may present with acute and chronic respiratory failure. So they may come with hypercapnic respiratory failure and admitted to the ICU. If they come with that, again, they are not in distress as patient with, for example, pneumonia. Who will come with pneumonia or asthma or in severe distress. No, these are not. They may be more sleepy. But when you check their saturation and blood gases, they really look miserable. So these patients are different from ambulatory. For that group of patients, again, we like to use the full face mask. But for patients with ambulatory sleep disorder breathing, what we like to use, number one, our first choice is the nasal mask. Why is that? Many advantages. First of all, it is less claustrophobic. Number two, you are likely to require less pressure. And you have in your book, I put the same patient on oronasal mask and nasal mask, same patient. You see that they require less pressure. It's again because what we discussed yesterday
of the Starling resistor concept. So nasal mask is our choice here, even if the patient is mouth breather during sleep. We start with the nasal mask. Because all patients, when their airway becomes narrow, they open their mouth. So they become mouth breather. As long as they don't have nasal blockage or blockade when they are awake, they can breathe with the nose, then our first choice is always to go with the nasal mask. It has advantages and disadvantages. The advantages, we said, less pressure, less claustrophobia, and it's more of natural breathing because we breathe with the nose, not like patients in air hunger who have acute respiratory failure. The disadvantage is that they may open their mouth when they go to sleep, and then they start to have mouth leak. So how do you know for that? When you do the titration, whether you do it in the lab or you give them auto CPAP at home, then you have to see the report. Like some of the reports here, you can see if they have leak, and you can see other things we'll discuss if we have time, but you will see also like if they have air leak, significant air leak. And we'll talk sometime about like some details about air leak. You are likely to have air leak if you require higher pressure. The higher pressure you go, the more that they will probably open their mouth. Because in patients who have intact anatomy of the upper airway, the soft palate and uvula usually will seal over the tank. So the tank is like this, uvula, it will seal, so it will come through the nose. However, when the pressure is high, it will give away at one stage. Some patients may feel it in their mouth. Their mouth will suddenly blow, and some will open the mouth and will start going. So we go with the nasal mask. Some patients may like nasal pillows, which is again less claustrophobia. It goes inside the nose. Some patients will complain of sore nose. But again, it's an option. But again, it's only for mild to moderate pressure. Once the pressure goes above 11, they may start having leak. The oronasal mask is always an option for patients who require probably high pressure and they have leak, or patients who have nasal blockage. So this about the masks. I don't know if you have questions about the mask. We'll try to cover as much as we can by your questions. And then when we do the titration of the CPAP, we can do it in lab, or we do home sleep study, then we put them on auto CPAP. And as I said yesterday, auto CPAP detect apneas by different mechanisms. You have to make sure that the company has a validated algorithm based on published unbiased papers. So you choose the mask, and Professor Hess has pointed out to how to do that, and they have measurement. I don't know if you have time. They make the measurement, then they choose the best mask. We encourage them to start with the nasal mask. Then during the titration, we can build up, as we discussed yesterday, by 1 centimeter for certain criteria. Because we have time for these patients, education, support, and behavioral therapy are very important. And they enhance, in systematic review, they enhance adherence so much. Not like patients who are coming acute, we are all tense, just to save them quick. No, here we have time. We start educating them before about the importance of using CPAP, on the quality of life, on the comorbid conditions, try to educate them, try to get the support from the family. For example, married patients, they have better adherence than those who are single. And if the family understands, the wife, for example, understands this and that it is important, they have better adherence. So we have to work with all these things. Also, regular and close monitoring and follow-up in the first few weeks is very important. In the first period, having easy access to consultation at the medical care team, also very important. In Saudi Arabia, we found that after 1 year, almost 80% are still using their device. If you have all these things. But if you give them the device and send them home, they will never use it because it is not physiological. What are the concerns patient may have? They will ask you, for example, if the electricity goes off while I'm asleep, will I die? They get concerned about that. What do you think will happen to them?
They will just wake up.
No, they will not wake up probably. Ask them just put it and breathe. Because here we use the one with the holes for the intentional leak to allow CO2. So some of them may not feel it. I mean, so it doesn't go off frequently, but if it goes off, most of them, they will not feel it. But they can still breathe. They will not die. You can then put it and breathe. And how do you start with the patient, this patient? Because as I said, we have time. We are not like in acute situation. I tell them usually put the mask and before you put it, start the machine so they can feel it. Put it while you are sitting, watching TV. Hold it with your hand initially. Hold it until you feel comfortable, then try to put the strap. Watch TV and until you get used to it, introduce it. When you go to bed, put it while you are sitting. Like you raise the head or put 2 or 3 pillows and take the sitting position, because the more we go to the supine position, the more we get scared, always. We feel that we are vulnerable, we are weak, and this is sitting on us. This is a bad feeling. So do it with sitting, then you can read, do something. Once you feel that you are not feeling it anymore, then you can turn off light things and put it. Again, I don't know what should we cover with you, but again, when they fix because the patient will fix it now at home, not like in the ICU, fix it for them. They don't have to keep it so tight. This is because most of the time we don't require high pressure like the ICU patient. They require high pressure, they have leak. So it shouldn't be that tight. And then they should check if there is leak around. If there is they don't feel much leak, then that's comfort. They don't have to keep it very tight. Again, as you know, for the home CPAP, like this one, is it where is the home CPAP? Yeah. Has a new model. Yeah, this is the new model, mashallah. Yes, this is a new one, not the black one. احنا الجامعة still bring us the black one. Okay. So this one you have like a lot of algorithm, like expiratory pressure relief. So when the patient exhale, they will not feel it. Many patients, when they get used to it, they say, when I put the device, I'm not sure because these devices, they will feel the breathing. You don't have to press the button. If you put it, it will start. He said, I'm not sure. So some patients say, I open my mouth to see if air is leaking, then they get used to it that even they don't know if it is working or not. You get the point, some of them. So, but you can feel the air coming through the holes. For example, here you feel the air is coming out. I think one of the points we need to cover is CPAP and bi-level. Probably you are familiar with the difference between CPAP and bi-level, isn't it? So most of the sleep disorder breathing, we start with CPAP, obstructive. Even obstructive hypoventilation, we start with CPAP. CPAP, because most of all chest patients, obstructive hypoventilation, they have coexisting obstructive sleep apnea, severe. So the American Thoracic Society says start with CPAP. When we shift to BiPAP, if they require very high pressure, so CPAP will go up to 20. With the bi-level, for adults, we can go up to 30. So we shift if they cannot tolerate CPAP, or if they still have residual hypercapnia despite using CPAP, or if they have OHS with no severe OSA. So it's like more of hypoventilation, then probably we can go to BiPAP. So if you use BiPAP, we start usually with 4 centimeters for the EPAP and 8 for the IPAP. Then EPAP mainly to eliminate the obstructive events, obstructive sleep apnea. And IPAP can help in the hypoventilation and can help also in removing hypopneas. Because hypopnea, the air is not completely closed, so the air is slightly open. So inspiratory pressure will open it more. But if it is completely closed, you need EPAP, you need CPAP, because you don't want it to close at end expiration. You want it to stay slightly open. If you increase EPAP and IPAP, remember that you always have to keep a difference pressure support of 4. So you always keep it minimum 4. You can increase IPAP more for hypoventilation, for example, but the difference shouldn't be less than 4. Patient, when they go home, they have to use it. What are the problems that we encounter? And I don't know if we have time to go. Again, in your table, I put in your 6 minutes? Okay. Table 3, I put a list of problems that will affect adherence and how to solve it. Like, for example, claustrophobia. Claustrophobia, the bigger the mass, the more people will become claustrophobic. Some people, when they go to the MRI, they get scared. They cannot tolerate it. When they go to a busy elevator, again, so they cannot help it. So again, behavioral therapy, cognitive behavioral therapy can help. very effective. And choosing a smaller mask, also ask them to use it when they are sitting. Sitting in the living room, they are awake, they are comfortable, so they get used to it. Difficulty tolerating blowing air. Again, maybe the pressure is high, so we go to the minimal pressure that will eliminate apnea. Expiratory pressure relief technology, what's called in some device flex technology. This is also very comfortable. I don't know if you have tried CPAP yourself or not. Have you tried it in yourself? Yeah. It would be good also to try it for sleep apnea and try the ICU devices for high pressure, because it's completely different. I have tried everything myself. Tried everything myself as a volunteering and not volunteering, because I have to use it. Okay, so dryness, one of the main problems we face, 65% of patients, when they come first visit, they will have side effects. Dryness. When you see dryness, as we discussed yesterday, the main thing you ask for is check if there is leak. Do you have example of leak here to show them? Leak. That's why you have to use the data, download data. In data here, you can see the residual HI. You can see how much they are using it. See, you see in the devices, they put like a line. So each mask and each device will have different leak threshold. This is the intentional leak. So when it exceeds this threshold, it's not acceptable, you see? So when there is leak, our system cannot keep humidifying the air, so we'll have dryness. Leak can be from the sides or can be from the mouth. Okay. If you don't see much leak, you can use humidifiers. In general, in Riyadh, I use humidifiers for all patients, heated humidifiers, because Riyadh is dry. And usually in Western countries, in summer, humidity is good. It's not dry. But for us in Saudi Arabia, in summer, we get more dryness. Why is that? Because we use the AC. And the AC will suck all humidity in the room. And then we'll have more. So I use humidifier always for my patient. Remember that the higher the pressure you need, the more likely that you will need humidification. Because this flow is too much, our system cannot humidify it. When we breathe normally, by the time air will reach to the trachea, it's already 100% humidification, normal body temperature. But with this high flow, you cannot do it. And the higher the pressure you use, the more dryness you get. If they have nasal blockage, and many of them, they may have nasal blockage, with using CPAP, make sure that you have humidification. One of the causes of nasal blockage in these patients is dryness. Humidification will help that. If not, then you can use some medication like inhaled steroid, for example. Skin irritation, a common problem we see, again, because they tighten the mask very, very much, or they don't clean the mask. When the mask is dirty, also, they will have skin irritation. Annoyed by the noise, these devices, probably no time to put it, but they are not noisy. They are very quiet. But if there is noise, then check the filters. Some devices you have to clean it. Other devices you have to replace the filter. Dirty filter will increase the noise. Sometimes you use white noise. White noise, a lot of apps now for white noise. Like you can put AC, you can put pink noise, or call it blue noise, brown noise, different noises now are there. You can use like waves or whatever, because if you put a white noise, it will mask. But the device in general has minimal noise. But some people, they hear, very sensitive, they hear the air flowing through the tube and the mask. So for that, they can use white noise. Unintentionally removing the mask, which is, again, a common problem. Again, what we discussed, they like wrong mask size, they have leak, they have nasal blockage. So try to solve these problems. Usually we recommend that they use it for, they put it like 4 hours per night, 70% of the time. But this probably is not enough. So what I tell the patient, use it all your sleep period. Our patient wake up for Fajr to pray, and some of them, they take break. I don't want to use it after Fajr. I'll sleep without it. They reward themselves for using it the whole night. That's the worst time not to use it, because that's the time when we have REM sleep condensed, because REM sleep will follow circadian rhythm. So we get more REM sleep. More REM sleep means more desaturation, longer apneas, more sympathetic activities like arrhythmias, and that's the time when they may have stroke or myocardial infarction, because even cortisol surge cortisol hormone will go up at that time. So tell them, you pray Fajr, put it please after that. Again, we have what's called, I talked to you yesterday about the REM predominant OSA. And REM predominant OSA happens only in REM sleep. And as REM sleep follows circadian rhythm, it's more at the end of sleep. So if they don't use it after Fajr, if they go to sleep, they get more. Okay. Do you have questions, something that I did not address? Because I don't know what to. Yes, please, go ahead.
What's the recommendation of humidity range? I don't know what's the, some machines use 1, 2, 3, 4. Or
Yes.
Yeah.
The more you increase it, the more the humidity.
Your recommendation?
Yeah, there is no fixed recommendation. Some people, they like the air to come hot and humid. Others, they don't like it. So we start like with something in the middle. Yeah. Then we see with the patient, do you feel that the air is, you are comfortable with it or not? And some people may use it like 2 or 3 in Riyadh. Then we go to Jeddah or to Dammam, they may not like it. So they may cut on it, or we may take it off for some time to see if they are comfortable with it. So it depends on the area they are living in and their feeling and the pressure. The higher the pressure, if someone requires CPAP of 20, they will need more humidity than someone who requires pressure of 6. Okay, thank you. Oh, Mike, okay. يعطيك العافية دكتور. الله يجزاك خير. شكرا لك.
Thank you so much for every one of you. I really appreciate, your attendance. Today I'm going to talk about, it's just 15 minutes, so I will try my best just to cover the high flow nasal cannula. So, high flow nasal cannula is one of the most, interesting and trendy therapeutic, procedures that we are utilizing nowadays. First of all, we would like just to understand, the mechanisms of actions for. It will lead to reduction of the dead space, increased dynamic positive airway pressure. Also, it will increase airway hydration, and definitely there is FiO2, so the oxygen, if we need it, we're going to have it. Also, the patient comfort. So, especially the patient comfort is really important, and it's superior than, utilizing non-invasive with those patients. So, this is really important and critical. As you can see here, also in your booklet, there is some recommendations about the utilization of high flow nasal cannula with different type of populations, different type of conditions. As you can see here, some like recommendations, strong recommendations, and the others like suggestions. And most of it is comparing it with conventional oxygenation. It's better than conventional when you utilize it post extubation. Also, you can utilize it during non-invasive breaks. Also, there is some suggestions to utilize it during the pre-intubation period. So if the patient is utilizing high flow nasal cannula, okay, you can keep the patient on high flow nasal cannula and you intubate the patient instead of discontinuing the patient. However, there is against this recommendation if the patient is not on the high flow nasal cannula. So you cannot connect the patient on high flow nasal cannula in order to pre-oxygenate the patient for the intubation. No, you need to just embobag and intubate the patient. So the first question that we would like to highlight here, as you can see here, how do you select the flow settings for high flow nasal cannula? First of all, how many one of you have utilized high flow nasal cannula in the clinical practice? Okay, so mostly with critical care cases, right?
Yes.
Or home care, something, or just critical care? Okay, so what's the starting point? So we need to remember something very important about this device. We need to consider the interface itself, which is nasal prongs, because each nasal prong has different sizes. And as we can see here, this interface, and the other one has maximum flow you can utilize with. And most of the companies, they are mentioning this on the top of the nasal prong. So you need to be careful when you utilize this. This is one. The other thing about the demand of the patient. So it's different from patient to patient, because sometimes some patient they need higher flow, some patient no. So you need to be careful about this. Also, the support that you are looking for. Example, at what time you want to ventilate this patient or giving a high flow. So that's really crucial when you select the flow settings. The other thing about the population itself, whether neonatal, pediatric, adult. And the key things in this is the weight. The weight is very important when you set up the flow rate. So as we can see here, it's like a rule of thumb. Usually, when you set the flow rate, regardless of the medical condition, you will look to the the weight of the patient. If it's less than 12 kg, you just give like 2 liters per kg per minute. Okay, so you just calculate the weight and you just play with this number, and also consider the interface itself. It can give the maximum flow. If you have patient more than 12, okay, you can, for the first 12 kg, you can provide 2 liters per minute, and you add 0.5 liters for the additional weight. Okay, so if you have patient with 20 kg, you can provide him like the first 12, which is 24 liters per minute, and the 8 liters it will be 4. So you're gonna give this patient like 28 liters per minute. So that's very, yes. The weight itself is not the ideal body weight. Usually it's like a rough estimate. There is no certain, to be honest, criteria, but this is based on the manufacturers, based on the studies they are utilizing. So example, with adult population, usually the starting point based on the the clinical trials, it's between 50 to 60 liters per minute. Usually they are starting with this number, and you just then titrate based on the patient need and patient demand. You can see here, this is very important to be considered here, which is the recommendation that the cannula cross-sectional should not exceed 50% of the nerves. Usually, the nasal prongs, depend on the patient size, it should not block the whole nostril. So the nerves itself need to be, at least there is a space within 50% with the cross-sectional, area. This is very important and need to be considered. Nowadays, and we will talk about it later, but they are now starting to have like something called, this is what we have it here, is like symmetric nasal prongs, which is equal each other. However, the new generation, they have something called asymmetric, which is one larger than another. Okay, so one larger and the other one is smaller. So the idea behind it to have unidirectional flow, and I can show you this here. You can see here, this is the idea behind it. So larger prong and smaller prong, so the flow will go, and this will lead to increase the comfort of the patient, decrease the noise, increase the CO2 wash out, also the PEEP level, which is unmeasurable, to be honest, but it can reach up to 7 to 8 with this mechanism. So it's really nice and interesting with this. And now we'll talk about the temperature. Okay, then we will show you on the device itself. So the starting point for the temperature should be 37, because your ultimate aim is to have high humidity as much as possible. Almost like when you start with 37, it can give you up to 100% humidity. This is very important. However, you need to consider something also crucial. Also, Professor Bahama mentioned this, which is the comfort of the patient. Some patients, they don't like high humidity or high temperature. So you need to titrate this down based on the comfort of the patient. Usually, based on the evidence also mentioned in the book, it's 31. When they compare it with 34, it's more comfortable. But definitely, the limitation is less humidity. So you need to play around with this based on the patient comfort, based on the need itself. But usually, the best thing, or based on the manufacturers and also the studies, is to start with high temperature to give high humidity. And you can see here through the how to set it up and how to is it connected, the camera? Yes. And you can see here through the screen how to set it up. We have like flow rate, and we have the FiO2, we have the temperature. These are the most important, variables that you need to set up when you start the machine. And you can play around with it. So usually you go down, up, based on the need of it. Also, yes. So the temperature can go one by one or by levels. Yes. What else?
And confirm. And also we have the flow rate starting from 2 liters per minute up to 70 liters per minute.
Yeah. So the new generation, because before the old systems, it can reach up to 60 liters per minute, but the new, generation of high flow nasal cannula, it can give up to 70, which is something really nice and good. And FiO2 also, again, as you can see here. And the most interesting thing about high flow nasal cannula, it can be connected to the wall to 50 psi, which is with the oxygen and air. Also, it can be connected directly to cylinder, so it's good for the transportation. It's more convenient for the patient and healthcare staff if you want to transport the patient while this patient on high flow nasal cannula.
Also, we can.
Okay. If you have any question on this, okay. We will go now to something very important, which is how do you monitor patient on high flow nasal cannula? This is very important and the critical, things while you are managing patient on this device. So usually, as you can see here, there is something called ROX index, respiratory, and oxygenation index, which is very important, respiratory rate. It can be utilized, it can be monitored, and usually when you start the treatment, you should monitor this within 2 hours, 6 hours, and 12 hours, okay? Then you see the case of the patient, and based on that, you start to make your actions. So you calculate it, and the ROX analysis can be calculated by SpO2 divided by FiO2 over respiratory rate, okay? So if the number, as you can see, at 2 hours, less than 2.85, you need to escalate and go to intubation. If it's between 2.85 to 4.87, maybe increase support. Maybe the flow you are providing is less than the required, so you need to go up and reassess again. And if it's 4.5 and above, that means this patient is fine, and continue monitoring, and you need to think how to switch this patient to another device or just wean this patient up from the ventilator. So it's very important. Also, when you start to whether increase the flow or decrease the oxygen, you need to play it around like this. When you increase the support needed, move the flow up first, then the FiO2. And vice versa, when you want to wean the patient down, you need to decrease the oxygen first, then you decrease the flow. The last thing we would like just to go over, which is how to discontinue this patient at all from the ventilator. Usually when the chief complaint of the patient is achieved, or there is nothing really worrying about this patient, the support is decreased, the respiratory distress elevated, you can just go and start play with this again. With this flow chart, you can see you look to 3 parameters, SpO2, which is the ROX analysis. Also, you need to look to the flow rates. You need to go down by oxygen until you reach like 40%, and then you go down, as we can see here, by the flow rate. You go by 5 to 10 liters until you reach like less than 20 liters per minute, and you just extubate, or remove the patient from the high flow nasal cannula. And usually some practices, actually it's different. Some practices, they are weaning the patient directly without going down with the flow, and just look to the patient, monitor the patient, make sure You evaluate this patient hourly within 2 hours of removing the patient from the ventilator. If you have any questions, I'm very happy to answer your questions. Now we have 15 minutes, I think, right?
Yeah. So
10 minutes. So if you have any questions
or are there
regarding high flow,
if you do not, I have more questions for you, but let's hear your questions.
This is monitoring and policy of weaning. It's for adult and pediatric or just for adults?
Yes, it's for both, and depend on the the characteristics of the patient, but it's for both. Yes, it can be like this. تفضل.
For weaning, speaking of weaning, there is no fixed number that I can titrate or wean the flow. So, for example, every 1 hour I go by 2 or 3. There's no fixed number.
It's a rough estimate, but usually you start with when you want to wean the patient up. Go down with the FI tool because it's really critical to, especially with hypoxemic, respiratory failure. Then when you reach, FI tool less than 40, you go down with the flow rates by 5 to 10, as you can see, every 2 to 4 hours. You can go down. And some practices actually, they are weaning up the patient directly without going down because it's just a flow. So.
And if you take it off and the patient starts to deteriorate, just put it back on again.
Exactly.
It is much better than non-invasive ventilation for patients with acute respiratory failure. Easier to tolerate because patients with acute respiratory failure usually they have stiff lungs. It is not really well. So with high pressure, with stiff lungs, it's difficult. If something is just under, like if they put you down in a swimming pool, too much down. However, still it's not friendly. It's not like a nasal cannula. This air is really very hot and just blowing like anything in your nose. So you have to tell the patient beforehand that this is not a nasal cannula, the flow may be high, if not we'll try to decrease it. So again, it's not, it's I'm talking from experience. I've used it for years. So it is better than an invasive, definitely, but it is not like nasal cannula. So you have to explain to the patient what it is.
And that's the reason why you need to have, high humidity with this, treatment. It's very important, actually, because of the dryness, because of the comfort itself. And also the asymmetric design, like this one. It's really interesting because it will make less noise to the patient. It will give, more comfort, and also it will increase the CO2 wash out. So sometimes you need to consider these things when you make up your options.
Yeah, I would just add to what you're saying is that I think our patients who might benefit more from the pressure of non-invasive ventilation or CPAP than from high-flow nasal cannula. And the example I would give would be acute cardiogenic pulmonary edema. So there we need the pressure to increase the intrathoracic pressure and to assist the left heart. And I don't think you'll get that level of pressure with high flow, but you'll get some increase in pressure with high flow. But maybe not enough for acute cardiogenic pulmonary edema.
Also, there is something important I would like just to go over. With this device, you can connect the nebulizer, which is something really interesting. So you don't need to. Okay, this one I will do it. So
okay.
It's fine. Could you turn it on, the cam? So I think the high flow nasal cannula maybe later on, I think, and Dr. Hess can elaborate with this, because the beep therapy with the high flow nasal cannula cannot be measured, to be honest, but it's fluctuating between 4 to 6 to 7, but maybe later on it can be measured. So I don't know. We never know. So
right. It's unknown.
Yes. So.
It's working.
I mean the camera. هذا ليش ما يكون موجود؟
Like if patient can take medication for central sleep apnea. Yeah. Oh, we need to keep him in the machine.
Currently there are protocols going with medications, but so far the results are not promising. But there are like a lot of teams globally that are working on medications, like to increase the tone of the upper airway, this and that. A lot of people working on that, but the results so far are not. CPAP or vestibular pressure remains the mainstay treatment, but there are dental like devices, mandibular enhancement devices. You have it in your book. We talked briefly about it. That will pull the jaw or push the jaw forward. So when you push it forward, you move the tongue with it. But I tell patients and students that it's like this chair. This is the jaw, and the tongue is sitting in it, the genioglossus muscle. The more it goes back, it's closer to the pharyngeal wall, so the airway is narrow. If you move it forward, it will open the airway. There are surgeries also to move the maxilla and the mandible forward that are approved by the FDA, and they have good results for selected patients. There are also hypoglossal nerve stimulation, which they can put a pacemaker under the skin. It feels that we want to breathe, it feels that, so send a signal to the hypoglossal nerve, so the tongue will move out to open the airway. So there are different modalities which are approved by the FDA, but the gold standard is still posterior bushal, and most of the papers showing like good outcome for like morbidity is with the posterior bushal.
Yeah, and correct me if I'm wrong, but some of the other therapies like the Inspire therapy and the dental devices, it may improve the AHI, but not as good as CPAP. CPAP is still better.
Because most of these studies, they go like 50% reduction as movement. But they're approved, and dental mandibular devices, they have been approved for mild to moderate cases. And recent evidence shows that probably it decreases the cardiovascular risk, but not as good as for the
so some of the surgical therapies, and you can correct me, but I think they have reported that there's a 50% reduction in AHI. That sounds really good, right? But if your AHI is 50, it only brings it to 25, and we want it to be 5 or less. So,
exactly.
Yeah, I don't know, but he said 5 minutes.
Oh, okay.
If you have any question.
If you allow me to add a point for high flow nasal cannula, it can be used for the customized patients. So
excellent,
it's
yes.
Very effective. I have used it for multiple patients, and you have no idea about the outcome itself.
Do you have the interface?
Yeah.
It is magic. I can tell you, it is magic.
You can see. This is the interface for high flow nasal cannula, trach.
It spares patient the non-invasive ventilation. It's a magic invention.
Definitely,
it's really good.
Definitely. It's
definitely. Alhamdulillah, I had it. Better than very good.
So maybe one day it will replace the gold standard. So never know.
Yes. I would not throw away the NIV.
Yeah.
At least something that I can talk about.
Yeah. But still, it's under. Yeah, والله ما ادري.
The emergency room, and you have a 30-year-old female patient, came in, rescued from a burning house, came in with stable heart rate, low respiratory rate, decreased level of consciousness, GCS 7/15, saturating around 90% on an rebreather, or more than that, maybe. And a decision was made to intubate and mechanically ventilate. So, it will take a second. I'll give you the mic. Okay. So let's see. You have the decision.
Okay, let's see the answers now.
Mechanical ventilation or weak.
Five answers only? We want more. We want more answers. 6. Okay. That's okay, we can show now. 13. Yalla, you can move. Okay, excellent. As expected, we have variety of answers, and that's good. Because in mechanical ventilation, there is not something right and something wrong. There is something wrong, it's right as long as you can defend it and justify it. We have a lot of people who chose the volume control, which is what we plan to start with. Volume control, we choose it because this is a normal lung. Nothing happened yet, just rescued from the burning house. So we don't expect a lot of complication ventilating this lung. I see people who chose PRVC. We cannot go wrong with the PRVC, but if you notice, the tidal volume here, we set it as 250 ml. That could be a little bit low, and that would take us away from thinking about the PRVC. So the choice of mode is right, but what will drive us away is the settings, PEEP 8, Y, 20. We see here that we started the lung protective ventilation, which is not indicated yet. We don't have a restricted lung yet. Some people chose the pressure control with the pressure control of 25, respiratory rate of 12. This could be okay, but we don't usually start with pressure control. We usually start with volume and then switch to pressure if we need to. SIMV, I see one chose SIMV. I would like to know why did you choose the SIMV if that's okay.
It's very fast. I didn't see the burst.
All right.
I see the telephone 350.
Okay.
350 and
Okay.
260, so
Okay. So you like the settings.
like
Okay. So that's justified. Okay. That makes sense. It's nothing against the SIMV, but it will not give us an extra advantage. It's a waning mode, and even as waning mode is not doing that good. So we try our best to avoid SIMV unless there is something that will push us to use SIMV. So here we will start with our patient. We will start with the mode that you all agreed on. Because this is a burning house victim, what's the FiO2 we will start with? 100, of course, but here we don't have the oxygen, so we will put it as 21. PEEP of 5, because still the lung is still normal and there is no indication to increase the PEEP from here. When we go to the tidal volume, we have here a smart feature to show us how many ml per kg. So starting with 6 to 7 ml per kg will be okay. So that will help us to set our tidal volume. Now for our minute ventilation. How do we choose our minute ventilation? Do you know any guideline roughly to estimate the minute ventilation required? Exactly, and this is how we calculate it. But how much do you want it to be?
6 to 10.
6 to 10 liter per minute in general. But could you tie it to the weight of the patient?
Like body weight?
Yeah, excellent. Ideal body weight times 100. And this will give us the estimated minute ventilation. So we want because this is a 50 kg patient, our target minute ventilation should be 5 liter per minute. Our target tidal volume is 7 ml per kg. So we can set our target tidal volume. We know our target minute ventilation. We adjust the rate until we achieve the minute ventilation that we required. And this is your rough guide how to initially start your ventilation. Now we have pause time. Usually we don't start with a pause time. So this is something you make sure to stop each time. How do we choose our inspiratory time? What's the ideal inspiratory time? 0.8 to 1.2, so usually 0.9, 1 second is excellent inspiratory time. What do you watch when you adjust your inspiratory time? What do you think? IE ratio, excellent. This is one of the things. So you have to make sure that you get an IE ratio that's suitable. 1 to 3 is fine, no problem. Now, for the flow, do we have anything to control? I want to show you the flow waveform when we start this ventilation. Okay. So this is a square waveform. This is a volume control mode. It's always square. We don't have option to change the flow waveform in this ventilator. But how can we, if we have a patient who is struggling with the flow and he shows symptoms of flow hunger and flow starvation, do we have anything in this ventilator? If I go back to the settings, time rise, excellent, inspiratory rise or time rise. Here it can show you, if we adjust the time rise here, you see the flow, it's changing when we increase the time rise. And then when we go back to 0, the flow is affected. So we have to know there is a relationship between rise time and the flow. So we can control the flow from the rise time slightly. Okay? So let's say our patient started on volume ventilation. She was doing well in the beginning, and then she started to show symptoms of restrictive lung disease. So what's our option here? What's usually the practice that you do in your hospitals? Would you go from here? PIP started to shoot, patient is not ventilating, white lung, pressure control. Okay, excellent. So this could be an excellent option. So we will go to pressure control mode. How do you set the peak inspiratory pressure?
Your volume control, achieving the volume.
Yes.
You should achieve the same peak if you are.
Exactly. So you will start from the pressure that's measured on the tidal ventilation. This will be your guide. 15 above PEEP. Of course, you have to know your ventilator. Does it count the PEEP within the PIP, or it sets it above the PIP? And you set that, and then what do you monitor when you do that? What's the thing you have to monitor?
The volume.
Exhale tidal volume, excellent. And you want it to be close to the tidal volume that you were getting in the ventilation, in the volume ventilation. Okay, let's say in this patient, she got very restrictive lung disease. The volume was very low. So with this pressure that you put, you reach the maximum pressure that you can set, but the volume is still very low. What mode can we switch to? Is there a mode that can give you the advantage of the volume control? PRVC. Okay. So is the PRVC volume control or pressure control mode? It is a pressure control mode. Excellent. So we will switch to the PRVC here, and then we will get the advantages of both modes. What are the important things that we have to monitor in PRVC? Let's imagine our lung is very restricted and the volume is not reached. What would the ventilator do here to try to give us the volume that we set? The pressure will be very high. It could be very dangerously high. If we keep watching, the peak pressure could reach to 40 without anything stopping it unless what? Alarms. Excellent. So we have to make sure that we set our alarm properly when we are in pressure regulated volume control mode. So let's say we switch to pressure regulated volume control. The patient was doing okay, but yet with time, let me go there. With time, again, we still have problem with our blood gases. How do we manage? How do we manage blood gases now? Let's see if our patient have respiratory acidosis in the PRVC mode. How do we handle that? In any mode, PRVC will, let's say in the PRVC. The minute ventilation, okay, excellent. When we say we want to increase the minute ventilation, rate or volume?
Depends on the patient.
And the patient, exactly. And what? What's it?
The limit.
Exactly.
To up or still.
Exactly. Did I reach the maximum volume? Did I reach the maximal pressure? Do I have room in the volume? Do I have room in the pressure? And based on that, I will adjust the CO2. Oxygenation, how can I control it? PEEP and FiO2, perfect. And the inspiratory time, perfect. So this will wrap the basic modes of ventilation. One of the things in the pressure control mode is the inspiratory time. How do you set your inspiratory time? And how do you control and how do you decide the inspiratory time and pressure control mode? What's the ideal?
If patient is retaining CO2 or having a ventilation issue, the item shouldn't be very long. 1.2 in a patient who's asthmatic or having a ventilation issue should be less.
Excellent, excellent. So we based on the patient need and the IE ratio. So 1 to 2, 1 to 3, depend on that. Again, what's the advantage between the volume controlled and pressure control mode? We said the pressure control mode has superior feature when we compare it to the volume in what? The minute ventilation is superior in the volume control. Protect the lung, right? When we choose it. This is also something. We can protect the lung in any mode if we use the mode properly. But the feature in the pressure control that I want everyone to remember and put in mind is the free flow. The patient can take as much flow as they can, but in the volume, we set the flow. So it will solve one of the biggest asynchrony, which is the flow asynchrony. So if we have a flow asynchrony, we prefer to use pressure control mode. Okay, let's stay. Ms. Bashir, if we please go to the other question.
I'm sorry, I skipped to it before.
That's okay, so people answered already. All right. So this is the blood gas is perfect. No, the one after. Our patient still, we did all what we can. We used PRVC. We put all the settings. The patient is deteriorating and she's not doing well. And this is what we see, the one with the X-ray. Yes, this one. With that question, I'll hand you to Dr. Steger.
Okay.
Okay, I'm Sigurd Årstad. I'm a pulmonologist. I work in Oslo University Hospital, and we're going to switch to this other ventilator. I know this from clinical practice. I have nothing to do with the company or anything, just to be clear. So you all answered the question now, and yes, well, actually all of the answers are correct, and you see that the patient had bilateral opacities, infiltrates, yes, and what about the blood gases?
Is acidosis.
Yeah, and more general bilateral opacities, and yes, severe ARDS, severe, and probably some inhalation damage to our lungs. If it wasn't the ventilator, we guess it was the inhalation. Yeah. So, and I think the all suggestions could be considered, and some of you mentioned APRV. Some of you mentioned that, and I think we want to first look at that. And so APRV is an option, and this is the concept is an open lung concept. We try to recruit closed alveolus, and it's extreme inverse ratio ventilation. And how do we set the ventilator?
B high and B low. T high
Yes.
and T low.
Yes, excellent. So this is a little bit strange mode. So we set the let's see. confirm. So here we are. So we set the T high. What would we start with?
4.
5, 6 maybe. Yeah, that is the length of the period with the high pressure.
Inspiratory time.
Inspiratory time. And then we can also set the pressure. How would you set the pressure of the P high?
The mean airway pressure or the plateau pressure and the convention.
Yeah, in the volume mode, we look at the P plateau, and however, not exceeding our limits for security. Yeah, that's important. So maybe, we can go a little lower. What about the P low? That is a PEEP in a way. 0, yes. There is one publication, maybe a few years ago, that had the P low at 5, a randomized controlled trial. But so there are discussions now, but the general recommendation is 5. No, it's 0. So stick to that for now. And how about the time we are in this low pressure? Sorry. This is the T low. Yeah, we set that quite low. The idea is that you should have a very short expiration time. Actually, so short that you will not reach a flow of 0. You should expire but have remaining auto PEEP. That is the concept. But we have to start, so we set it low. But we don't know exactly. We set it like 0.5 seconds at the beginning, and then yes, that's okay. And then we can start the ventilation. So you see the very long inspiratory time, and then very short expiration time. And how would you adjust? Are you happy with the expiration time? Could you adjust that?
According to the peak expiratory flow rate, it's from 50 to 80 according to the stats of the yes.
Say again, please.
According to the peak expiratory flow rate, I see
yes.
that this is a very short time.
Yes.
It's not appropriate, so we could shorten the P high, the T high phase, so we could get more expiratory flow rate from the downside.
Yes.
So it could be, I think it's 50% out of the peak expiratory flow rate.
Sure. Yes. Yes, that's correct. We want the expiratory flow to end the range of 75 to 50% of the peak expiratory flow. And we can look at the graphic for that. So we can freeze the ventilator, and we have the expiratory flow curve here, and so we can see this is the peak expiratory flow, and then we can actually measure it by bringing the cursor to the area. Yeah, around here. Yes. And we can see here 60, and then we can go to the area around maybe like 30 or. And then we can see here actually now I think that the T low is too long. So for initial setting, I will actually go now and immediately change the setting to a little lower. We have to unfreeze that before and then go back and go by 0, go to 45 and then repeat again and look. So the less the compliant the lung, the shorter the expiratory time will be, and we need to adjust the T low according to that. So we don't want the lung to totally empty. We want to remain intrinsic PEEP to keep it open. That is the concept of this little bit strange ventilatory mode. Okay,
does it help more with oxygenation or ventilation?
Well, this is constantly recruiting. So this is a way to recruit more of the lungs that are sort of collapsed. So, and it's a good question. So because recruiting lung, does it help for what? Oxygenation or?
Oxygenation, well, yeah. I mean, with that question, the last question was
yes.
Both mixed ventilation and oxygenation.
Yes.
Yeah.
Does recruiting the lungs only help to oxygenate the patient?
I think both. Right? Both.
Good.
Okay.
Better alveolar ventilation, better gas exchange. Okay. So we have one question, huh?
So in APRV, would you manage unacceptable levels of pH and NAVA?
Wonderful. All suggestion could be considered was most of you answered, and that's correct. So if we increase T low, that could increase ventilation. However, we must always consider the other topic about expiratory flow, that we should not lose the intrinsic PEEP. We shouldn't increase it too much. So pay attention to but then we might maybe go from 75% towards 50%. But we are not aiming for a PEEP of 0 actually, no? But it could help. Increase P high, that it's what we mentioned already, that it could recruit, make more lungs available for ventilation. Yeah? That is by increasing P high. Decreasing T high, time, how would that influence ventilation?
Yeah. It's equivalent to the decreasing the respiratory time in the conventional ventilation.
It will increase the respiratory rate.
Yeah.
Yeah. By increasing, because these are both inspiratory and expiratory time are controlled by time.
Yeah.
So by reducing time, that's how we can increase respiratory rate. Yeah. Okay. You were onto it, but okay.
Actually, having a concern with increasing the B high.
Yes.
Because it's when you're speaking about B high regarding an open heart ventilation, and you set your B high, let's say for your optimal PEEP according to the PV tool or whatever the method you have used. The thing is here, what if I already set it on the upper inflector point?
Sure.
This is going to be injurious.
Very good point. So we have to, of course, because if we start with the plateau pressure that we had in volume control, and then we have still something to go before we reach our safety level. That we shouldn't. Normally, you shouldn't go above that. So it's a good point. Okay. So. Okay. So. I think that we can. Another option was ASV. I can just give you a short introduction to that mode as well. Let's just go back. So when a key factor when we're thinking about adaptive support ventilation, we will set the minute ventilation. And how do we set the minute ventilation? The ideal, we set it according to the the patient's height, and then so that needs to be correct from the beginning. So, and then the idea of ASV is that we need to set oxygen and PEEP according to our normal standards. Huh? And then ventilation and control of CO2 pH is controlled by the ventilator itself. That's the concept. We set the minute ventilation. And how would we start in ARDS? We are talking about the patient with severe ARDS now. what will be your sorry, say again? Yeah, but you have to set the minute ventilation, the percentage of the, that is the, what you have, that is a little strange, but so you set the, not 100%, but you, in this case, you will set it at 120%. That will be your start. So the ventilator will aim to ventilate the patient according to that. So, so then the ventilator will use a few breaths to sort of automatically measure the patient's resistance of compliance, and then it will aim for the set minute ventilation, and it will, according to the dynamics of the patient, either adjust the breathing frequency or the volume. So you can see that the patient's, it will automatically adjust to be within this safety window in order to protect the patient, not to harm the lungs of the patient. So it will automatically adjust according to the setting we initially made.
There is no, we didn't set RR or something. The RR changes with the mood, the condition of the.
So we must, as before, control oxygen and PEEP, but the ventilator adjusts its rates and volume. And the patient can also trigger the ventilator. So this could be used in severe patients having controlled ventilation, mandatory breath, but also they can go towards spontaneous ventilation. So in this case, we are still in a situation we need to secure the patients. It's not so much about comfort. We are not talking about liberation. So remember that we always have to consider where we are in this in the situation of the patient. Are we focusing on security, about ventilation, or are we talking about comfort, or are we getting into liberation? So this mode can actually help in the transition also. We can use in the acute severe patient, but also gradually go over to more synchronized ventilation. Okay.
Yes. Intubate the patient on ASB if we reach a minute ventilation of 80 to 60.
No, it cannot only look if you reach the goal, because you have to see what's is it. Do you reach the goal because the patients are ventilating spontaneously, or is it controlled ventilation? Yeah.
But we can extubate patient on ASB.
Yes. Yeah, because it gradually will, at the end, it will actually be a spontaneous ventilation. So it's possible to do that depending on your protocol. But the idea of the mode itself could be used all the way to extubation, to weaning. Yeah. Do you do that? Yeah. Okay.
Thank you. Thank you. So a few days later, the patient is improving, doing better. Sedation is being weaned. And you have a decision to choose. What type of spontaneous mode do you want? Let's see. Once we switch. We have the answers pulling in. Let's see. So by show of hands, how many RTs do we have in the room?
All of us are.
Okay, excellent. So let's see. Yep, let's see. Okay, so majority chose pressure support, and I see someone likes SIMV. No judgment, no judgment, all good. So it is the most common spontaneous mode that we have used in our practices across the board in Saudi and international. So what is the starting number that you like?
For pressure support?
Pressure support, you're just starting the patient on pressure support. 10, 8 to 10 is a nice number you can start with. So usually we switch to the same oxygen and PEEP as the patient was on before, as long as they meet the, let me start here. Let me see, yeah, everyone likes 10, let's start on 10. The flow cycling part, based on what type of patient you have. If you have a patient that you think is prone to have intrinsic PEEP and hyperinflation, that's when you're going to go up a little bit more. So you will influence the expiratory time to try to make it a little bit longer. Although you don't have a direct control on it, this could help push the patient to that state. So our patient doesn't have any problem, so we could lower this a bit to a 20 to a 25. Rise time, keep it on a 0.05 based on the ventilator you're using. You want the flow to come in quickly. You don't want the patient to starve for the flow. Trigger as it is. All of our ventilators have a backup. So you just set your apnea time appropriately and make sure that your apnea ventilation, your backup ventilation is set to your preferred settings. This ventilator will automatically choose the mood for you. If you use pressure support, it's going to be pressure control, but some ventilators will allow you to go back to PRVC or volume control. So here all looks good, accept, and we switch to a pressure support. So what are you looking for at the moment you switch? Patient triggering, so patient is triggering. Thank you very much. And what else? The respiratory, the triggering, we can look at it here. Looks good. What else? Tidal volume. So is this a good tidal volume?
So it's 6 ml. No, it's okay.
It's okay. So we're looking, as you would set in volume control, or as you would start the patient on a controlled mode, you set a specific tidal volume. When the moment you switch a patient to something spontaneous, you have to have at least a mental number in your mind, at least 5 mL per kg from ideal body weight. If you reach that, excellent. If you have just a little bit less. So if you have less than 5 mL per kg, the patient is around 50 kilograms, 5 to 150. If it's less, you go to your pressure support and you nudge it to the upper part. If your numbers are too high, that's when you can lower it down. There are other things that could help you know if the patient or the pressure support you're giving the patient is appropriate from the start go, is you have all of these numbers on the side. I'm not sure if all of us like to look at them. Do we? Yeah. So what is your preferred number from the start? So an SBI is a nice number. We all learned it. We all like to use it. But below 105 is what we're aiming for. But usually we'll allow the patient to stay a bit on it to look if it's acceptable or not. So 23, excellent, below. But when you look at the P0.1, what do you see? Are you happy with that number? So what are we aiming at the beginning? When they include it in the beginning, you want to see something between 1 to 1.5. If I have anything less than 1 or 1.0, that means that either the patient is being heavily sedated or I'm over-assisting my patient. The patient is not doing a lot of work. So if I see that, I'm going to go back to my pressure support and say, if my volumes are acceptable, my rate is acceptable, I'm going to lower my pressure support so the patient does a little bit more work.
So you can see this work.
Yeah, that's an indication to how much work the patient is doing. You want them to still be within an acceptable amount of work. You don't want to over-assist them. Yeah. If you see anything above 3.5, definitely you are under-assisting your patient. If you see a number above 6, that means your patient is not doing well, he's not ready to be weaned yet, you switch him back to something controlled. So in your practice, you start with 10, and then what do you do? Do you extubate on a 10? Or do you lower your pressure support? Lower, so you want to challenge your patient. Most of us will go to a 5/5. Some might put it on pure CPAP. So 5/5 for 30 minutes, or you could actually go here. So on this ventilator, to go into a true CPAP, you just lower your pressure support to 0, and the amount of PEEP you put is your CPAP. And you're going to look at it the same way you look at pressure support. The same indications apply. 30 minutes, the patient is doing well, you can take him off. Right here, you could see the patient is actually not doing well. He's not taking enough volume. That means taking the tube out is a high risk. Another spontaneous mode that you could use is volume support. How many of you use it in their daily practice? Or let's say monthly practice? Once. Okay, do you remember the case that you used it on?
He was on pressure support, but the doctor preferred on support because he wanted to change.
Okay, so volume support is similar to a PRVC, but in a spontaneous mode. So usually it's good for patients who have been on the ventilator for a long time, who have weak muscles. You want to train their muscles. You're not going to put a patient on pressure support and you're going to extubate them in 30 minutes. That's not usually what happens. So as you would set PRVC, you're going to set volume support. When I said setting pressure support, you have a target tidal volume in your head. Volume support, you actually write that target. So if you can see here, if I choose my tidal volume, I'm going to go up. I'm going to set something between 5 to 7. The thing is, if I choose like a 6 right now, let's see, 6 mLs per kg, I'm going to switch the patient to volume support. I'm telling the ventilator, I want the patient to get a spontaneous breath of 300. If the patient gets anything below that, they're going to increase the pressure support automatically. The problem with that is that, like right here, I'm going to accept that and switch the patient to it. If I set the patient on a tidal volume or a spontaneous tidal volume of 300, where do I look at? What is my guide to know if I'm doing well? My pressure, excellent. So my peak pressure is actually my pressure support minus my PEEP. So 18 minus 5, that's going to be your pressure support.
Oh, it's high pressure support. It's
high pressure support. So what do you do in that case? Do I do? Decrease the tidal volume. So either I put the goal too high. The patient is still weak. They can't get 6 mLs per kg. Let me start on a 5.5 or a 5 ml per kg. Maybe the patient will do better. They could work to that goal. Once I lower it, the patient gets a good PIP, the patient gets a good amount of pressure support, then you can leave him and let him work to reach that goal. The opposite is true. If I put a 300 and I find my PIP to be 8, am I happy with that?
Yeah, I'm happy with that.
Why?
8?
Yeah.
He's taking 300 and the pressure support is 8.
Yes, so
you are not supporting him too much, all right?
Yes, I'm not, but how much support is okay? So I'm giving him 3 pressure support. Would you ever do that?
Oh, no.
No, we're not. So that could mean either the patient is pulling too much air, he's starving, that means that the goal I set was too low, or the patient is actually doing very well. So as you would manage a patient on PRVC that's pulling the pressure down, some people say, the PIP is 16, excellent. No, the PIP is 16 is not good for a PRVC. Yeah. Same goes for volume support. If my PIP is too low, that means I'm not helping my patient enough. Go back to your volume, increase it, increase the goal. If the patient can pull that volume with low support, put him on an SBT, extubate him.
Yeah.
Okay? And if we could have, sometimes you will have a patient that's doing well on the ventilator, but you would find some asynchronies. You manipulate the rise time, you manipulate other ways, but now our patient has a lot of asynchronies due to missed triggers. What could you do? Do you have a pocket? Can it be here? Okay. I think this could be clipped in. Okay.
Okay, thank you. If you could not maintain that. So the patient is asynchrony and with a ventilator with missed trigger and of course a lot of missed efforts. So what's the choice? So, oh, well done, it's NAVA. So NAVA is a mode of ventilation. It's a spontaneous breathing mode and it stands for like what? What is NAVA stands for? NAVA. Wake up. It's sleeping time.
Neurally adjusted. Ventilatory.
Okay, excellent. So neurally adjusted ventilatory assist. How many of you have used NAVA or at least seen it on a patient? No? Okay, thank you. We have one in the audience. I'm also a respiratory therapist and I have used NAVA over 700 babies when I was working in the UAE. For 21 years. So anyway, NAVA is a spontaneous mode of breathing. It stands for neurally adjusted ventilatory assist. It's a spontaneous mode that gives ventilation, delivers ventilation in synchrony and proportionality with the patient's breathing. What do we need to start NAVA ventilation? So you have the servo ventilator here. This is the NAVA demo module. You put the slot in here and then you connect the cable. And then this is the EDI catheter. So what is this EDI catheter we're talking about? Can somebody tell me what do you think is this?
For the triggering, I think it's going to.
Yes, so basically this is an oral or nasogastric tube. It serves for feeding. You can feed the patient through this and it will be connected on the ventilator to trigger the breath from there. So how do we use it? So first, you have to know the weight and the height of the patient to find out the right size of the EDI catheter because we have different sizes from neonatal, pediatrics, and adult. So once you find out the correct size of the catheter, you go here on the ventilator screen and then EDI and NAVA over there and then go to the EDI catheter insertion and then now you decide whether you wanted to put it orally or nasally, depending on how comfortable it is gonna be for the patient. So if you choose, for example, oral, and then I have this patient who is 50 kilogram, who is like more than 150 centimeter, so I choose French 16, 125 centimeter. So how will I put this? So basically, you're gonna put the EDI catheter the same way you're gonna put the nasogastric or oral gastric tube. So you insert it, and of course, nurses always listen to the stomach, right? Make sure that it is not in the lungs, that is lying in the stomach for feeding. So, but then how far you gonna go through? We have a ruler in that box where the catheter is. Okay, this box has the ruler. Okay, by the way, this is the ruler. This is for baby. So I measure the necks. So from the nose, bridge of the nose to the earlobe and the xiphoid process. I take note of the insertion distance. And then I put it here on the ventilator, which is like 65 centimeter. But prior to that, most of the time it's good, but you need to confirm the position of the EDI catheter. And how do we do that? How do you confirm the position of the EDI catheter? So in the ventilator screen, you will see here EDI catheter positioning window. Can somebody tell me what do you see here in the screen? What are these? Come on, guys, wake up. So these are ECG tracings, right? So we have 4 ECG tracings in here because we connect the EDI catheter. So the EDI catheter, by the way, it has 9 sensors there. So the 9 sensors capture the diaphragmatic EMG, which we call the EDI signal. And you see it right here. This is the EDI signal in the bottom, okay? So this one lies on the level of the diaphragm. So it captures the EDI signal. But why are we capturing also the ECG? Because the EDI catheter is positioned behind the heart. So it captures the ECG and we use it to finalize and verify the correct position of the EDI catheter. So how do we know that the catheter is in a correct position? So look, we have 4 ECG tracing. The second and third ECG should turn into pink. So every time the patient inspires, it turns pink. Inspire, pink, pink, pink. So second and third ECG should turn into pink. Very easy, you can visualize it from even far. And then from here, you will see the reference. You see the PQRS. And then you will see that the P wave and the QRS complex disappear as you go to the bottom line and the fourth ECG tracing, it disappears. So now that our EDI catheter is in the right position, we are now ready to put the NAVA mode. And then here, by the way, sometimes the EDI is not in the right position. It's very easy now. We made the software very easy. So there will be an arrow here that tells like you have to push the EDI catheter a little bit down or pull it up a little bit, just 0.5 centimeter. And do you know how the EDI signal is measured? What is the measurement parameter? It's not centimeter water, it's not, any guess? So it's in microvolts. Yeah, it's in microvolts. That's the measurement. And then here, these are the NAVA level. So basically, these are the NAVA mode or parameters. It's all the same except the NAVA level. The NAVA level is different from pressure support because you set it for the adult between 1 to 3, and then you look at the EDI peak and the EDI mean together with your respiratory rate and the tidal volume. So the same way you're gonna ventilate the patient in conventional, what you're looking for to titrate the parameters, but with the additional of the EDI peak and the EDI mean. So if the EDI peak is above 20, you increase the NAVA level. If I'm on 2, I can go 0.2 to 0.3. And then the EDI mean, it means that the diaphragm is contracting on the resting level. So what do you do if the EDI mean is more than 1? Because 1 is the normal value. What do? You can increase the PIP level. So that you will, because the patient means that the patient is trying to contract the diaphragm. So you can increase the EDI, what do you call this one? The PIP level, okay, on a patient. And then, of course, the EDI signal, when it's not there, for example, this is flat. What does it mean when it's flat? No, let's say it's working technically. What's wrong with the patient? Yeah, it can be that there is a phrenic nerve paralysis, or, for example, in the case of neonates, it could be apnea. Yeah. So then, because of apnea, you have a backup ventilation. You will see up here, NAVA, and it can turn to pressure control ventilation during apnea. So, okay, and you can also use NAVA and then extubate the patient to non-invasive NAVA. Thank you. Do you have any question? Yes, yes. You can actually use NAVA for neonates. And actually, you will see a lot of clinical importance when using NAVA for neonates because, you know, the endotracheal tube for neonates are uncuffed. So there will be a lot of asynchrony because of large leakage. And also because the neonates, you know, they breathe very fast. And sometimes if they are in respiratory distress, their rate is very high. You will actually see that with the NAVA or NIV-NAVA, they will respond quite well. They will use very low peak pressure and very low oxygenation. And there's some clinical evidence studies that supports that if you want me to send you. Thank you.
Thank you. So by that, we conclude our workshop. We're open to have any questions or if you want to share experiences with our facilitators. Thank you very much for your
Thank you.
Any hospital in Saudi use this?
Yes.
Where?
Oh my God! I think King Fahd Hospital in Jeddah. There is
Jeddah,
one or two. There are a hospital there. Can I contact you and I'll give you the exact?
I see you. I think I am Aisha, respiratory therapist in Salama Hospital.
Salama Hospital.
I think it's here with
Yeah.
Saleh.
When was that with the? Exactly.
I think, but this busy day.
Yeah, exactly. I was going around. Oh my God. Yeah, in Jeddah. And actually, Saleh is attending the NAVA summit. So I think we will start NAVA in your facility.
What time?
Yeah, we have to agree with the time limit. Inshallah, we will, especially with
Because
neonates.
actually, I want to see how it's working, how it's being fed, how it's during the
With neonates is wonderful.
Because
they are the most
because we
fun.
have many patients in NICU.
Yeah, I saw it. I went there. Yeah.
I will wait you.
Yeah, inshallah, inshallah. We have, we are connected, right?
Yeah, give me your number.
Yes. Okay. Yeah. Okay. So that's my number.
I will take a screenshot. Okay. Because I think someone will want us.
Okay, sure. Hi, hi.
The study that you told me about.
The neonates?
Yeah.
Yeah, of course, yeah. If you can take my number here, send me WhatsApp.
educational activities for several years, and I never wear anything but a suit. Well, Keith and the president of the ARC, Carl, wanted to wear scrubs today. They're like, it's a workshop. And so I pushed back and said, I don't do that. I wear scrubs at work, and they, peer pressure is why I'm, so, but anyway, I am very comfortable, and it's most comfortable my feet's been in 2 days. So anyway, just for introductions again, my name is Dr. Brady Scott. I am a respiratory therapist like many of you. I am a professor and program director at a Master of Respiratory Care program in Rush University in Chicago, Illinois, US. This is my colleague Keith.
My name is Keith Lamb. I am a respiratory therapist at the University of Virginia, and I practice on the trauma and surgical critical care service.
Okay, and our other colleague there is coming back in. Akil, it's your turn.
My name is Akil Mayouf. I've been practicing respiratory therapy for almost 15 years now. I've been teaching some of waveform for the last 6 years or so. So welcome. Thank you very much.
Thank you. So here's what we're looking to achieve. So we have some objectives that tie directly to the chapter in advanced monitoring today. Like the lecture I tried to give yesterday in 25 minutes, you can only cover so much, right? So what we hope is that we can have some discussion with you. We want you to chime in. We want you to raise your hand. We want you to ask questions and make this as interactive as possible, right? It's late in the afternoon and would love your input, and hopefully the idea is you get a little bit more knowledge before you walk out the door, right? But we're going to do that in a conversational and discussive type of way, all right? So makeup of the room, mostly respiratory therapists. Do we have physicians in the room? Physician, do you mind telling me what type of physician you are? You're a pulmonary, does that, in the Saudi, does that mean imply critical care or just pulmonary? So you're not in critical care. Okay. In the U.S. model, a lot of our critical care doctors are pulmonologists. Not everybody, but most of them are, the fellowships and things. And then the nurse. Is the nurse in the room? We have one nurse at the conference I thought was great.
Yeah. We haven't found that nurse yet.
So process elimination means it's the next group. Or they're like, I'm not saying anything, right? That's fair. Okay, so I'm going to start out with, we'll frame a discussion around a scenario, and I'll read this out to you. You're managing a 68-year-old female patient who was transported by ambulance to your emergency department with severe shortness of breath. I have to go with it. The last group I said called 911, and I learned that we have 911 in Saudi too, right? But not everywhere, right? That whole conversation in the last hour about that, I'm like, I said 911, I'm like, oh, maybe it's not 911 here, but it is. Okay, I digress. So she has no significant medical history. So you get called to the room, you get called to the emergency department because of the shortness of breath call from EMS. And so on arrival, you notice that the patient appears just on inspection, right? So we know that a lot of the times, for those of you that have this experience, like in a trauma room, as you're standing at the head of the bed waiting for the patient to enter the room, you can make a lot of assessment as even the patient's getting close to you, right? For example, if the EMS folks are bagging the patient coming in, it tells you a lot of information about the severity of the disease. And I don't think that should be downplayed. It is tremendously important that your general inspection tells you a lot about what's going on, right? So that's not, I think sometimes we think advanced. I'm not sure. I think the ability to interpret what you're seeing is just as advanced as anything else. You note a rapid respiratory rate of 35 breaths per minute. You have accessory muscle use, some nasal flaring, just generally bad breathing, even had a really rough time breathing. Her saturations are 85%. 85% on a non-rebreather, turned up well past 15 liters. You're just sort of, somebody just put it on and went shh and turned it up to that noise that we all know is high, right? And the patient is a bit diaphoretic, cyanotic, just generally not looking well. She is unable to speak in full sentences, and she has this anxious, like appropriately anxious appearance on her face. Now, with all that information, what I want you to do is I want you to tell me what stands out to you here as being not great. What's your impression of the situation?
Asthmatic, stage 4.
Oh, asthmatic. All right. And based on what?
Based on symptoms here.
Okay. Which one?
I have saturation 85, rapid breathing, tachypneic, and unable to speak full sentences.
Okay. All right. Anybody else?
She's respiratory distress.
Respiratory distress for sure. And which of these values or which of these observations stand out particularly for you as making you say this is certainly not a good thing?
Well, cyanosis.
Cyanosis.
Saturation is very high.
Saturation's 85. Saturation on room air of 85 is not great. And then we're going to tie that into 100%, which is, or not 100%, but a non-rebreather, which is even worse. Yeah, and we talked about this the last group. You know, a respiratory rate of 35 is never good, you know, for an adult, unless you're out running a sprint. Then you say, oh, okay, then it's contextual. But at the end of the day, you know, tachypnea, like I told you yesterday while I was on stage, I think its respiratory rate is largely undervalued. And there's a lot of literature to support that. This is not even an opinion. You can go look up, do we undervalue respiratory rate? And you'll see papers that are like named that, right? So there's a lot there because it's hypoxemia. It could be metabolic derangement. There's a lot of things that the respiratory rate itself as a vital sign tells us. I'm on live stream, so I don't want to say this too much, but we do know that there's some literature that would suggest that some clinicians tend to type 18 or 20 or so as a respiratory rate, but they're not really counting them. This is actually published in the peer-reviewed literature. So it's like one of these deals where you go up to the EMR and there's the respiratory rate tab and you go, 18? Not that we've ever done that, right? Of course, we've never done it. I'm just saying this does exist in the literature. But there's some argument here that in reality is at least some having the equal appreciation to the respiratory rate as we do blood pressure and heart rate is where we should be. It's just harder to measure and those type of things. So anything else? Is there any other information you want? Accessory muscle use? Level of consciousness. Let me say that the level of consciousness. Yeah, let me say that the level of consciousness here, because somebody asked me the last group, GCS, so I'm like, I don't know the GCS, but how about that the questions you ask her, she's appropriately answering them in short sentences, but appears that she's aware where she is, what's going on. You're not really surprised by her answers, and perhaps she's even tracking you with her eyes. As you walk around the room, she's following you around. So she has some conscious understanding that you're with her. Right? That's a great one, sir. That's a lot of information right there, right? Because you could argue that this one's going to be like, okay, we can sit back for a minute and not intubate, gather more information, versus the person who's completely unresponsive, where you start gathering the equipment to intubate, right? So look how advanced that is, how quick that was. That one question about mental status, it could be a tremendous amount of information to help make the next decision. What other information would you like? Finally, every group wants the blood gas. Who wants the blood gas right now to make the next decision for this patient? 2.5. 3. Okay, 3. Who doesn't care about breath sounds? Who doesn't care about the blood gas right now? Oh, okay. Some of the room doesn't care so much about it. And you're not wrong. Nobody's wrong or right. Right? So that's why I want the conversation to go. I want the conversation to flow. Breath sounds. Surprisingly, crackles everywhere. You thought expiratory wheezing or even biphasic weaning, but all of a sudden we have a lot of crackles everywhere, and perhaps even on you visualize, she's swollen in the lower extremities, and maybe we'll say maybe a bit of pitting edema. And all of a sudden your mind went whoop, or like, well, we just went down another path, you know. I agree with you. I did kind of build that like an asthmatic, so it's a real good guess, right? Okay, so let's say chest film comes up. So in your ER, you'd magically have a chest x-ray sitting there, right? And we get it, and it has bilateral, this bilateral type image of that would be consistent with pulmonary edema. Okay, let's talk about that blood gas. Now, do you want a blood gas?
If there's an X-ray, there will be a blood gas.
Okay, good question. So before the blood gas, you're trying to ascertain a little bit about the history, or to ask the patient about the history. The patient admits to you, well, what would you ask, sir, if you don't mind? What is your history, or would you ask pointed questions? Oh, I love that, because what does that tell you? That gives you an idea. If she's on heart medication, then we got some idea, what's going on. What kind of medications are you on? Especially if she said, I take a, I don't know, in the U.S., it would be common to hear somebody say, I take a water pill. Water pill meaning a diuretic, creates urine. So like in the U.S., you got to be careful with people using that jargon. Like they'll say things like, I take a water pill, and you're like, what's a water pill, Then you look at Lasix, they're like, oh, I got it. Now I get it, right? Right, good. So let's say that the patient isn't on, maybe she's on levothyroxine, she has a thyroid issue, and past medical history that she admits to is just hypothyroidism. Nothing that, not helpful at this point. But I like that question.
What about her temperature?
39.
We ask if anyone in home has fever or influenza or anything.
Lives alone. Great question.
This is the first time it's happened before for her, this condition.
When you look in the EMR, she's never been admitted in your hospital ever before. In your EMR, doesn't mean in the next hospital. But when she's been to the hospital before, years ago, something unrelated. Now let's move back to that ABG question, because I think this one's a hot topic. And we've been talking about this for the last couple days. Go ahead.
What is the blood pressure of the patient?
Oh, good question. 140 over 90. Let me change it. 160 over 110. A little more consistent with the story I'm trying to tell. Right? Okay. Blood gas. Yay or nay now? Right this minute. Yes? Still yes? Yes? Keith?
No.
Okay, 20 years, or how long you been in RT? 25 years? Why 25 years, Keith, right now you're not caring so much about blood gas?
Well, let me pose the question. So let's say we did do a blood gas on this patient, tachypnic, hypoxemic, diffuse alveolar edema, work of breathing, tachypnic, all these, febrile now we know. And it was 740. And it was, PCO2 was 40. PO2 was 85. Bicarb's 24. Are we not going to treat this patient based on that blood gas?
So if it was 7440, what might it mean to you? Because, well, hold on, but keep in mind.
He's working hard too.
Yeah, the rate.
Increased work.
There's renal compensation is not occurring. That's going to occur. Are you talking about renal compensation?
Not really.
Now let me give you the full picture. 740 40. Let me see. So 85%. So let's do the dissociation curve. PL2's 50. Bicarb's 24.
Maybe in Bayard of gas exchange because of the edema.
Okay. 40. What the point I'm getting to is what he's saying is if I gave you a blood gas of 740, 40, 50, hypoxemic, with a bicarb of 24, you would go, yes, right? That patient still looks terrible, right? As a matter of fact, I would argue that patient should be more like 747 with a CO2 of 32, alkalotic because I'm hypoxemic, and it's not happening, so it goes into that asthmatic type. All of a sudden your blood gas is normal, but you're breathing 35 times a minute. If I ask you to breathe at a relatively normal tidal volume at a rate of 35, and you did that for a minute, what's going to happen? your CO2 is going to go way down. Well, CO2 is not going down with the rate of 35, so what does that mean? There's only one physiologic answer.
Increased fatigue.
It's increased fatigue, it's rapid shallow breathing, it's dead space, right? Using physiology. So again, I think that's your point, right?
Yeah, so my point is that delaying treatment of the patient, this patient needs treatment, regardless of what their blood gas analysis would show. It's either going to be normal, but they're working really hard to keep it normal, or it's going to be abnormal, and they need to be treated. So either way, they need to be treated. There's been a paradigm shift over the last several years, at least in the United States, of treating the patient and not wasting time doing excessive laboratory evaluation before you treat the patient. So if you look at the literature, and you saw Dr. Hess as his lecture, this is the hypertension, the alveolar edema, the chest X-ray, the hypoxemia, all this stuff is classic acute cardiogenic pulmonary edema. What is the standard approach to treating that? Non-invasive ventilation, diuresis.
Right. Yeah, exactly. And go into treatment.
I don't need a blood gas to tell me that that's what this patient needs, right?
Now, if you drew the blood gas and then you treated the patient right after the blood gas, nobody's saying that's the wrong thing to do.
No.
But like, if you drew the blood gas and you sent it to the lab and you're like,
Waiting for the results.
I don't know. Just do me a favor. Don't do me like that.
Yeah.
If I'm ever your patient, you can go ahead and put me on NIV. We'll move on. And I think to the gentleman in the back that so correctly brought out, you have a mental status that's intact, which is very helpful here. Now, if I would have said, she's unresponsive, sir, that's a whole different ball game, right? But her mental status is going to help us with the path forward. But I digress. We're not here to talk about whether or not we draw blood gas, because you may work in hospitals where that's a normal thing to do, and that's fine. And you may work in hospitals like, yeah, I would agree with Keith. We're getting a little more used, for a long time, to be quite honest with you. We've been shifted towards, we'll get the blood gas in a little bit, after we've started.
Blood gas, we may get a venous blood gas, because what we would be concerned, we know she's
the pH,
hypoxemia.
yeah.
What we really want to know is if she's hypercarbic, right? That would be the indication for if she was unresponsive or mental status was decreased. You can easily assess a acid-base status with a VBG. It's commonly done.
So for the sake of time, he correctly, well, we'll see. Do you believe him? Is the pulse oximetry enough here, you think? Are we okay with pulse oximetry? Is it useful in this scenario? The SATs say they're 75. Were you drawing a blood gas for those that were blood gassers to verify the pulse oximetry accuracy? Was that the intent? Was the intent to go, oh, my SaO2 is 85%, so yes, we believe the data? Or were you like, no, I already knew that you're hypoxemic? Then I would question, then what were you looking for? I guess pH, I'm assuming, and CO2. So do we believe the pulse ox in this type of situation? Yeah, why not, right? So why, and somebody said in the last group, unless there's a contraindication, right? And what might those be? What creates pulse oximetry inaccuracies? And that's really what I want to drive home before we shift here. What creates inaccuracies? Yep, like perfusion. In this case, we got a high blood pressure. Movement, artifact, yep. And you can see that on the waveform sometimes. I know the companies have gotten better with artifact mitigation over the years. Pulse oxes were really not good in the beginning, but the companies have worked on their software to...
Maybe she got nail polishes.
Nail polish? Anybody got some nice nail polish on today? We got to be careful. We get hypoxemic, right?
In our countries, the henna, we have special.
But do you cover the nail bed?
Yeah.
Oh, okay. No, I didn't know. So it just covers everything in the hand. Oh, okay.
In case of carbon monoxide toxicity.
Ah, I like it. Right? So back to your question, I guess, sir, when you started kind of digging into where you're coming from, what you've been doing, what happened, where did you get here? If I would have said, actually, there was a house fire, which is the classic respiratory example of carbon monoxide poisoning, right? Then all of a sudden we're like, whoa, we got to be careful with pulse oximetry now, right? Remember when you have those dyshemoglobins, like carboxyhemoglobin, then it will give a falsely high or falsely low pulse ox. Right, it will say, you know, the question is it false? Because I guess the question is SpO2, which is, right. But it's showing that something's attached to the hemoglobin. It just doesn't differentiate in most pulse ox is what it is. Because the affinity for oxygen and hemoglobin is like 200 times more than, or for carbon monoxide and hemoglobin, 200 more times than oxygen, right? And then the other thing we just mentioned yesterday was, you know, more and more conversations about skin tone, okay? Now I will tell you that this is imperfect at this point. The skin tone, certainly observational studies that are showing that there's inaccuracies across skin tones, and this is not a new phenomenon. I know that this is a recent paper that come out that kind of put a focus on it, but it's been described for 20 years. Yeah. So my question is in darker skin tones, what is the likely direction of inaccuracy? Inaccurately which way?
No, it's higher, I think.
Well, inaccurate's inaccurate, high or low, right? So which one is it? So if I have dark skin, am I more at risk for being my inaccurately low or inaccurately high?
Inaccurately high.
It's high.
Yeah.
It's, yes.
Because the light will be fewer.
So it's inaccurately high, which can be negative. Why? Why is that a bad thing? You think you get an A on the test, right? You know, like, oh, I'm 92, not really 88. That must be better. Why does that matter? Because I didn't treat you. Yeah, you're like, nah, you're fine. See you later. And you're like, no, really, I'm not. Right? So it's called occult hypoxemia. And occult hypoxemia is when you have a variant, when you have this variation in this case, in the darker skin, it appears that sometimes the pulse ox might be falsely elevated on the pulse ox. So it is always good for you to compare those. And more research is being done to better understand this and figure this out a lot better in a more scientific way. Some of these studies were observational and they're flawed by design. So there's a lot of studies that are being done to correct this a bit, okay? And I'm doing one of them. I was telling the last group, $13,000 device from US dollars that you put on the skin, it tells you exactly the skin tone. And we're measuring it here. Because you know what, I don't care what the pulse ox doesn't measure here. It measures here, right? So that's what we're trying to understand, okay? So what we're going to do is I'm going to tell you that the doc said,
Intubate.
Intubate. I don't care. The non-invasive ventilation's overrated. Not doing it. High flow, don't like it. We're going to intubate. Now what we're going to do is we're going to intubate this patient right now. All right? Despite the fact that we're like, well, Dr. Hess said what we should do is NIV, and I would agree because that is what the right thing to do is, but it doesn't work for our workshop. So we're going to intubate the patient, and what Mr. Lamb's going to do, my friend Mr. Lamb, is going to walk us through what kind of observation we can make now. Now that we've intubated the patient, you put the patient on the vent, what should we start looking at beyond just writing all the respiratory numbers down? Now we want to get into sort of deep dive a little bit more into some of the finer details. And you got to put this on, by the way. Yes?
Before we side stream, nasal can.
Yeah, of course.
Instead to make a blood gas for.
Yeah, I think you could always put it on there. There's not a whole lot of risk to it unless you were to interpret the numbers wrong. You know, the question is, what are you seeing? You know, that if she's breathing hard, she's probably mouth breathing, so you might want to get something here. It is not a general practice of mine in that scenario to use end-tidal CO2. But in the ER setting, I have used end-tidal on an unintubated or a non-intubated patient when we're sedating them, or I'm concerned about their mental status. But she's conscious. So, but I guess the point is it dangerous? As long as you're interpreting the data right, you should. Go ahead. Sorry.
Oh, no worries. So to just recap here, we have a female patient that comes in, hypoxemic, tachypnic, tachycardic, febrile, chest x-ray shows diffuse alveolar edema, neurostatus is okay. What did I miss?
Intubated.
And we intubate her despite the abundance of evidence that would tell us to at least first trial non-invasive ventilation to avoid the intubation. So they're intubated, and we've done all of our confirmation, et cetera, and I, as the respiratory therapist, want to evaluate her lung mechanics so I can titrate stuff on the ventilator and sort of get a feel for what's going on. Two of the most common mechanics to evaluate are static compliance and airway resistance. So given all the data that we know about this patient, what do you think out of those two parameters right there would be abnormal?
Low compliance.
So if stage 4 asthmatic, resistance would probably be high, right? But somebody who's got diffuse alveolar edema, you're correct, the compliance would be low, right? Good. So what is the definition of compliance? Tidal volume divided by what? Peak inspiratory pressure minus what?
Plat minus peak. That's what they're saying. Plat minus peak. Your brain is on the resistance.
Oh my God. I'm sorry.
Coffee.
I'm sorry. Plateau pressure. Now it looks like I don't know what I'm talking about.
That coffee machine only filled his coffee halfway. Well, I hit mine 2 times. That's why my brain's still working.
Plateau pressure minus PEEP. So the units of measure for compliance are milliliters per centimeter of water pressure, right? Which means that I get, well, we have to measure the compliance first. So what's our plateau pressure in a person that's got diffuse alveolar edema?
So we're going to have you guys build the scenario. If you were building this scenario for your student and you had to create the plateau pressure in this scenario, what do you think it would be? This guy's math is good. 30.
30. Beautiful.
We like that math.
We like 30.
We worked it out. But how elevated, right? Somebody gave us a plateau 29 earlier. We're like, no, that doesn't work. We don't do odd numbers over here.
Yeah.
Americans always do even numbers.
Yeah, easy way out all the time. So plateau pressure, and what PEEP do you start at? What's your typical PEEP? I like 5. Why 5?
3 to 5. But in this case, not 5.
But why 5 usually?
Physiologically.
Just one person. What'd you say? I didn't hear you.
Same answer.
Okay. No, we established through diffuse discussion earlier that there's no such thing. And if you go back and do a literature review, that's sort of an anomaly. The natural PEEP.
Oh, physiological PEEP.
Yeah.
That thing we've all learned about that doesn't really.
Yes.
You know how somebody convinced me it's not real? Because I was taught.
Yep.
Put the endotracheal tube like you open a valve and the lungs collapse or something. I don't know what I was thinking or what I was taught. I'm like, no, there has to be physiologic PEEP. And they're like, well, but your trach patients their lungs don't collapse. And I'm like, they don't.
Mind blown, right?
You're like, what about all those people that walked in smoking all their life? Now they have a laryngectomy. They're shopping and
Not only do they not have collapsed lungs, they have distended lungs, right?
Oh goodness.
So anyway,
take a nap after I was told.
the most dangerous word that can be uttered in science, and in probably anything, but more specifically in science, is because that's what we've always done, right? 5 PEEP. So let's say we put them on 8 PEEP. I don't ever start somebody on 5 PEEP regardless of what their problem is. So 8 PEEP. And so what's the difference between 30 and 8? Is it still 22?
Oh, 6 mLs per.
Yeah, we need to know that. So let's say it's 450.
We'll say 4. Yeah, I appreciate the guy here. He just knew what we were trying to get to at the point. But 450, we'll do 6 mLs per kilogram.
So we take our tidal volume. and we divide it by our delta P, the difference between our plateau pressure and our PEEP. And it's what, 21.5? 20. 21?
21.
Okay.
We're going to round up. Is this good or bad?
Isn't it centimeters? Is the unit correct? Isn't it centimeter of water per
It's
liter
ml.
per second?
It's ml per second.
It's ml per centimeter water pressure.
Change in volume
Or the change in
divided by
pressure.
So ml divided by centimeter of water.
Because the definition of compliance is how many milliliters of volume do I get for every centimeter of water pressure? And we know how many centimeters of water pressure there are because we measured them. And so the difference is so this I get 21 milliliters of volume for every 1 centimeter of water pressure that I deliver to the patient, right? So the question was, is it normal? What is the normal compliance of an intubated patient? 50 or more, probably, right?
Around 50 or so.
Yeah.
60, 50, depends on your source. That's around 50, 60 or 50. But we get less than that, then you have an abnormal amount of change in volume for the unit of pressure. And I'm going to be honest with you, for those of you that are new in your career and this doesn't make a bit of sense, think about how really simple this actually is. Each time you go click up on your pressure, if you're on pressure control on a ventilator, if you really think about what this is, that means you just added 20 more mLs of volume. Click again, and you did it again. Click again, and you did it again. Every time you click 1 centimeter water up, you get a change in that much tidal volume. And I don't know why it took my brain so long to figure that out, but because that's what you're looking at. Like you're looking at 450 divided by 22, and so it just tells you for each one of those units of pressure, you get that much volume. So think, so you now you're on pressure control. You can go click, and it goes boop like that. That's from your compliance. I mean, that eliminates resistance there, but like a dynamic, that it gives you an idea of what this really is.
Yeah, so I don't put a whole lot of stock in this specific number, but I want to use this to sort of trend what happens with the patient afterwards, after they're intubated and after we work our magic with the ventilator. So this is at least less than half of normal static lung compliance. Does that surprise you in this patient?
The look on this face right here tells me there's a question. I'm a professional educator. When somebody looks at me like that, I know what is it.
She doesn't believe me.
You're here to learn,
That's what
right?
That's what it is.
And if somebody doesn't know something, ask it, because we probably all need clarification on it. Go ahead.
What I know is the way we measure resistance is basically by subtracting basically the driving pressure over the flow itself.
Yeah, so we're not talking about resistance.
We're not doing resistance yet.
We're talking about compliance.
Huh? Oh, okay.
Yeah, we're talking about compliance.
He just erased the airway resistance right.
It was there. I'm not trying to trick you. It was there. It just shouldn't be.
It got me concerned because the whole thing.
No, you're right, because resistance is centimeters of water per liter per second, or all that other things.
This is why I was talking.
Yeah, gotcha. So now you're glad you clarified, right?
Yes,
So.
and me too. So, what causes a decrease in compliance? The decrease in compliance for this patient is this diffuse alveolar edema, right? So compliance is decreased whenever there's something that's taken up space. So alveolar edema, anything in the pleural space, even extrinsic influence on the airway pressures, which we haven't talked about, morbid obesity, et cetera, anything that takes up space that's not supposed to be there will decrease your compliance, right? Airway resistance.
Sometimes she's like,
This is-
I've learned.
This is your turn to shine now.
I was like, this is the American way.
Don't be quiet, yeah, right?
The numbers should be the same no matter what changes.
What is airway resistance?
PIP. Is that so?
Peak inspiratory pressure, right?
Yep. Overflow, which implies itself
Minus?
dynamic measure.
Minus what? Plateau pressure?
Yeah.
Divided by flow. So the ventilator will give us all this information, right? We do an inspiratory pause, we get a plateau pressure, we look at the peak pressure at the same time, we subtract those numbers, we know what the flow is. We probably are doing this on a volume assist control with a fixed flow rate. which is the best way to do this and really the only way to do this appropriately. But what does the ventilator give you? What are the units of measure for flow that the ventilator gives you? Liters per minute, right? We need to know what the liters per second is. That's the description of airway resistance. So we always use, but from way back in the day, we used to actually change the flow to 60 because it was easier to calculate that way, right? And so
it creates a more consistent way. Actually, some people would argue this, that, again, I'm not telling you to go back to your hospital and do this. That don't get us in trouble.
yeah,
Some people would even argue
he's in charge. So
some people would, like the one time I did a study, I published a study, I think in 2017, and we had to come up with a protocol of how to assess resistance across a lot of different patients. And every one of them, we did it exactly the same. And we moved everybody's flow to 60, and then we measured the resistance, and we used that value from 60 liters always as the value to know if we had a change in resistance based on our intervention. The intervention was to use like a thing that cleared the inside of an intratracheal tube out.
oh yeah,
Yeah.
remember that.
Yeah.
So if I want to know what the liters per second is, I simply divide the liters per minute by 60, right? And that equals 1 in this case, which makes it more consistent if you do it all the time, and it makes it easier to do the math. So what's our peak inspiratory pressure? 40? Okay, so 40. What's our plateau pressure? 30?
Plateau pressure was 30.
30, right? I don't think our plateau pressure can be higher than our peak pressure. Well, it ain't normal, let's put it that way. Divided by 1, right? So in this case, with these numbers that we got directly off the ventilator, the airway resistance would be 10 divided by 1 equals 10. What's the normal airway resistance for an intubated adult? 10 or less, probably, right? 10 or less. So that's normal. And in this specific case, that's what we would expect, right? If this person's primary pathology is acute pulmonary edema, then we would expect abnormal compliance, abnormally low compliance, and probably a normal-ish airway resistance, unless they did have concomitant asthma, which would be unfortunate for them, but that's double
so you
down.
went from no medical history to 2 diseases all in one scenario.
So that is what, those are the 2 major things.
We got about 5 minutes for this.
Okay. So anybody heard of, is that right?
Yeah.
Anybody heard of driving pressure?
Yes.
And what does it mean? Okay, so driving pressure equals plateau pressure minus PEEP. Whoops. See, I automatically put everybody on A to PEEP, so I don't even. Anyway.
It's this. It didn't work. It's me. My eraser worked better.
Yep. Okay, plateau pressure minus PEEP. Now, since the year 2000, when the ARDSNet trial came out, and everybody started to use lower tidal volume because what happened to people that got lower tidal volumes? More of them lived, right? Versus the control group that was 12 milliliters per kilogram of predicted body weight, and the study group was 6 milliliters per kilogram predicted body weight. So ever since the year 2000, we have sort of focused on tidal volume. And and even our EMR systems are set up to tell us what 6 milliliters per kilogram predicted body weight is, because that has been the standard. Along comes Marcela Amato that wrote a paper a few years ago that retrospectively looked at a bunch of prospective ARDS studies, and he was searching for a variable that specifically was tied to mortality. He was trying to narrow it down, right? So when he looked at tidal volumes and plateau pressures and PEEP levels and everything else, any kind of variable he could consider, he found that driving pressure.
And when Keith said a few years ago, that would be 9 years ago, right? I think it was published in 2015.
That sounds right. Yeah.
And I say this for those of you that are new to healthcare. When we get new information like this, it's pretty significant. It's a slow change. So you're like, I've never heard this. This must be new. It's not. It's about 9 years old. This paper come out. More studies are coming out, but it's a change in healthcare is glacial speed. Sometimes it's pretty slow.
And what he found is that there was a precipitous increase in mortality at about 15 centimeters of water of driving pressure. So we have, there's been a paradigm shift of sorts that instead of, maybe the right thing to do instead of paying so close attention to tidal volume, that we look at driving pressure. And if, as an example, if we have two patients, they're both 5'9" males. If we looked at our handy dandy predicted body weight chart.
So 5'9" is this female or male?
Male.
Male.
Isn't that the?
Oh, I didn't see the thing.
In that
yeah,
male?
I think so.
Okay. Yeah, I don't either. Just for this drawing.
I didn't see it, sorry.
And we have two 5'9" males. They're both sick. They're both intubated. And you do a CT scan on both these patients. And you have the one patient that has about 2/3 of their thorax filled with edema, atelectasis, et cetera, and the other one is 1/3 filled. If I put 424 milliliters in this patient as a tidal volume, and I put 424 milliliters in this patient, which patient is going to experience more stress and strain to the functional alveoli that they have? The left one, right?
The left one correct.
Huh?
You gotta say left one correct.
Oh, correct.
Left one right.
God. Or we got to start putting this one on the right side. But anyway, so correct. So what do we use as a surrogate or an evaluation? So what this tells us is that with Amato's study is that maybe it's not the tidal volume specifically, right? Maybe it's the tidal volume in relationship to the amount of space that's available in the lungs for the tidal volume to go, right? So what do we use, what measurement do we use to evaluate that relationship? It's not enough to just look at the tidal volume because we don't know what the tidal volume, what kind of stress and strain a tidal volume is going to cause to the lungs. We use pressure. Pressure is a surrogate for how much space is available for that tidal volume to be. Does that make sense? So,
Everybody clear on that? So we don't really know what's going on inside the lung, so we're using pressure to tell us what's happening on the inside of the lung. And then we have to extrapolate that in and say, well, that's what you're seeing.
yeah, and so that's where the
Scans can help.
CT scan, ultrasound sometimes, et cetera, et cetera. But what we use at the bedside with the ventilator is driving pressure. So if the driving pressure is high, that means that our volume is too big for the space that's available in the lung, even if it's 6 milliliters per kilogram.
For those of you that like to read peer-reviewed literature, I think it was in 2011, Luciano Gattinoni published a paper that described a concept called the baby lung. And it was a baby lung concept in adults, meaning that it basically describes the functional lung units in an adult patient with ARDS. So on an x-ray, the lung looks total whiteout. You know, everybody's seen the lungs where you go, even if you're not good at x-rays, you go, whoa, That's bad. The whole lungs like that. But if you look at a CT, it's like more like that. It's the dorsal lung side, right? It's these gravity-dependent dorsal lung units. They're all collapsed. These ventral lung units, not only are they not collapsed, they're over-distending.
They're being injured, right?
They're over-distending. They're like, because you're taking that same 6 mLs and you're cramming it into a smaller functional lung every time. That make sense?
Because guess what? People don't, these patients, they don't die of hypoxemia. If you look at the data, if you do a really good dive in the data, there is about a 40% mortality rate in ARDS with moderate to severe ARDS, no matter where you're at. If you're in Riyadh, or if you're in Chicago, if you're in Charlottesville, doesn't matter. About 40%. Only 1 out of 10 of that 40% actually die from hypoxemic respiratory failure. The 90%, the other 90% that don't survive, die from multi-system organ failure that's caused by this lung injury, and that is serious, right? That is, you have some control over 90% of the people that don't survive ARDS. So this is a monitoring overview, right? So what I'm asking you to do is to monitor that driving pressure, and if you see that driving pressure is high, then do something about it. And what are those things that you can do about it? What's the first easy, simple thing you can do?
Reducing tidal volume.
Reduce the tidal volume. Boom. That's the first thing you can do. Immediately drops the driving pressure.
Today, nowadays, talking more about the mechanical power.
Yes. It's all tied in, though, right?
Yes.
So mechanical power. Can we get another hour or so? Or?
Yeah, we're going to just go off. Yeah, we got to give him some time.
Yeah. Mechanical power is just the energy applied to the lungs, right? That's what it is. And even if you don't know what the calculation is, you should know what the components of that calculation are, and that's anything that increases energy, increased tidal volumes, increased respiratory rate, driving pressure, all that stuff, right? More energy. So
decreased tidal volume. What else?
Increase PEEP.
So you increase PEEP, and then what could you do? What can everybody in this room talk to the team about to make that look nicer? If this were like ARDS, if it's non-cardiogenic pulmonary edema, you take them and you go like this. Boom. That's what proning does. It takes this lung unit, it flips it over and takes gravity off of it, right? Heart comes forward, fluid shifts, that pressure on those lung units, they start opening. You take that same tidal volume and you redistribute it across the lungs, and guess what you quit doing? Injuring the lungs. And Keith said this so nicely before. We think about prone positioning a lot to improve oxygenation.
Like this.
I view, personally,
Thank you, sir.
prone positioning as a lung protective strategy. It protects the lungs too, because it opens them back up. You redistribute your tidal volume across the lungs. And it lets you turn your FiO2 down, and all the mechanics change.
I'm old, so I forget things. Forget what I was going to say. But yeah, so my point was going to be that hypoxemia isn't necessarily the thing that you should target. There's studies out that look at target PO2s of 60 versus 90. No difference in outcomes in those two groups, et cetera, et cetera. It's not even the control group of the ARSNet study that's 24 years old now. That control group had higher PO2s, despite the fact that more patients in that group died, right? So you cannot associate an improvement in PO2 with outcomes.
Everybody get that point? In ARDSNet, the big tidal volume group looked better.
But still died more often.
But died more often.
Yeah.
They looked better for about, what is it, Keith? I think that one graph shows about 3 or 4 days.
Yeah, about 72
and then
hours.
It goes like this.
Yeah.
The bad group went better, and the good group went worse because the lung injuries were very. That is really eye-opening because you can't just measure easily
very important.
ventilator-induced lung injury.
This concept is very another good example. So that to Dr. Scott's point, flipping somebody on their abdomen, yeah, their PO2 about 80% of the time their PO2 is going to go up, but that's not what improves mortality. What improves mortality is the redistribution of transpulmonary pressure and stress and strain on the lungs.
Okay, thank you, Mr. Keith. I know he took
a bit of more time to explain this concept, but it's really very important to understand this concept in terms of lung protective strategy. So anyways, in this part, I will try to give some emphasis on how to apply what we have learned from Mr. Keith here on while we are assessing our patient under mechanical ventilation on a daily basis, okay? But before that, I would like to give a brief overview of waveform graphics, okay? So let's start with, what do you think, how many types of ventilator graphics do we have? How many types?
Scalar and loops.
Yes, exactly, excellent. So we have loops and we have scalars, okay? So we are not going to talk about loops today, but we need to focus a little bit on the basic shape of the scalars. So what does it mean? What is the meaning of scalar? Okay, so scalar is a graphical representation of plotting one variable versus time. So if we plot, for example, pressure versus time, we get pressure times scalar, okay? So in mechanical ventilator, we have three types of scalars. We have pressure times scalars, flow times scalars, and volume times scalars, okay? So please notice, let me freeze the waveform. Please notice only the flow time scalar goes below the baseline and the expiratory part, okay? So you need to know the normal graphical representation of each scalar in order to identify any abnormalities or distortion of the waveform, okay? So now let's talk about the basic shapes of waveform. In waveform language, we have only 3 types of shapes. But when you check the textbook, you will see exponential decay, descending ramp, whatever. So we can all categorize them into 3 main types. What is this shape? Square, exactly. So what does square mean? I mean, if you see square waveform, okay, good, excellent. So it means I need you to memorize this key concepts. So square waveform, it means number 1 is controlled. Controlled by whom? By the ventilator. So number 1, it is controlled by the ventilator and it is constant throughout the inspiratory phase. Okay, so this is 2 key concepts. Square waveform means it is number 1, constant throughout the inspiratory phase. Number 2, it is controlled by the ventilator. Okay, now the second shape. What do you think? What is this shape?
Descending.
Descending. Okay, I like what you said, descending, because this is descending or decelerating ramp. So all type of ramp you will see, we will put them fall under the ramp. So all ramp have the same characteristics. Number 1, ramp means it is variable. Okay, what is the meaning of variable? It means that the ventilator does not control this parameter. Okay, and number 2, since it's variable, it will be changed or affected by lung mechanics plus patient effort. Okay, so for square waveform, constant, controlled by the ventilator. Any type of ramp is variable and affected by lung mechanics and patient effort. Okay? Okay, so in which mode we have constant or controlled pressure and ramp or variable flow? Pressure modes, right? So what is the name of this mode? Adaptive pressure ventilation. Do you know this mode? What is this? Is basically PRVC. Okay, so what do you think by waveform language? PRVC, is it a pressure mode or volume mode? Pressure mode, despite we are setting, Yeah, but the ventilator actually regulating the pressure to achieve measured volume. Okay, so you are setting this volume, but the ventilator actually controlling the pressure to reach this volume. Okay, so let's check another mode. Okay, now let's check this one. Okay. Let me freeze the waveform for you. Okay. Now, let's check the pressure time curve. What is the shape of this curve? Ramp. So any type, they call it a shark fin. Any type of ramp, it means it is variable. Number two, it is affected by patient effort and lung mechanics. Okay. So now check the flow time curve, please. It is square. It means controlled, constant through the inspiratory phase. Okay, so controlled by the ventilator. In which mode we have a variable pressure, but the ventilator controls the flow and volume. Volume control, exactly. So basically in waveform language, we have only two types of modes, either pressure modes or pressure breath modes and volume breath modes. Okay, so this is the most important or the basic concepts of waveform here. اوكي الله يعطيك العافيه لان انا ما في وقت اصلا ما تكلمت ابدا يعني يلا يعطيكم العافيه زين I will try to wrap it up very quickly. We would like to apply what we have learned here with Mr. Keith into on the ventilator. Okay, so now let us measure the static compliance. How would you calculate the static compliance on the ventilator? I cannot hear you. Okay, how would you add the plateau or measure the plateau? Yes, you go and just apply manual inspiratory hold. Okay, so as you see here, this is a cross-sectional representation of each parameters, and you can see the measured values here. So at this point, you have plateau pressure of 22. The flow is, why the flow is 0? Because you applied inspiratory hold, okay? And the volume is 254. Now you can calculate the static compliance. What is the static compliance? Change in volume divided by change in pressure. So this volume, 250 plus, will be divided on plateau minus PEEP, okay? So now, how many minutes do I have? Okay, so thank you very much. I hope you enjoyed this session. Actually, this is very important concept. I know I have no time with my part, but this is really very important concept. If you get from here with this message, I think this is a lot of or a great value. Thank you very much. No, it's okay. It's okay. الله يعافيكم يا رب إن شاء الله. شكرا جزيلا يعطيك العافية حبيبي. موفقين إن شاء الله. شكرا لك.
More than 20 seconds. Once the patient reaches 15 seconds, thank you very much. Stop exhalation and start maximal inspiration. 15 seconds. What if there is no plateau and the patient is not able to reach 15 seconds? What shall we do? Huh? Ask the patient to leave. You did not meet the criteria, not plateau or we move to the third one. Exhalation time is within the repeatability tolerance. What does that mean? Patient is exhaling for 5 seconds and stop. He said, I cannot do more than this. Repeat it again. It's the same. Repeat it again. This is the repeatability tolerance. This is what can the patient do. So I need to accept that one. This is rarely, but it happens. So if this is the capacity of the patient, I need to accept it. So end of forced expiration criteria are 3. Okay? The golden standard what? The golden criteria? Plateau. Second, 15 seconds. Third, within the repeatability tolerance. Okay, I have acceptable trial. I need to get 3 acceptable trials from the patient. Once I have 3 acceptable trials, I need to apply the repeatability criteria. What is the repeatability criteria? The difference between the largest force vital capacity and the second largest force vital capacity is less than 150 mil. And the difference between the largest FFE1 and the second largest FFE1 is less than 150 mil. If we have 3 acceptable, 2 repeatable, test is done successfully. I did a great job. Okay, clear? Very simple. Sunday you grab any patient and said, please do spirometry. I need to get 3 acceptable criteria, 2 repeatable. Can we just, can you get the old result? حقت سلة ولا ما يخزنها؟
We'll do it again so they can.
So حصة thankfully she is doing spirometry for us. Now we will once you perform spirometry, you need to inspect 2 graphs. The first graph is called flow volume loop, and the second graph is called volume time spirogram or volume time curve. I need to inspect both of these graphs to check the acceptability criteria, and for the interpretation, when Doug talk about it, he will elaborate on these 2 graphs. Well done. Thank you very much, Hassa. Please. Now is much better than. So let's start with the flow volume loop. It's a flow versus volume. This is why it's called flow volume loop. So patient has to start. What is the instruction for spirometry? Yes, 5 minutes. What's the instruction? Maximal inspiration. This is the maximal inspiration. See, until it reaches the total lung capacity. Here is the total lung capacity, and here is the residual volume. Between the total lung capacity and residual volume is the vital capacity. So the test starts from the total lung capacity. Patient has to forcefully exhale, blast it. The flow rate, it will reach the peak within the 10th of the second. If the peak is displaced to the right, this is not acceptable. This is a weak effort. So the peak has to be, you have to see it near the line. Then the flow rate, once it reaches the peak, it starts to decreases linearly in healthy subject. Linearly in healthy subject as the volume decreases. So the flow rate is decreasing until it reach 0. That means no air getting out of the lung. At this point, you need to instruct the patient to take maximal inspiration from residual volume to total lung capacity again to close the loop. Great. Done. This is the volume time spirogram. Two things you can get from the volume time spirogram. Start of the test, you remember that? This is one of the acceptability criteria. And start of the test, there should be sharp vertical raise and smooth bending. The second one, completeness of the test. I can see here the plateau, see? Plateau. How many, mashallah, 8.5 seconds. يعني حصة was able to exhale for 8.5 seconds and there's a clear plateau. That means there is no air getting out of the lung. I'm sure 100% all the volume in the lung or all the vital capacity has been exhaled out. So here is completeness. I need to inspect this one. Start of the test and completeness of the test. And here is the time. This is the FFE1, FFE2, FFE3, FFE10. I can't get from here. What is the vital capacity? Here. What is the vital capacity from this graph?
8 seconds for you.
Huh? 3. You can see it here. Vital capacity is here. Clear? Any question? Spirometry is easy, simple. Repeat it for me again in half a second. Done. Half a second, finish. خلاص. 1 minute. The instruction.
The instruction.
Give me the first part.
I will take a normal breath. Then.
Normal breath, forget it. Normal breath, I'm just preparing the patient to start the test. Sometimes you don't need, usually we ask the patient tidal breathing, then we ask to take maximal
Exhale.
Forceful exhalation. Then complete exhalation. Forceful, it's the same. It is one criteria, but I'm trying to make it easy. Forceful, then complete. If I finish the forceful part, I start in pushing the patient to go, and this is sometimes it takes 8 minutes with hissa. So 8 minutes, keep going. You need to repeat that for 8 seconds. Keep going until I see a plateau. Thank you, Hissa. Take a maximal inspiration to close the loop. Then I apply the 3 acceptability criteria and I apply the repeatability criteria. I'm done. Thank you.
Don't forget to exchange your microphone.
I have 2 microphones. I have 2 microphones. Take this one.
Yeah, you need both.
I think you need both.
You need both since they're live streaming.
Really?
Yes.
Take this one.
Okay, Bismillah ar-Rahman ar-Rahim. I'm Hissa, I'm a respiratory therapist supervisor, pulmonary function in National Guard Hospital. Welcome everybody. I just want to give you a very small and short presentation about the technique of doing pulmonary function test, especially lung volume. And I just want you guys to know that the PFT test is a very valuable tool that we can use in treatment and also for diagnosis of the patient respiratory diseases. and we have to instruct the patient, and we have to prepare the patient before the test, during the test, and if the patient needs anything to understand before he's doing the test, we have to let them know all the information that they needed. You have to instruct the patient very, very well. You have to encourage the patient. As we always say, we have to be very mean. You have to be almost shouting to the patient, so the patient understands that they have to give their maximum effort. طيب. So lung volume, we usually do lung volume if we did a spirometry and we still need further information. For example, we want to confirm restriction, we will do lung volume. Okay? Before know how to do lung volumes, we can do lung volumes in 3 ways. Before that, I want you guys to know about the difference between volumes and capacities. The volumes that we have essential volume, which is the tidal volume that we are doing every time, and we have the inspired reserved volume and the expired reserved volume, and we have finally the residual volume. Okay, the residual volume is the volume that remain in the lung after maximum exhalation, and you cannot get it out. Okay, and we have also the capacities, which is 2 or more of the essential or the volume that we have, such as vital capacity, which is the tidal volume with the inspired and expired reserved volume. That's your vital capacity, which is measured by the spirometry. And also we have another capacity, which is the total lung capacity, that we are trying to measure it in the lung volumes in the different ways that we will use. Okay, so the total lung capacity is all the air that you can exhale, actually inhale deeply at the maximum. This is your total lung capacity. Okay, all the air. So, going back to the lung volume, the 3 ways that we can measure the lung volume. The first one is the body plasmography, which we call it usually the body box. Also, we have the nitrogen washout and the helium dilution. Body box, we can put the patient inside the box to measure functional residual capacity by measuring the intrathoracic gas volume that's inside your lung by Boyle law, as we know all, that the volume that we want to measure it, we have another volume, which is the tight pressure cabinet that we put the patient inside. We call it body box. And we put the patient measuring their volume by the different pressure that we have and the constant temperature. We measure the volume that we want, which is the volume inside the lung. The common error for this test is the leak, and also breathing against the shutter. Sometimes the patient stop breathing against the shutter, but you want the patient to breathe against the shutter, so it will be zero flow. We can measure the volume. We usually try to get 3 acceptable tests, and it has to be 5% from each other. And also the body box technique is easy to do, and there is no waiting between the trial, so it's easier than the other techniques. And also it can measure all the patient status, like if the patient have obstruction, it doesn't matter if the patient have severe obstruction, because the other technique, if the patient have severe obstruction, it will underestimate their lung volume, because it's just measuring the ventilated area, the other techniques. But this technique, we usually do it in the lab for all patients. Okay. The next test is the nitrogen washout. What are we going to do? We are going to wash out the nitrogen. You are breathing air, and the air is 79% of it is nitrogen. So the nitrogen will keep your alveoli open, صح? You don't want to wash out all the nitrogen. You will keep such like 1 to 2% of nitrogen inside the lung to keep the alveoli open. So you will wash it with pure oxygen, 100% of oxygen, and you will do the test, which is the largest, the FRC, the largest volume of nitrogen being washed out. Waiting between each trial, it will be around 15 minutes. So that's take a lot of time. Usually in the lab we do one trial and that's it. Okay. So the mean value between the trial, for the acceptability, it will be 10% from each other. The technique will be open circuit. So the patient will breathe the air, and the air that they take it go out and take a new one. We are washing the lung from the nitrogen. Okay, I'm very fast, so I can show you on the ProLab machine the test how it's work. The helium dilution, let's also calculate the lung volume, which is FRC, by breathing the air in the closed circuit. We have like a mixture of 10% of helium. We are rebreathing this mixture to achieve the equilibration between the machine and the lung. So when it's calculated, they will stop the test when 0.02 change in the helium for the 30 seconds, the last 30 seconds. Okay, if there is no change, we stop the test. Usually it will take around like 3 to 4, maximum 5 minutes to be equilibrate. Usually the helium dilution technique is underestimating the lung volume for the COPD patient, because as I told you, if it's severe obstruction, it will underestimate the lung volume, so it will be because of the poorly ventilated airspace. It has to be waiting between the trial 5 minutes, and the acceptable criteria, it will be within 10% from each other. Okay, we'll go back for this one. Diffusion capacity is the third test that you can do, and you do this test to see how well your lung can diffuse the oxygen. So you are using the carbon monoxide to mimic the oxygen and measure how well your lung can do the gas exchange. So the oxygen, when it's go from the alveolar to the pulmonary capillaries, it has to be measured how well. If there is anything that prevent this oxygen to go through, it will show in this test. This test usually, there is different techniques that the test can be done by. So usually, always, most of the time, we do the single breath technique. The other technique, because single breath, it's we call it a holding breath technique. So you have to hold the breath for 10 seconds. I will show you how to do this. And other technique for patients who cannot hold their breath, we have intra-breath, we have rebreathing, we have the multiple. It's used for patient who's doing the test while exercising, or patient who cannot hold their breath, or for study purposes. Okay. Diffusion capacity can be interpreted with other tests. You cannot see the diffusion and say, oh, this patient having obstruction or restriction. No, you have to see the other test results. Okay, for that one, the maximum voluntary ventilation, we always do it for a patient. We can measure the FEV1. We multiply FEV1 by 40, supposed to be 35, but we just do it 40 because it's easy for calculation to get the maximum voluntary ventilation if the patient cannot do it. The tests have some limitation. It's like kind of difficult to be repeated. Patient may like cough or get dizzy or get tired from the test. Sometimes they do it this time, then you do it the second time, the patient do it like totally different. So this is why we don't use it much in the lab. Okay. So it's like just deep breathing. I will show you just deep breathing, continuous deep breathing, tidal volume. Then for 12 seconds, then you stop the test. Okay. This is some information about the lung volume. I just want to show you here, guys, how do we do those tests. As I told you, it's very important to coach the patient, instruct the patient how to do the test, and you have to be very, very, very mean and tell them how to do the test, exactly what it should, otherwise there is no benefit from this test. Okay, so I'm gonna show you first the maximum voluntary ventilation. Since we are not connecting the gases, we don't need gases for the maximum voluntary ventilation. This one, you can see, guys, here. So I'm gonna do the test myself. How many minutes? Good?
10 minutes.
Okay. So we'll have our time here. So we'll start the test as I told you. So now when the patient do this test, you will ask the patient, keep going, tidal breathing, keep going until the test finish. And that's it for the maximum voluntary ventilation. Okay, and the other test, we have to connect the gases, supposed to have gases, but for example, this is for helium dilution, and it will be done like this. Since we put the filter of, or we call it parrot here, filter of diffusion capacity, this one. You can see this one. And the other one for lung volume is this one. We'll show you later. Okay. So I will just wait for the gas flushing, its diffusion capacity. So you will ask the patient to breathe normally, then exhale. Why we ask the patient to exhale? Because I don't want the patient to take the sample while he's inhaling. So we want him to exhale. While exhaling, I will open the shutter to give the sample. Then I'll ask him to take a deep breath, deep, until now exhaling all the way out. Keep going. Then I'll give the sample and ask the patient after that to take a deep breath, deep. More, I want at least 85% to 90% of their vital capacity. طيب. Then I'll ask them to hold their breath, hold it. Here, you will hold it, then exhale all the way out. When to stop exhalation? When you see this line, the green line, that means this sample is come back to the machine again. The sample you gave at the beginning. Okay, you give the sample here, you ask the patient, breathe normally, exhale, then open the shutter. If you open the shutter and the patient inhaled before, that means the patient is inhaling against closed shutter. This is the Valsalva maneuver. Okay, so you don't want this. Again, we'll show you since we have time. We will ask the patient to breathe normally. Just preparing now. Normal breathing. We'll ask the patient tidal breathing. Then I'll ask the patient to exhale all the way, fully exhalation, so I can open the shutter while the patient exhaling, not inhaling. He's exhaling, I can open the shutter. Yalla, take deep breath. Hold it for at least 10 seconds. Then I'll ask the patient to exhale all the way out. Okay, this is the total, the diffusion capacity test. Okay. The other test I can show you here from the lung volume, I can put this parrot, which is a filter. In the lab, you don't have different filters. You have the regular filter for the lab. This is just for this machine. So I'm gonna just put this in here. You can see. Then stick it again. We will do the multiple breath washouts. What we are doing in this test, we are measuring the functional residual capacity through washing the nitrogen washout. So I'm gonna just see here. First of all, the machine will let the patient breathe normally, and there is no oxygen given to the patient for the first tidal volume until the patient is stable. Patient is stable breath, then it will switch to the oxygen. Then it will switch to the oxygen, you can see it. When it's switched to the oxygen, you will see the nitrogen concentration on this side. Okay, so now waiting for the tidal volume, breathing stabilization. The patient is stable, the machine switching to the nitrogen washout, and you will start to see it here, the green column here. So you will start to see what? The decrease in nitrogen washout, decreasing, decreasing, decreasing. If you see a bump up or increase, again, that means there is a leak. Okay? So you will see we are waiting for the nitrogen concentration. While this, you will ask the patient, just keep going, breathe normally, breathe normally, breathe normally, until you finish. Usually, for the nitrogen washout, it will be washed out in 5 minutes. More than this, 7 minutes, if you reach the 7 minutes, you have to stop the test. Okay? Usually, it will be done in 5 minutes, and try to stop before 1% concentration of nitrogen, better to prevent alveolar collapse. Okay, so you can see it, how it's going down. This will be inside the patient mouth.
This is only managed breathing. Is nose clipped or without?
What?
Is nose clipped or without it?
It's better, but if you want, some patients, they don't like the nose clip, you can hold it. Yeah, you can hold it. They can hold it, but nose clip is better. And also, we prefer on those tests, especially helium dilution and the nitrogen washout, to use the flanked mouthpieces. So it will prevent the leak, especially for patients who cannot, it's long time. So you can see it here, and this is the result. Okay. So this is most of it. And if you guys have any question about lung volume, you can ask. If you have any question about lung volume or other tests. You have question? Okay, so we're done here. Let Dr. Douglas continue. Too much.
Okay, now that we have done the testing, now we can move to the interpretation of the data. Remember, I said the word interpretation. I did not say diagnosis. We're not going to use this information just by itself to diagnose a patient. We're going to use it to confirm with all the other medical information we have on the patient to get that diagnosis of the patient. Make sense? So when we look through here, we have to look at our spirometry, which is what we consider our direct spirometry, which is what Dr. Hodges was going through as he blew out so hard. Did you see the wall move? The wall was over there vibrating. And so we're able to collect that data from that vital capacity because of that volume. So when we look at FVC, forced vital capacity is the best predictor of obstructive or restrictive disease. What's that? Restrictive. It's the best predictor of restrictive disease. The forced vital capacity is the best predictor of restrictive disease. So when we look at that, we want to see, based upon their information, as Hessa was talking about collecting, we know that based upon that patient's information, that is their normal predicted. That's what they should be able to do. But this is what they were able to produce from the therapist getting that information from them, and this is what is collected, and that is 85%. Is that good or bad? Anybody know?
I think good.
It is. You think good, you thought right. So it is good. So usually we're looking somewhere around 80% and above is where we're trying to say, is that again going to be able to meet the criteria? It's a good rule of thumb. So we're going to say that this is normal. So that means that we most likely do not have a what? Restrictive disease. Most likely. We're going to have to confirm a little bit later. So now we move on to FEV1. If FVC is the best predictor of restrictive, FEV1 is the best predictor of obstructive. That's right. So same thing. Here's what the patient should be able to do. This is what they actually did. Now 61. Good or bad?
Bad.
Bad. It is now low. And so since it is lower than what we're thinking it should be, we're thinking somewhere in that 80% or above, we're going to say that this is an obstruction. So now we have a normal and an obstruction. So most likely it's probably an obstruction. But we need to look at the FEV1 FVC. And all that is a mathematical calculation. Also known as the FEV1 ratio or the FEV1 percent. So here is what the patient should do because it's just calculated based upon this. But this is what they actually did. Is that number above or below that number?
Below.
It's below. So if it is below, that means it is obstructive, right? So when we go through in here and we look, how many O's do we have?
2.
How many R's do we have?
No.
So we're confirming that the patient has an obstructive disease, all right? And we can see that clearly on that piece. Here's again another interesting piece, and I'm going to give it to you because you guys are just the last group. Look at this over here, post-bronchodilator. So the patient was given albuterol, waited, redid the test. This is what they found, and now the change is plus 4%. Good or bad? Should be what? Should be over 12%. So now we're saying that this patient has an obstructive disease, but their bronchodilator doesn't help, right? But we need to confirm all of that information. So let's move on to confirm the direct spirometry. The indirect spirometry is the what? The lung volumes. The indirect spirometry. That's again what Hessa was talking about. We can't directly measure it. We're indirectly measuring it because we're looking at the physiology of the lung. So let me erase. And let's move and take a look at the lung volumes. So as we look at the lung volume for this patient, their TLC is, as we said, normal. This is what they did. Good or bad? Good or bad? Good.
Good, same.
Yeah, it's good. It's 100%. So it's good. So we're going to say that it's normal. The vital capacity we saw earlier was normal. Same again, normal. The RV is good or bad?
It's good.
It's okay. It's okay, but it's pushing up above. So it's rising, correct? It's rising. Remember what residual volume is. Residual volume is the volume what? that you cannot exhale. So as Dr. Hodges was pushing out all of that air and making that wall vibrate, when he couldn't blow anymore, he reached that very end, and what any of that air left in his lung, that's residual volume, because he couldn't blow anymore. The only way you can get rid of all your residual volume is what?
Yeah.
You're no longer here, right? So that person has about 120%. And so since it's pushing upwards, probably it's okay, but it is pushing upwards, and when you start seeing the lung volumes go up, then that tells you that is on that obstructive side. Does that make sense? So same thing that we see with our RV-TLC percent. Again, same thing what we saw earlier with the FEV1, FVC. It's just a simple mathematical calculation. So what else do we need to go look at? What other test did HESA do for us? What's that? So now we can go on to look at our tests of diffusion capacity. So we know we have this person who has an obstructive process. Now, our single breath DLCO, normal, this is what's found, 87%, good or bad? Good. It's acceptable. It's normal. So that tells us what? What does that tell us about the lungs? Yeah, there's no diffusion defect, which means that if that number was low, we would have an alveolar capillary membrane issue. That defect would be there. But this person does not. So this person has an obstruction, but no problem oxygenating. Make sense? Let's look at what Dr. Hajid was talking about just earlier when we first began. Take a look at the loop. So remember, and he was telling you, look, how'd that come up here? I don't know how that closes. Anybody know how to get rid of this thing? There we go, thank you. So look what we have here. See this dotted line? That is the expiratory. That's again, he was blowing that out. That's what we're measuring here. And then he was talking about that big deep breath in. Now the loop that's here, does it look anything like what it should be? Doesn't look like anything what it should be. It actually is pretty flat here on expiration and pretty flat on inspiration. Kind of looking like a little oval. If you remember the talk yesterday, what's our problem? What's that? It is obstruction. What kind of an obstruction? A fixed obstruction. So now we have something in the airway that's not moving, and it's again having a problem in terms of inspiration and expiration, and we can confirm it here. Now, if you also want to look, you can see the little dotted lines here. You can see it got a little bit better, but not much better when we gave the bronchodilator. Make sense? Is that helpful? Let's look at another case. All right, same thing we have. Patient's information, all input into the computer. The computer tells FVC this is what the normal is. FVC is the best predictor of obstructive or restrictive. Restrictive disease. So here's what they're able to do. 68%. What does that tell us? Good or bad? That is bad. That is low. So that means restrictive. So we're going to put an R there. Now let's look at the FEV1. Normal. This is what they were able to do. 56%. Good or bad? Bad. So that's down. So we're going to put an O there because we're saying that we're confirming that lower amount is an obstructive process, right? Here's our confirmer. This is going to tell us, is it leaning towards obstruction or is it leaning towards restriction? So we look at the FEV1. That's what they should be doing, but they do this. Below or above that 74? Below, which means that if it's going down, it should be? How many O's do we have? How many R's do we have? What's the problem? Obstructive or restrictive? It's obstructive. But remember, vital capacity, that residual volume. When residual volume goes up, then you might have some issues with vital capacity. Or that's not the case, and there's just another restrictive process along with an obstructive process. So we need to see if that's true or not. How do we know whether it's true or not? We go get a what? Lung volumes, that's right. So let's go look at the lung volumes. We have to do the lung volume test to help confirm. Remember the lung volume, this is direct. We're going to look at the indirect, again, all the air that we can't see coming out into the pneumotac. So here, TLC, normal found, obstructive or restrictive, because now it's lowered. What's our problem? Obstruction or restriction? What's that? Nope.
Less than 85.
So since it's going down, that tells us we have a restriction. Make sense? Now we come over here and we look at the RV. The RV is, it's lower but still normal, pretty close to normal, if you will. It's really in that normal range. So we probably don't have any excessive amount of residual volume, again, shortening our vital capacity. So that tells us that we now have an obstruction and a restriction. So that's called a mixed disorder. Does that make sense? So we're able to find these two different issues because we ran both tests. Remember, if you only did the spirometry, you would only need to know, you'd only get the one information, which was obstruction. Without this, you wouldn't know that they had the other part. That's why it's vital that you do both. Now, what's the third test that we take a look at? So if we look at the diffusion capacity, now this is interesting, we talked about that yesterday. We have the normal single breath, but because of hemoglobin being so important, we're able to enter that because we have that information for the patient. We're able to correct that patient based upon their hemoglobin. So we're able to get a much more real or true value from what they actually have. So here, take a look at what they've measured, 58%, 63%. They're both what? Low. Which means, since they're both low, it's not restrict. Remember, DLCO does not tell you about obstruction or restriction. It tells you about the integrity of the AC membrane. What's wrong? Do they have a problem with their AC membrane? They cannot diffuse gas. What's one of the most common disorders that we see in respiratory failure that cannot diffuse gas? What's that? That's a good one. What's another one? Goes along with COPD. Emphysema, not infection. Although it could. Emphysema. So look, because remember, if we had an infection, if we had fluid in the lungs, that could lead towards a restriction, which we saw, right? So now we've got both. So now we think about what's going on with the patient. If we had more data, if I gave you more data, it may be a little easier to figure out. But for this patient, they probably got some COPD issue, which is affecting not only the ability to transfer the gas, but because of the COPD, they have the obstructive part, but they also have some CHF, some cardiac issues. So with those cardiac issues, remember, COPD and CHF seem to go together like peanut butter and jelly. That you see them very, very commonly together as comorbidities. Here, that's what we see. Because of the blood flow coming from the heart, not able to get out, comes back flows into the lung, creating fluid in the lung, which creates the restriction. Does that make sense? That's where we're ending for the day. Questions, comments, happy thoughts from the panel?
Could we do this, all of it, for an ICU patient?
Could you do that for an ICU? You could if if you can get the machine to be portable and roll to them. The key would be, are they conscious enough to be able to do all of the instruction? I would probably tell you majority of ICU patients, probably not. My thing would be extubate them. But the other important thing would be, why do you want to know what they're doing as they're intubated? Let's take care of the intubation and we can worry about, the interpretation of what's long-term going on with their lung. This is more of a pre-test, something that we're going to be doing over time. If you have a disease process we want to monitor, it's not necessarily acute. When you have someone who's acutely in the hospital, they're sick already. They can't do these tests very well. It can be very difficult. No other questions?
Clear, thank you very much.
All right, thank you all very much.
The exam, the test.
هذا